Myself, Dr. Abhishek Patel, medicine residents.
We welcome you all on the behalf of Department of Internal Medicine, Jupiter Hospital, Thane, for today's CMA on infectious disease.
Some few general instructions for everyone. We request everyone to keep their mobile phones on silent mode. The registration desk is set outside of the hall, and the certificates for the same will be issued at the end of the event. We request all speakers to please adhere to the time frame given to them. The questions will be taken at the end of the sessions over the IL mic.
भाई अभिषेक तू बाहर अपना फ़ोन पे क्या बिजी था?
हाँ यार वो थोड़ा क्रिप्टोकोकस अपना क्रिप्टो करेंसी के ट्रेंड्स देख रहा था.
भाई क्रिप्टो करेंसी छोड़. We as a medico should know about cryptococcus rather than cryptocurrency.
So to enlighten us about Cryptococcus, a cryptic disease, we would like to invite Dr. Ayesha Sunawalla ma'am, consultant infectious diseases at PD Hinduja Hospital and visiting consultant at Breach Candy Hospital and Jaslok Hospital. Over to you, ma'am.
Thank you. Thank you for that kind introduction, and it's an honor to be here this morning. Special thanks to Dr. Kanishka for inviting me here. And so to begin this talk on this cryptic disease, I'm going to take a leaf from Dr. Kanishka's book and pose a cryptic question to you all. So what is the association between this beautiful picture here and Cryptococcus? Any takers? Okay, we'll come to it in the course of this talk. So Cryptococcus, the name is derived from the Greek word, the hidden sphere. And as you can see so beautifully in this picture over here, these are pathogenic round to ovoid encapsulated yeasts, which produce a wide array of clinical manifestations ranging from asymptomatic to cutaneous, pulmonary, CNS, and disseminated forms. There are two main species of Cryptococcus. Cryptococcus neoformans, which accounts for 95% of cases across the world, and the less common Gattii. Of course, there are multiple variants and subspecies and strains, but for the purpose of this clinical discussion, we're going to stick to this. There are very important species and strain-specific differences in the geographic distribution, environmental niches, host predilection, manifestations, and response to treatment. And over the next 30 minutes, I'm going to try to take you through the epidemiology, the risk factors, unique properties of the different species, varying clinical manifestations and challenges in the management. And we're going to do this with the help of two exceptional cases that really highlight all these points beautifully. So the first case is one that very aptly sort of describes the term barking up the wrong tree, and there's a pun intended on the word tree, as you will see in the course of the presentation. This was a 54-year-old gentleman, resident of Tardeo, sofa maker by profession. History of ischemic heart disease post PTCA in 2016, no other premorbid conditions. Presented elsewhere in September 2022 with a cough which was initially dry, but eventually became purulent over the next 2 months. Daily spikes of fever, initial severe holocranial headaches, which had spontaneously reduced by the time he presented to us, progressive dyspnea on exertion, and weight loss of almost 8 kilos over the past 3 months. So this is his chest X-ray done elsewhere, and you can see this large left upper zone opacity. I would go as far as to call it a mass because it has very well-defined boundaries that you can see here. He was evaluated elsewhere, and his routine blood work was unremarkable, retroviral disease status negative. He received multiple courses of empiric antibiotics, and clearly there was no relief. This is when he was advised a CT scan, and the radiologist went as far as to call this a large neoplastic solid cystic mediastinal base mass encasing the great vessels. And with this finding, he was referred to Tata Memorial Hospital. He never went there. He went to an oncologist at another private hospital who asked for a PET scan. And the PET scan was done by Dr. Jankaria. And Dr. Jankaria disagreed with the earlier radiologist and said that this is actually a large necrotic lung mass, not a mediastinal mass. There were also some bilateral ill-defined nodules in both lungs and enlarged mediastinal lymph nodes. So a CT-guided biopsy of this lung mass was performed. And you can see over here the histopath showing you these spherical to ovoid encapsulated yeasts which have been marked by the red arrows, similarly seen on the GMS stain over here. And this was described as an organizing cryptococcal pneumonitis. Strangely, nothing was appreciated on microscopy. There was no growth on culture on day 8 following the biopsy. And the cultures had been sent to Hinduja Hospital. So with this relatively exotic diagnosis, he was referred to me in infectious diseases. And various things went through my head at that time. The possible epidemiological and risk factors for cryptococcal infection in this patient. The fact that Cryptococcus was not identified on microscopy, there was no growth on culture on day 8. And the fact that this patient had these initial holocranial headaches which had spontaneously reduced. So there were lots of things going through my head at that time, and I was trying to confirm this diagnosis. So let's take each one of these. Epidemiology. As we understand, cryptococcal meningitis, the incidence of cryptococcal infection, in fact, is highest in sub-Saharan Africa, followed by India, Southeast Asia, and some parts of South America. In fact, in sub-Saharan Africa, it's still the commonest cause of meningitis in patients with advanced HIV. And across the world, it accounts for over 220,000 cases of cryptococcal meningitis with about 180,000 deaths each year. So a formidable entity. Characteristically, the epidemiological niche and the association is with avian exposure, especially pigeons, to which we're most commonly exposed. But this colonizes the GI tract of many birds, pigeons, fowl, parrots, turkey, several other birds. It doesn't cause infection in these birds because Cryptococcus cannot survive and thrive at their higher body temperatures. It's also found in decaying wood and organic matter. Specific risk factors for cryptococcal infection, we know are advanced HIV, especially with a CD4 under 100, where it's recommended to screen these patients. Different kinds of immunosuppressive therapies, transplants, both solid organ as well as hematopoietic stem cell transplants. Lymphoproliferative disorders, especially CLL, sarcoid, even without treatment. Various monoclonal antibodies, Anti-GM CSF antibodies have been particularly associated with cryptococcal infections, connective tissue diseases, idiopathic CD4 lymphopenia, which is defined as a CD4 count of less than 300 and less than 20% of circulating T lymphocytes in a patient who has no other factors responsible for a low CD4 count. In this patient, the CD4 count was about 590. Chronic liver, organ failure, hyper IgM, IgE. There is even an association with diabetes mellitus. And in up to 20% of patients, there are no identifiable risk factors. So coming back to our patient, what were the potential epidemiological risk factors in this patient? Again, South Mumbai, sofa maker, native of Gorakhpur, UP, where he would travel to every year. No remarkable exposure to birds or bird droppings. We kept asking him what he was stuffing the sofas with. Were there any bird feathers down? And he said that's transitioned completely to foam. He hasn't worked with any birds or feather stuffings for years. So for all practical purposes, this was an immunocompetent patient, which drew our attention to the possible cryptococcal species that we were dealing with here. So let's talk a little more about this. Cryptococcus neoformans classically causes infection is classically an opportunistic infection infecting immunocompromised patients, those with advanced HIV. Gatii, on the other hand, does cause infections in immunocompromised, but is also associated with infections in immunocompetent patients. And because it causes infections in immunocompetent patients, unlike neoformans, it produces granulomas. So even in the lung, the lesions are larger. They may actually be mistaken for lung abscesses, cysts, high-grade lymphomas, malignancies, as was in this patient radiologically. Meningitis, the classic presentation is a cryptococcal meningoencephalitis with these soap bubble-like lesions in the basal ganglia areas. But Gatii characteristically produces large space-occupying lesions called cryptococcomas. Pathophysiologically, you have basidiospores in the environment, less than 5 microns, which are the infectious propagules that enter the airways, reach the alveoli, where at body temperature they form these large polysaccharide capsules, which are responsible for the virulence and pathogenicity. They evade immune defenses and enter the bloodstream. They may do this directly or in a Trojan horse mechanism within the phagocytes to reach various organ systems of the body, particularly the CNS, and that predilection for the CNS or neurotropism is accountable by this melanin which is present in the cell wall of the fungus. So coming back to this case, a CT-guided biopsy was done for this patient, but they had failed to sort of notice that this patient was producing so much sputum. So the first thing I asked him to do was, send sputum to the lab again. And they called me within a few hours, completely sort of horrified because his calcofluor stain was studded with these yeast. In fact, they thought it was artifactual because they had never seen such a heavily sort of densely populated, calcofluor. And I want to point out here that even in cases when you're not suspecting this infection and it's part of a large differential, a simple gram stain can actually so beautifully pick up these cysts. This was subjected to the India ink stain, which, as we know, the carbon grains in the ink cannot penetrate the polysaccharide cell wall capsule, and that results in this beautiful clear halo that you see around the refractory wall of the yeast. Sensitivity of the India ink stain varies depending on the fungal burden, and it's much higher in the HIV population, up to 80%, than in the non-HIV population. Nevertheless, clearly the burden was so heavy in this patient, it was positive. So was the cryptococcal antigen, and I'll talk a little more about the antigen in a few slides ahead. Now, coincidentally, on day 9, the very next day, that earlier biopsy, which had not shown anything on microscopy, flagged on culture and was picked up on mass spectroscopy or the MALDI-TOF as being Cryptococcus gattii. So that confirmed our sort of suspicions of the species in this immunocompetent adult. When we talk about the ecological niches of gattii, as I said, infects both suppressed and competent persons in hyperendemic areas, India being one of them, commonly associated with several species of eucalyptus trees in tropical and subtropical climates. And on further probing this patient, there was a eucalyptus plantation near his home in native Gorakhpur, which he visited just 2 to 3 months before these symptoms developed. However, recent epidemiological studies show that gattii is found in moist barks and tree hollows of various species of trees found in India. Some of these are found all across Mumbai as well, like the Indian laburnum, the sacred fig tree, which is our peepal tree, the false ashoka. So it's anyone's guess where he really acquired this infection from. Gattii, like neoformans, again, is primarily a disease of the tropics and subtropics, but unlike neoformans, there have been outbreaks as far north and far temperate as British Columbia and Canada, and even some of the Nordic states in Northern Europe. And this is attributed to the Teddy Roosevelt effect. So standing here on this engine is Theodore Roosevelt himself, overseeing the construction of the Panama Canal in 1914. And as we know, the Panama Canal actually opened up trade routes from South America to the far-flung corners of the Western world. And there was a large export of timber and seeds across this canal, which is thought to attribute to the changed epidemiology over the last century, and perhaps responsible for the large gattii outbreak which was seen in British Columbia in 1999. And that brings us back to the cryptic question that I asked you right in the beginning. So lots of articles on this. The same Vancouver outbreak actually even infected domestic animals and terrestrial wildlife, and 42 dolphins and porpoises in the Salish Sea also died from cryptococcosis at the time. And construction, deforestation, other activities that disturb the soil and aerosolize gattii were attributable to the outbreak. So clearly something of much greater dimension than we imagine. Clinical manifestations of cryptococcosis, it primarily infects the lung and ranges from asymptomatic colonization to life-threatening pneumonias. The most common radiological finding are solitary pulmonary nodules or multiple nodules, but you can have others. I'd just like to point out that like tuberculosis or histoplasmosis, in a relatively immunocompetent host or one whose immunity has improved, this infection may spontaneously resolve without treatment. So you may see phases where the patient has had exacerbations and remissions without treatment. The second most common organ involvement is the brain. Again, may produce acute, subacute, and chronic meningitis, multiple sort of radiological presentations. Raised ICP is very important, and I'll come back to that. The third most common organ involved is the skin, and this may be involved by primary inoculation in an immunocompetent host or as a sentinel manifestation of dissemination in an immunocompromised host. It produces multiple morphological forms, but these characteristic umbilicated nodules, is very important in cryptococcosis and must be closely differentiated from other molds like penicilliosis and molluscum contagiosum, especially in the HIV population. It's interesting to note that patients who are on calcineurin inhibitors like tacrolimus post-transplant may actually present with skin manifestations more often, and that is because the calcineurin inhibitors have inherent anti-cryptococcal activity at higher temperatures, so at body temperatures, and they prevent visceral disease. But they can't do that at lower temperatures in the skin. So you have greater isolated cutaneous manifestation in patients on calcineurin inhibitors. Other important sites are the eyes, the prostate, which is a sanctuary site, and in addition to this, it can involve the bones and joints, heart, various other organs as well. Must remember that immune reconstitution reactions are an important and a significant sort of threat with Cryptococcus, and they may present both as unmasking as well as paradoxical iris, especially in patients with HIV. Coming back to our case, it was very important to rule out CNS involvement over here. That initial holocranial headaches, which had spontaneously reduced, were still worrying us. Of course, there was no other sign of meningitis in this patient, but CNS involvement would dramatically alter the management and the prognosis. And it's essential to evaluate for this, of course, in anybody who is symptomatic, but even in the asymptomatic, immunocompromised HIV population, Cryptococcus gattii, especially because it's known to cause dissemination, it's very, very important to rule out CNS involvement. And so we did an MRI brain, and lo and behold, here we have a focal enhancing lesion in the left frontal cortex with minimal perifocal edema, suggestive of an infective granuloma. We did a CSF, which showed us a lymphocytic pleocytosis, raised proteins, and hypoglycorrhea, and you have a CSF antigen, which is also positive. What do we understand about the cryptococcal antigen test? The serum cryptococcal antigen test has a greater than 90% sensitivity for diagnosis of invasive disease in HIV patients, and hence it is considered a very important and effective screening tool for patients with CD4 counts less than 100. And that's because the serum CRAG is positive weeks to months before clinical manifestations in the CNS actually develop. So before you start the patient an antiretroviral disease and risk the possibility of cryptococcal iris, it's very important to rule this out with screening. The sensitivity reduces to 60% in other immunosuppressed patients like post-transplant, etc., and even less in immunocompetent patients. You may see occasional false positives due to cross-reacting antigens, especially with trichosporon species. False negatives may be seen with very low fungal burden, early asymptomatic meningitis, chronic indolent meningitis, and then you have these important pro-zone and post-zone phenomena. So we understand that the cryptococcal antigen comes positive when it detects cross-linkage between antigen-antibody. So if there's an excess of antibodies or an excess of antigens, this may have a false positivity because it's not picking up adequate cross-linkage. How do we mitigate this false negativity? Is by doing serial dilutions. So you do away with the excess antibodies or antigens and you try to pick it up. So you have to ask your lab to do serial dilutions if you are strongly suspecting Cryptococcus. Most labs have moved on to the lateral flow assay, which has a much higher sensitivity and specificity, both in serum and CSF, over 98%, and a sensitivity of about 85% in the urine. As we know, this has a rapid turnaround time, minimal laboratory infrastructure, low cost. It's just a dipstick test, an immunochromatographic dipstick test, stable at room temperature, better pickup of gattii. However, we must remember that it has limited value in serial monitoring of response to treatment. And that's because the kinetics of antigen clearance is slower and less predictable than a quantitative culture. So at the end of your induction therapy, it's important to repeat your CSF and ensure that your cultures are negative before you move on and not rely on an antigen test. Coming to the principles of management of cryptococcal meningitis, I think there are three salient features. One is a prolonged course of antifungal therapy characterized by an induction, consolidation, and maintenance phase, which I'll come to. Maintaining the intracranial pressure, which is very important. This raised intracranial pressure is actually pathognomic of cryptococcal meningitis, and it's due to blockage of the arachnoid villi due to clumping of the yeast, which are present in these perivascular Virchow-Robin spaces. So repeated therapeutic LP and ventricular drains, shunts are often required to reduce the intracranial pressure and maintain it. Modulating immunosuppression, again, forms a very important part of treatment, because on one hand, you want to control infection while preventing immune reconstitution on the other. And so it's recommended that ART be started after about 4 to 6 weeks of antifungals, and generally after completion of the induction phase. What about the use of adjunctive dexamethasone in HIV-associated cryptococcal meningitis, drawing an analogy from TB meningitis? I'm sorry, some of my fonts have changed over here, but basically what this study showed us, this NEJM study showed us, that not only was mortality higher, but patients had greater neurological disability, clinical adverse events, and fungal clearance was also slower in the dexamethasone arm. So clearly not a recommendation for cryptococcal meningitis. The pathophysiology differs to some extent from TBM. Antifungal regimens for cryptococcal meningitis, we still allude to the IDSA 2010 guidelines by and large, and this sort of distinguishes the three phases based on the risk factors, and then sort of draws conclusions to their duration, and also gives some alternatives. This guideline is now being updated, and our mentor, Dr. Soman, is part of the new guideline body, which should shortly be released. What about antifungal combinations for the treatment of cryptococcal meningitis? Well, interesting finding from this article, which showed that clearance of infection was just as rapid with 1 week of induction rather than 2, and there were probably less side effects also noted with a single week of induction. In the absence of availability or tolerance of liposomal amphotericin B or amphotericin B, the oral combination of fluconazole plus flucytosine also produced satisfactory results and maybe a sustainable alternative. However, must remember that this was in Africa, cryptococcal meningitis mostly due to neoformans and in the HIV positive population. So not sure how to apply this to other groups. This is the most recent study. Again, we have to sort of understand and take cognizance of the fact that this disease is a disease of the resource-limited setting, and so prolonged courses of amphotericin B are not affordable, not available. Prolonged hospitalizations are not sustainable. And so they've looked at single-dose liposomal amphotericin B for cryptococcal meningitis, where they used a single 10 mg per kg dose. What did they find? They found that death from any cause at 10 weeks was just as good with a single dose as it was with control. And in fact, the side effects were lesser with a single dose. However, the mortality in their control arm was almost 30%, which we would like to believe is much higher than what we see over here. So we're not sure how this applies to our setting. Clearly, this was in a public health setup, in purely resource-limited settings. So needs a further look, more studies before we apply this to our patients. And now quickly to take you through this second case, just to show you how diametrically different this organism can be and how it presents differently. This was a lady, again from Mumbai, with granulomatosis and polyangiitis, multiple findings. She was on steroids, weekly methotrexate. March 21, she presented with low-grade fever and cough with expectoration. You can see her CT showing you a nodular opacity over here in the lower lobe. She was started on empiric first-line AKT based on granulomatous inflammation reported on the histopathology. However, a few days later, the fungal culture grew Cryptococcus neoformans, and that's when she was referred to me. Now, it's very important to ensure that TB is not coexisting, because in hyperendemic settings like us, both these diseases can coexist in a vulnerable host. And so we asked the histopathologist to take a relook at the histopathology and redo fungal stains and stuff, and they actually gave us an amended report saying that they had seen the highlighted fungal yeast amidst necrotic areas. Subsequently, her 6-week TB midget culture also came negative, and so she was treated as a case of Cryptococcus. On further probing, they found that their bedroom AC was infested with pigeons, and when they actually serviced the AC, the entire machinery was full of pigeon feathers, which is what we often find in city dwellers who develop this disease. Again, no clinical or radiological evidence of dissemination. Cryptococcal antigen test was negative in this patient. Sensitivity would be about 60% in the non-HIV population. And so she was managed as a case of pulmonary cryptococcuses. Mild to moderate symptoms would require a single drug, fluconazole, for 6 to 12 months, unlike severe pneumonia, which would be treated like a CNS manifestation. There was good clinical and radiological resolution at 3 months, and her fluconazole dose was actually reduced slightly because she had some intolerance to this. To our horror, she was admitted 2 months later with severe headaches and vomiting, dry cough, dyspnea, and exertion. You can see that her CT scan shows marginal increase in the nodules over here. Cryptococcal antigen was still negative. MRI brain was done because of those headaches, and that showed diffuse pachymeningeal thickening and enhancement along the falx and the frontoparietal areas, which was not seen on the earlier scans. Her CSF examination showed elevated proteins, but otherwise there was no pleocytosis, CRAG was negative, no evidence of TB, cultures were sterile. And a CT-guided lung biopsy also didn't show any evidence of infection. So after much deliberation with the primary rheumatological team as well as the radiologist, the neurologist, it was decided that this was a non-infective cause. And what do we understand about pachymeningitis? We know that it's an inflammatory disease characterized by local or diffuse dural thickening. What's interesting here is that the common associations are TB, CNS cryptococcuses, and granulomatosis, all three of which this patient could easily be. So this was really a sort of dilemma for us. But as I said, after much deliberation, it was decided that this was her primary rheumatological flare. And she responded very well to steroids and rituximab with complete clinical and radiological resolution. And she's doing well on follow-up at 1 year. So in summary, we had an immunocompetent patient with a disseminated disease and an immunocompromised patient with a focal disease and a tricky differential. And I just want to highlight through these two cases that regardless of the risk factors, the epidemiology, the ecological niches, the species of Cryptococcus also went a long way in changing the course of their manifestations and the eventual management. Thank you.
How soon can you detect positive after infection?
The positive CRAG is what you mean, the cryptococcal antigen. Yeah, so it depends upon the host factors. So in a patient with advanced HIV, it's known to have a very good sensitivity even weeks to months before the patient becomes symptomatic. But that positivity and that sensitivity reduces in other populations. So as you can see, even in this lady who had symptoms, and we currently have a case of a patient who is immunocompetent with a joint infection, which is proven Cryptococcus, and their serum CRABs come negative. Yeah? Sure, go ahead, sir.
Actually, I came early for the meeting to hear you and also see you because one of my patients described you. Following up with me, and you have treated him extensively. But I found that in the differential, tuberculosis, I passed my MD in 85. At that time, we had this immunocompetent syndrome as my MD exam question because HIV was not an established entity at that time. So we are retro learners. Now the things are there. So in this presentation, I find the absence of one differential diagnosis, that is biliardosis. And biliardosis is not discussed at all for most of the reasons. And you can imagine with that patient, he had encephalitis, and it was diagnosed as milioidal encephalitis.
Right.
We have treated him extensively with injectable antibiotics for 3 months. And the guy underwent craniotomy and all, everything. And now he's doing well. He came for the basic metabolic abnormality, that's diabetes to me, and he's okay. So I wanted to ask you whether does it really come in your differential biliardosis, and when you have this in the differential, and this BART and this
So as I said, Gatiae has been known to aerosolize into the atmosphere. So any susceptible person just breathing the air around it is good enough, you know. True, but the entire outbreak that's happened in British Columbia and everything didn't involve timber workers or anything, you know. In fact, it, as I pointed out, it even involved animals and other sort of wildlife in the area, and it was purely through aerosolization is what is believed. And as for your question about melioidosis, of course, it's very pertinent, very important, and it's something that we need to create awareness about. In these two cases, I would say, of course, anybody with an extensive pneumonia, which is unexplained, uncontrolled diabetics, especially from certain parts of coastal India, but otherwise from everywhere. But generally, when it disseminates, it produces abscesses. And we don't see, you know, ring-enhancing small lesions or pachymeningitis with melioidosis. You generally see large pyogenic abscesses, yeah, in various organs tissues.
Diagnosis came through the biopsy. First case, the lung mass was biopsy.
I have another question for that. You know, previously microbiologists used to see through the microscope, and the treasury of their information was their own information and the books. How much of AI is being used now?
Sorry, how much?
AI.
Well,
Yes, I'll tell you now. When this Burkholderia was diagnosed, I just discussed with the pathologist. He said now these diagnoses have become simpler because of the molecular techniques and also some use of some AI software. So I don't know how much.
no, I would disagree about melioidosis. Melioidosis is still picked up by a discerning microbiologist with the right biochemical tests and colony morphology. So you have a microbiologist who is experienced and has seen melioid, will pick it up in an instant if it's growing. Absolutely, but that goes with most things. And whereas Cryptococcus is concerned, apart from the immunochromatographic test or cryptococcal meningitis picked up on the biofire, which is a PCR test, all right, you wouldn't really use artificial intelligence. Your India inks and your, as I showed you, the gram stain, the calcofluor stain, these are all very much sort of inherent microbiology tools, you know. Sure.
Can you elaborate on the point that Cryptococcus has a predilection for which part of the myelin sheath or something like that?
No, it's not the myelin sheath. The cell wall has melanin in it. Yeah, and any organism which produces melanin or has melanin has a specific predilection for the CNS, okay? Especially the basal ganglia areas, because melanin has a neurotropism. Sure. That's what I pointed out, that the outbreak was due to Gatiae. And the species Cryptococcus gatiae can produce and has produced outbreaks in immunocompetent hosts as well. Yeah, Cryptococcus neoformans, the second case, is predominantly associated with immune suppression and is more of an opportunistic pathogen than Gatiae. Okay, thank you.
Are there specific criteria to differentiation to Gatiae and neoformans?
So that is picked up on, I asked our microbiologists as well that on colony morphology or anything else can you make out, and they said no, it has to be picked up on an automated system, and now we have Maldi which picks it up.
The automated system is AI.
That's true, but that's to give you the exact strain or whatever. The basic Cryptococcus is picked up by the microbiologist.
Thank you.
The sensitivity may not be different, but Gatiae definitely has a more virulent it's a more virulent organism causing refractory disease, and it's very difficult to treat.
Thank you, Dr. Ayesha Sunawalla ma'am, for
Thank
the
you.
amazing talk on Cryptococcus.
Thanks.
Now I'd like to invite on stage Dr. Kanishka Dawda sir to kindly felicitate ma'am with a token of her appreciation.
महेश, तेरा इंटरनल असेसमेंट का एग्ज़ाम कैसा गया था?
ठीक ठाक था यार.
मुझे सर ने कल ओपीडी में बुलाया था. सर बोल रहे थे कि आई डोंट नो अबाउट प्रैक्टिस चेंजिंग पेपर्स इन मेडिसिन, बट योर पेपर्स विल श्योरली चेंज माई प्रैक्टिस इन मेडिसिन.
So to actually talk about practice changing paper in medicine 2023, we have with us Dr. Amit Saraf sir, Director and Senior Consultant, Department of Internal Medicine, Jupiter Hospital, Thane for our next talk. Over to you, sir.
Thank you, Mahesh and Abhishek. I think, as a little of a, when I sit in the audience, I always wonder कि एक should be a disclosure in one of your slides कि how many slides do you have? It always helps when I am sitting, if I want to plan my phone calls, my toilet break, my tea break, I would want to know कि speaker के इसमें कितना slides है यार, so then I can plan it. So let me first answer my own query. I have 7 slides. My own department has given me a very difficult topic, that the fast 5 practice changing guidelines of the year 2022, not 2023. So I have 5 slides on that. Here first hai, the last has to be a thank you slide. So I have total of 7 slides. So because I'm going to save a lot of time for my own event and for the speakers also, let me take these initial few minutes to welcome all of you on the department, on the behalf of Department of Internal Medicine. Thank you so much for coming here on a Sunday morning and gracing our event. I really welcome you all and thank you all. The reason for doing this infectious disease CMA this morning was that Jupiter Hospital is one of the 4th hospital now in the MMR, Mumbai Metropolitan Region, to launch an official adult vaccination program. What we do is we have an adult vaccination passport, we call it. It's freely available on any cluster, starting from the reception desk on the ground floor, the health checkup area, the OPD clusters, the IPD clusters. Any one of you can walk in if you come, pick up a passport. The passport is a small little booklet designed like a passport, which has your patient's details right from demographics to the vaccines he or she can take, the vaccine in a short capsule summary on the left-hand side page, on the right-hand side the date of the dose and the number of dosages given, and the last page is a summary of the entire vaccine, exactly how pediatricians do it for their own children, the vaccination. But this is like a passport, a pocket-sized book, which the patient can carry back, and it becomes a record. So not only as a process, but I thought as a protocol, as an adult vaccination drive, because officially it's been done by only Hindujas, HN, and now Reliance. So I thought we should also come into that and launch it officially. So to launch that, I thought a CME on ID would be a good idea. And the entire crafting, conceptualization was done by my 2 close friends and associates, Dr. Dhanashri, Atre-Singh, and Dr. Kanishka, Dawda. A big round of applause for them for this morning, for this entire program. The success story also is the part of the team. So Dr. Javal, Dr. Yogita, my all residents here have been working very hard last few days, going home late at night to ensure all these facilities, all this is to your comfort. And I pray and hope that everything is to your comfort this morning, including the breakfast, the registration areas and everything. So I hope you have a wonderful day today. We learn a lot of academics at the end of the day. And I hope when we get back to our practices from Monday morning, we do initiate a lot of adult vaccinations, which I'm sure during the day we'll be able to pick up bits and pieces, whom to vaccinate, when to vaccinate, what kind of vaccines to be given. So with those...
Thanking you for whatever you have done. It is an excellent, on your behalf of Jupiter Hospital, it's really excellent.
Thank you so much, sir. Thank you so much, sir. So with those few words, thank you. Thanks. Now I come to my topic of a few slides. So fast 5 in the year 2022. I am the only offbeat speaker in today. Everybody will be talking on ID. I thought I'll talk a little different. So what came up in the last 1 year in the various papers. So what I've done is these are compilations of index journal from India, which is mostly JAPI for us as physicians, NEJM, Lancet, and BMJ I've taken as international references. So from that, what came at first and foremost was the mRNA vaccinology. So I think 2020, 21, and 22 was the years of vaccine. every adult, because of COVID, thanks to COVID, was really educated of the importance of vaccine. In that foray came the mRNA. There are various types of vaccines, as we are aware. mRNA came to the forefront, and advancement in the generation, purification, and cellular derivation of the RNA have enabled the development of this mRNA, which is a broad array specifically towards cancer and Zika. So 2022 was a year when these two vaccines made the foray, made the forefront, and I'm sure by the end of 2023, they'll be out for absolute deliveries and hopefully prevention of certain kinds of, especially lymphomas and blood cancers and Zika virus as well. The technology is cost effective, relatively simple to manufacture, and elicits the immunity in a novel fashion. In silico, most of us, before looking at the slide, imagine our own health checkups. We all sitting in the audience undergo a lipid profile today morning, or a patient comes to us with a health checkup and his LDL is the only thing which is a worry. Others, total cholesterol, triglycerides, maybe a little up and down, but LDL-C is definitely high. And then what do? The patient is asymptomatic, not on any complaints, maybe a middle-aged man, maybe on a hypertensive drug. So over the cut across, the research guidelines have shown that that LDL-C is the one which really causes a lot of atherogenic potential, a lot of atherosclerosis, and we need to target that. Problem as clinicians, where do we face? Patients discontinue therapy. Patients find the cost factors a little worrisome. Most of the statins cause a lot of myalgias. The moment renal impairment settles, we can't give most of the statins. We have to scale down the dose. The moment you scale down the dose, the lipid lowering potential goes down. So challenges. So again, in the year 2022, we had a new drug, Inclisiran. It is a beautiful drug. It was basically twice a year injectable preparation. So this will, in the moment it is launched in phase 4 and therapeutic dosages this year, it will revolutionize the way we manage lipids, mostly the LDL-C. In contrast to statins, it requires very infrequent dosing, twice a year, effective and sustained LDL-C reduction, and a prolonged effect may help in also elevating our major problem of medication non-adherence and non-compliance. Diabetes, my area of interest, twin incretin. Twin incretins, when they come in the market this year, trust me, they are going to revolutionize the entire diabetes scenario. Your both glucose-dependent insulinotropic polypeptide, the GIP, and the glucagon-like polypeptide receptor agonist, the GLPs, both put together are going to revolutionize you and me treat diabetes. There are already multiple drugs available today. The moment these two come in the market as a combination, your weight loss, your sugar controls, your least side effect, least risk of hypoglycemia are all going to be addressed by just a drug delivery of these two molecules together. And they work, as we are all aware, they cause the pancreas to release a little bit of more insulin, block the hormone glucagon, and thereby limiting sugar spikes, especially in Indian scenarios, because we are a carbohydrate-rich community. The breakfast served today, pohas and idlis and medu vadas. The lunch we'll have today. So we do, as Indians, have a lot of carbohydrate in our diet. So we need something which ebbs that post-meal sugar spike. And this is going to revolutionize it in this year itself. HOCM, again, I thought amongst all the new things which came up last year, HOCM was an area where not lot of work is being done, other than little of beta blockers and in some individuals, some surgeries as an extreme measure. You don't really have much to offer your patients. They lead a pretty bad quality of life of dyspnea, edemas, cardiac failures, arrhythmias coming on off and on. So this, again, last year, the first-in-class medication, they have yet to give it a nomenclature, is going to be launched, which is going to reduce the abnormal contractions caused by the genetic variations of the heart. Snooze and okay, two options. I hope nobody's snoozing in the audience. And something pertinent to today's crowd and today's topic, artificial intelligence for detection of sepsis. Now, how does this work? Your sister, everybody, we work in hospitals, some of us are hospital owners, some of us work in a hospital. Our nurse enters data into most of the EMRs. Imagine an ICU patient. She's entering the temperature, the pulse rate, the blood pressure, the saturation level, the intake output. Most of them are electronic data. Their AI is being developed as we speak, and they're going to be again into practice this year onwards, which will critically analyze those very subtle graphs and give us an alarm bell that this is a patient of yours who probably is going to turn septic or into septicemic shock or into sepsis in today or tomorrow or in the immediate future. So AIs are being developed again to make those subtle changes, see the algorithms, try to give you a little of an inkling that this is the patient, you need to test for some maybe inflammatory markers, maybe the markers for sepsis, and give a higher antibiotic, or maybe change or shift onto antibiotics. So these were a few little exciting papers which caught my attention for the last year, and thank you so much for a very patient hearing. Thank you so much.
Thank you so much, sir, for that amazing and crisp talk.
थैंक यू सर. यार अभिषेक, मैं सोच रहा था कि शहंशाह वाले अमिताभ बच्चन का मेटल वाला हाथ खराब होगा तो वो डॉक्टर के पास जाएगा या मैकेनिक के पास?
उसके हाथ का तो पता नहीं, but your jokes surely need some repairing. So it gives us great pleasure to invite Dr. Rajeev Soman sir, who will be joining us online. Rajeev Soman sir needs no introduction. He is a pioneer in the field of infectious diseases. He has multiple publications and journal articles to his name. He will be giving us a talk on prosthetic joint infections.
Visible?
Yes, sir. Yes.
Is my screen visible?
Yes.
Yes, sir.
Yes.
Chat box, please.
Yes, sir, your screen is visible.
Kanishka. Sir, you can start, sir. You are visible and you are audible too.
Can you hear me?
Yes, yes, sir.
Yes, sir.
Very loud, very clearly.
Just call him and tell him maybe he's not listening. उनका speaker on नहीं रहेगा.
उनका स्पीकर ऑन नहीं रहेगा. Hello.
Sir, you can hear you. Start. See, you can see your sound. Yes, yes. Now, no.
Start now.
Yes.
Because I am not getting a sense of what is happening.
No, we can hear you, sir.
Hello.
Yes, we can hear you. We can see you.
Hello.
Yes, sir. We can see you. You can start.
Or am I speaking to myself because not able to
Go ahead.
hear, I'm not so sure. Okay, so friends, good morning. It's indeed a great pleasure to be here as part of your meeting, and I'm going to speak to you about prosthetic joint as well as implant-related or orthopedic-related implants, infections. So these joints and implants assist structure as well as function, and therefore we definitely need them. However, having an implant or a joint is sometimes like entering an unknown cave, because you don't know what is lurking inside, and that danger is sometimes always of infection. And infection may be a low incidence situation, but certainly a high consequence situation, because cure is seldom possible without removal of the joint or the implant. So the outline of my talk is we'll discuss a little bit about the pathogenesis and the very prominent role of biofilm in all this. What are the diagnostic challenges? What can be a management algorithm with some illustrative cases? Prevention and special problems in India. So we know that there is a problem with the biofilm. So there condenses with glycocalyx, so this is the biofilm formation, and then there is ineffective but persistent inflammation, which is produced as a result of the leukocytes, so that the leukotrienes and the prostaglandins which they liberate actually damage the surrounding tissue, and therefore bone resorption can get triggered and loosening of the joint or the implant can occur. Later on, there can also be dispersion and a metastatic seeding and embolism. This, of course, applies more to intravascular biofilm-related infections and not really to the joints. It is very simplistic to think of the biofilm as being a protective barrier for the bacteria and they shield them from WBCs and antibiotics, but there is much more to it than that. The gene expression of the bacteria which are embedded in the biofilm actually changes. So the phenotype changes to a non-aggressive form with low metabolic activity and with antibiotic resistance. And as you can see here, the MIC of the biofilm organisms may be as high as 8,000 times more than of planktonic organisms. So if we have to treat an infection which is related to a biofilm, then the required antibiotic properties are, it should be bactericidal, it should be able to penetrate the biofilm, it should work against the stationary phase bacteria which are not really dependent upon cell wall production, and it should have no inoculum effect. In other words, the bacteria, even if the bacteria are in high number, the antibiotic should be able to work against it. Now, needless to say, there is no such antibiotic which has all these 4 or 5 properties, and therefore it is inescapable that if infection has already set up, which is related to the foreign body and related to the biofilm, then the cure won't be possible unless the device is removed. What clinical features alert the clinician? Of course, it is an acute onset pain. There is never a reduction in the post-operative pain. So there is no pain-free interval after surgery. There might be history of a prior wound healing problem or sometimes a sinus formation. We can look at various inflammatory markers either in the systemic circulation or in the joint fluid itself, which may tell us. And finally, the PCR sequencing, which can also be done, 16S rRNA sequencing, can also help to pick up the genetic elements of the organisms which might have found their way into the joint. Now, more probably, you can look at abnormal lucencies. So, if you see more than 2 millimeter lucencies, and especially if the lucencies, radiolucencies are there on both components of the joint, it can definitely mean that it is likely to be infection, or there is loosening and movement of components, or if you have an abnormal radionuclide scan, maybe about 6 months after the replacement, because you know that if you do it sooner, the surgical trauma itself can give you a positive scan. As we discussed earlier, the biofilm blunts the infection. So you have different joint fluid cutoffs. Now you might remember that 75,000 or 50,000 WBCs is what we usually look for in a native joint septic arthritis. However, if you look at what sort of counts are seen after joint replacements, they are much lower, and therefore something which is producing a count of just about 1700 in a knee joint after 6 months of surgery may be also indicative of a joint infection. Needless to say, if purulence is found at surgery or there is acute inflammation seen on histology, and by that we mean 5 to 10 polymorphs per high power field, if organisms are seen on smear, and there is a short time to culture positivity, all this will definitely indicate that there is an infection. Now, at surgery, we generally want 5 to 6 cultures, and these should be separate tissue samples from suspicious areas. They should be sent immediately, and it should be inoculated preferably into a blood culture bottle if it's a liquid medium. And it might even be advisable to change the gloves and the actual instruments which are used to obtain these cultures from the separate sites, so as to prevent, or to rather to demonstrate that the same organism is getting picked up at different sites and not due to a potential transmission from the same glove. Prolonged incubation and sonication of the device is certainly very useful, especially if prior antibiotics have been received by the patient. Ideally, the patient should not be on an antibiotic for at least 2 weeks before, and I would even say that peri-operative antibiotic or pre-operative antibiotic should be deferred until the sample has been collected, again to maximize our chances of obtaining the positive culture. And sometimes, although we have all these criteria, it is not always easy. Sometimes all these criteria do not point in the same direction, either towards infection or away from infection. And therefore, the clinician may have to stack the evidence for or against infection before he takes the next step. And therefore, some clinical judgment is always required because all these criteria may not always be met in each and every patient. Now, let's take this first case. So, this case outline highlights that there is a need for several aspirations if CONS has been found. So, here we have a 65-year-old doctor. He was a diabetic, obese, he had osteoarthritis of the knees. And this is an old case, so this was in 2003 when I was also a junior physician or a junior ID physician. So he had pain 1 month after surgery, there was hardly any systemic toxicity. He agreed for an aspiration and CONS was found. But he dismissed himself saying that it's a contaminant. And we have seen this phenotype that this is a dominant surgeon who throws his weight around, he's the know-all type. So he said this is just a contaminant. But after a lot of convincing, he agreed for a second aspiration, which also showed the same organism, namely CONS. Why is this important? To show that the second aspiration is also positive for this organism. Because remember, this can also be a skin contaminant. So when you get one culture positive, you do not know whether this has come from the aspirate and it has come from the skin contamination while doing the aspiration procedure, or on the other hand, the skin organism has found its way into the surgical site during surgery. And all this is important because after 3 weeks of infection, the opportunity for carrying out debridement and retention of the prosthesis can be lost. Now it is even said that it's not enough only to say that this is CONS, but you may possibly have to show that they are identical genetically by next generation sequencing. So when is the strategy of DIRE, as it is sometimes called as debridement and retention of the implant or implant retention? So you need good criteria, or at least most of these 5 criteria. So if you have an onset of infection or clinical infection 3 months after implantation, or it could be late but it is hematogenous. So then I will come to that a little later. The duration of symptoms is also less than 3 weeks. So what does this tell us? The mature biofilm has not formed. And remember that once a mature biofilm forms, it's very impossible almost to get rid of it. If it is a well-seated, not loose prosthesis, there is no soft tissue involvement, again telling you that the number of bacteria, the burden is quite less. Or there is no growth or low virulence organisms such as CONS has been found, which is susceptible to oral antibiotics and to rifampin. So all these 5 criteria indicate that there is a small organism burden, there is an immature biofilm, and therefore debridement with washing, removal of the plastic polymer and antibiotics, say maybe 3 months for hip and maybe 6 months for knee can be used. Now, most authorities don't recommend 6 months of antibiotics even for the knee, and generally 3 months works well. Now, this kind of strategy would work best for older patients, and if other procedures such as removal and reimplantation are considered highly risky. Also, be reminded that if all these 5 conditions are not met, the results with this debridement and retention can be suboptimal. Now, MDR, GNV are really nightmare pathogens, and they actually serve to expose the gaps which we have in infection control. So here is a patient who had a right hip replacement done elsewhere. There was fever and wound gaping and purulent discharge 1 month later. A resection arthroplasty was done and the surgical specimen was cultured. And to our dismay, this surgical specimen showed 3 organisms. So this was Pseudomonas, Klebsiella, as well as Proteus mirabilis. And as you can see, the Pseudomonas is resistant to everything which is just reported as susceptible to colistin. And the same thing is true for the Klebsiella. And for the Proteus mirabilis, of course, it is susceptible to meropenem. So we often like to see what is the genotype of these organisms. So the isolated Pseudomonas aeruginosa was shown to be present to producing NDM, and the Klebsiella pneumoniae, as expected, was producing both NDM as well as OXR48. But interestingly, we also must supplement this information by knowing the epidemiology. So we know that there are other NDLs, other OXRs, there could be amino acid insertions producing PBP3, especially in E. coli. So even this genotypic information is not complete. So the clinician must know what other genetic mechanisms could be there which might create a problem. The same thing is true about the phenotype. So here we have, in this particular patient, there was a discordance in carbapenem susceptibility, and sometimes looking at that, sometimes looking at the discordance between carbapenem and third generation cephalosporins also can tell you that there might be particular types of resistance mechanisms. What we don't look at commonly is efflux, permeability, ESBL types, as well as MC and MC types. So these are other things which we need to imagine, which might be occurring in that particular patient. And finally, you have considerations of in vivo. Because this is a mixed flora related infection, we have to look at the bioburden. The nature and site of infection determines many things. Antibiotic penetration also is dependent upon the site of infection and whether source control is done or not done. So actually we need to look at all this information before we can judge what treatment can be fashioned for this. So if you look at this, this was the phenotype, this was the carbapenemase genotype, and then the clinician has to think like what possible additional mechanisms may be there, and taking into account all these, then the patient's treatment can be fashioned. So if you pay attention to the Pseudomonas, the Klebsiella and the Proteus, you have various alternatives, but finally it will boil down to using ceftazidime avibactam along with aztreonam for all these particular infections. Reminding you that colistin might also be considered as one of the drugs which can be used, but Proteus mirabilis has intrinsic resistance to colistin. So actually we will have to choose these drugs. Now interestingly, when you have a polymicrobial infection, some of the enzymes, now remember the gram-negative bacteria have the enzymes in their periplasmic space, and once the organism starts getting lysed, these are liberated into the surrounding medium, and therefore if we are using a drug which is not stable to one of these enzymes, that drug runs the risk of getting destroyed by the enzyme which is now liberated into the surrounding medium. So now returning to this case, what can we do? Can we probably have to opt for a two-stage exchange? Now there are some options of using one-stage exchange, which is often utilized in Europe, but that is mainly when it is a hidden joint, when there's good soft tissue, there's a good bone stock, there is no graft needed, the organism is simple to treat, and antibiotic cement can be used. So in these situations, which is mainly meant for the hip joint, one-stage exchange may be considered after 2 to 3 weeks of antibiotics. Here the clinician appreciates that osteomyelitis is still present, but it is amenable to the antibiotic treatment, which is to be continued for 3 months. So he is actually putting in a new joint in the presence of osteomyelitis. So needless to say, the organism should not be highly virulent, should be amenable to treatment easily. In our circumstances, most of the time these conditions do not apply, and therefore what we utilize most often is a two-stage exchange, as is being used in most of North America. So that is done with antibiotics in the interval. So if you have susceptible organisms, perhaps we can use a shorter interval such as 2 to 4 weeks, but if a longer interval is more appropriate, if the organisms are somewhat like MRSA or MDR GNPs or fungus and so on, and no spacer is generally recommended unless it is loaded with an appropriate antibiotic. So if you don't have an appropriate antibiotic to load that spacer with, then it is better not to use. So a two-stage exchange. How is it done? After an antibiotic course, a free interval of 2 weeks is generally used. Then cultures are obtained to ensure clinical microbiologic absence of infection to the extent that we can. And then do a re-implantation. But even during re-implantation, obtain samples again for culture and histopathology. And the antibiotic which was effective for organisms found at the first surgery should be used after specimen collection. If the culture is negative, if no acute inflammation is found, then really no more antibiotics are needed. However, if anything out of this is positive, then we still think that antibiotics should be continued further because the infection has not yet been eradicated and a new implant has been put inside. There are a few differences between joints and implants. So let's quickly spend a moment over that. So implants hold parts of the bone together, so that is required for achieving stability and may need to avoid micromotion. This micromotion between the components produces hemorrhages from the fragile capillaries and prevents control of infection as well as fusion of the parts. In the joints, the joint needs to be present permanently as against an implant which can possibly be removed after control of infection, and the goal in the joint is to enable motion. On the other hand, the goal in the implant is a rigid fixation till bone union occurs, and perhaps it is retained as long as there is no uncontrolled sepsis. Infection can be suppressed with antibiotics for at least 3 months, maybe up to a year or two, until the bone unites. And following that, the implant can be removed. Now, eradication of infection and of the biofilm is certainly attempted with joints, whereas eradication of infection and of the biofilm is not always a priority with implant-related infections. We are okay with suppression, which is acceptable till the final removal of the implant is done. Needless to say, this type of strategy for the implant, to keep it, treat it, and then remove it after the infection is suppressed and after the bone is united, cannot be easily used if we are dealing with highly resistant organisms, and that will outline some of the problems which we face in India. Now, this was a rather old study done by Ayesha when she was my fellow. So this was implant-related orthopedic infections due to carbapenem-resistant gram-negative bacteria. This was way back in 2013, and I think I was not really able to find any larger studies from our country, and that's why I'm still quoting this particular study. So we had just 11 patients that time, and that time carbapenem-resistant GNB was a big news. It's no longer a big news anymore. So these were patients seen between 2012 and 13, and some of them had genetic studies. 5 were found to be NDM, and 1 was found to be NDM and OXA producer. So this was big news that time that, we were talking about NDM and OXA48. Today we are always talking and breathing and eating these terms. So various different antibiotic combinations were used to treat these patients, including debridement and permanent removal of the implant, and with that we used to get a good result. Let's address this issue of hematogenous infection. So here you have a patient who had a high-grade tibial osteosarcoma and he had a megaprosthesis. The patient was receiving chemocycles through a port, and he developed abrupt onset of high-grade fever and these shadows which were seen, which were reported as consistent with IPA. The patient had neutropenia and was treated by the oncologist empirically with meropenem. So the serum Aspergillus galactomannan was actually found to be negative. Nevertheless, voriconazole was started. The blood culture had shown MSSA. Meropenem was continued. Next blood culture came negative, and meropenem was given for 7 or 8 days, and the patient was discharged. A month later, the patient developed pain and swelling in the knee, where he had this megaprosthesis along with fever. The knee was aspirated. It was found to be turbid. Culture was awaited, and the patient was referred for an ID opinion for suspected aspergillosis of the knee. Now, at this stage, when we looked into the case, we re-examined the diagnosis of invasive pulmonary aspergillosis done 1 month later, 1 month earlier. So it really appears unlikely in view of the abrupt onset of fever without cough, The serum galactomannan was negative while the patient was severely neutropenic and was not on any mold-active prophylaxis. Besides, aspergillosis of the knee is not a very common problem. So what could it be? The patient, remember, had a chemotherapy port in place for several months, which could have produced Staph aureus bacteremia. While nodules with halo are characteristic of IPA, the same appearance can occur due to other causes such as hematogenous Staph aureus abscesses. Since the patient had received meropenem for only 7 days, which is in any case not the preferred treatment for Staph aureus bacteremia, the infected prosthesis or the port was still in situ. The seeding of the megaprosthesis could easily have occurred, resulting in Staph aureus related septic arthritis of the knee. So the port was removed, the blood culture as well as the culture from the right knee periprosthetic fluid did show the same MSSA. And so now we knew that this was a infected port, Staph aureus bacteremia, hematogenous lung abscesses, hematogenous infection of the megaprosthesis. Okay, so the appropriate treatment perhaps of Staph aureus bacteremia, including port removal and appropriate drug selection, could have prevented this hematogenous seeding of the megaprosthesis. This example tells you about inappropriate initial strategy and how that can result in the loss of a limb. So here you have an elderly patient with a TKI done elsewhere developed a prosthetic joint infection. So this was reported as Staph aureus coagulase positive, and this report from elsewhere is really speaking uninterpretable. This tells you that linezolid is resistant, vancomycin is resistant, oxacillin is susceptible, and so on. So it was rather difficult to make any sense out of this report. The patient underwent multiple debridements with retention and was treated with various antibiotics over 1 year, including linezolid, TMP-SMX, and almost all others. So on presentation to us at Hinduja Hospital, the patient underwent a resection and removal of the hardware. And here we found that the organism detected was actually Acinetobacter. So this was probably acquired during multiple lavages which this patient had undergone. So we did treat this patient with colistin, but we also thought that we should treat that previously identified Staph aureus, although the susceptibility of that was very strange, with daptomycin. A PET scan also was done for this patient. We showed that the proximal bone was not that much involved. But how could you actually get rid of this much amount of infected tissue, both of the femur and of the tibia, without producing unacceptable amount of limb shortening? So this much removal is actually going to make walking impossible. So in this particular patient, she unfortunately landed up with an amputation. So if there is a recurrent infection, there is severe bone loss, resection, arthroplasty or fusion can be an option. But at all times, goal is a reasonably functional, painless joint rather than just eradication of infection. If infection is extremely difficult to control or life-threatening or mechanically unsound, as in this particular patient, then which is going to produce a huge morbidity, then amputation is the only way in which we can actually have a cure of this infection. So as I said, initial strategies, if they are not really appropriate, we can go in the wrong direction and ultimately we need amputation. So it's very important to get it right the first time. So sometimes we say that we should always learn from others' mistakes. We can never live long enough to make all the mistakes ourselves. So I'll now address what might be special problems in India. So we know that there is no universally good infection control practice. There is hardly any surveillance of the surgical site infections. So the orthopedic surgeon doesn't know what are the surgical site infections, how many are there, what organisms are involved, and so on. And therefore it becomes somewhat difficult to adopt an appropriate strategy. So there might be improper prophylaxis for clean surgery as well as implant-related surgery, and this prophylaxis is dictated by many factors, including knowing what is the local epidemiology. All this prompts initial procedures which might be inappropriate. So when you are not supposed to do debridement with retention, that becomes an easy way out, and the same thing is repeated over and over again for a year or two. So organisms which we often encounter are these MDR, GNPs, we have MRSA, we have MDR, Atre-Singh, we have fungal and NTM infections all the time. And then these are really not uncommon. It is impossible to cover many of these organisms empirically, and therefore microbiological diagnosis is very, very important. Empiric treatment is next to impossible. And in this context, the multiplex PCR tests, which are coming from Western countries, may hold a promise. But if you look at them again, many of these certainly are encountered, but some of the uncommon ones which I listed above are not even there in this particular joint infection panel. And therefore, we have to use this, but keep in mind that there could be others which are not picked up by this panel. Another problem is the use of the term superficial infection soon after an implant. Very often it is said that it's just a superficial wound infection. But remember here that soon after the implant is not yet hermetically sealed from the superior structures. Okay, so to say that this is just a superficial infection, it is not involving the deep structure or the implant, might not be right. It is said that when you see any superficial infection in the patient who has recently had an implant, the chances are deep infection is definitely there. There's also a psychological barrier to the diagnosis of implant-related infection. So if the surgeon has done this procedure himself, then he's a little bit reluctant to accept the diagnosis, so he's thinking now of fat liquefaction or something else which is producing that. The surgeon might want you to, as an ID physician or as a physician, might want you to examine the patient from head to toe, but without looking at the operative wound, because he's now thinking that this could be typhoid, it can be malaria, it can be urinary infection or something else. So this kind of a threshold for acceptance of the diagnosis of an early implant-related infection is very difficult. Often surgeons view that as a personal failure, which is actually not true. It's a system failure because, it's, after all, so many things could have gone wrong. But there is also an opportunity for actually treating and curing that infection if the diagnosis is accepted in time and appropriate steps are taken. Sometimes we are given reports of swarms of sinus tracts and sometimes even swarms of operating surfaces rather than the fluid, rather than the tissue, to guide therapy. Now this may sometimes be difficult and may or may not be representative of what is actually going on. Antibiotics are sometimes used pre-operatively, but as I said, empiric choice is difficult and hampers the detection of pathogens. Now, when you use antibiotics as a sole strategy without doing debridement, retention, explantation of the device, remember again that no antibiotic works efficiently in bioweapon, especially if it's a high inoculum infection and stationary phase organisms. So not following this algorithmic and a team approach can actually lead to a disaster. So by that I mean that if you advise that the patient probably needs explantation of the device, a few days later you find that the implant is still in and the ID physician is out. In other words, your reference is cancelled. Now this kind of algorithmic approach which I outlined earlier is formulated by experimental and clinical studies as well as, more importantly, analysis of failures. Also, it depends upon what is the local epidemiology of pathogens, resistance, what is the team expertise, and finally, of course, the patient preferences. An agent with an antibacterial activity, anti-biofilm efficacy, and high oral bioavailability is really difficult to find in India. So, we cannot use easily strategies like empiric therapy, debridement with retention, one-stage exchange, and oral antibiotics in the continuation phase, as was done in this trial called as the OVIMA trial. And also it is difficult to find agents which you can use for chronic suppressive therapy. I'll close by saying that a high index of suspicion is needed. We need to stack evidence for and against the diagnosis of an implant or a prosthetic joint infection. identification of the organism is absolutely needed. We just cannot fashion empiric therapy without knowing what is the organism. Device removal is a drastic but ultimately necessary step in many cases. And the result is that the patient faces multiple surgeries, great expense, prolonged hospitalization, renewed disability, and even death. And for all these reasons, prevention is paramount. With this, I will stop my screen share and if there are questions or comments, hear them. I'm not very sure whether I have been audible all throughout, but if I am the...
Hello, I'm Dr. Wabe. I wanted to know what is leukocytes that you mentioned in your talk.
Can I stop? Yeah, now I can hear you.
Sir, what is leukocytes that you mentioned in your talk? Hello? I don't think he has been able to get it.
I'm not able to hear anything. Anyone there?
Yes, sir. So we all are here.
Now I can hear you.
What do you
Is there any question? Can I?
Yeah. Dr. Rajeev Soman, can you hear me? Dr. Rajeev Soman, can you hear me?
Sir, can you hear us?
Yeah, now I can hear a little bit. But I can exactly make out what he is saying.
Ask the question.
What is it?
Yeah, sir. Dr. Salve wanted to know what is the leukocytes which you mentioned in your talk.
What is the?
Leukocytes.
Is it leukotrienes? Is it leukotrienes? I don't know what.
L-U-C-E-R-I-D-S. L-U-C-E-R-I-D-S.
Sir, leukocytes.
I don't know what.
Hello? Dr. Soman,
Yes.
sir.
Yes, I can hear you now.
Yes, sir. How difficult it was to convey the message to the patient and the relatives that immediately within first few weeks of your operation, there is some infection in either in the joint or in the prosthesis. And what was the acceptance level of the patients? Did they change the team of operating surgeons or they continued the treatment with you only?
I am not the operating surgeon, so anyway, it is a little, it's a tricky thing to tell the patient how it is important to do the right, follow the right strategy, and possibly the patient needs a washout of the joint, a lavage, and culture and so on soon after an implant-related surgery. But I think there is a technique of telling them that you have a window of opportunity. If that opportunity is not taken, then there can be a problem.
Yes, that.
Sometimes the patients would return to the same operating doctor, and if the doctor is convinced, he will do the procedure. And we have had exceedingly good results with debridement and retention if it is done at the right time. And the organism is also fairly susceptible to something which we can easily.
Yes, that word, psychological barrier, was the perfect word as far as the conveyance to the patients is concerned. Thank you.
Sir, one question. Sir, are you able to hear me?
Yes.
Yeah. Sir, one question. There are many patients post joint replacements who definitely come with a visible swelling, pain, redness. But in those cases, probably because they are previously treated with antimicrobials, despite of joint aspirations, we get negative cultures, or even the cell count is inadequate. In these cases, what is the right way to go about? What is the role of PET, and what other diagnostic modalities will help us, sir?
I think I said most of the things in my talk, but again quickly. One is that the patient, it is very important that the patient should not be put on empirical antibiotics. There is no arm of that algorithm which is telling you that you can use empirical antibiotics without anything else as the sole strategy. So there is no such strategy. So it is very important to not to have antibiotics before. Now if somebody has already started antibiotics, then we should wait for 2 weeks at least. Okay, 2 weeks nothing major is going to happen. Right? So if we wait for 2 weeks, our chances of getting the organism is very good. Secondly, because this is all associated with biofilm, the inflammation is blunted, and therefore the cell count in the joint fluid will not be so high as in native joint septic arthritis. Okay, so much lower thresholds are there. But finally, the key is to find the organism there. And if you cannot find the organism by culture, this joint fluid panel is a new test which is we have found extremely useful. So these are some of the ways. Then you can also do whole genome sequencing or metagenomic next generation sequencing. Find those which are not being easily cultured or identified in other ways. So high tech is required to find those organisms in these situations. But the simple thing is this, that obtain good cultures, give an antibiotic-free period. I would even go on to say, and I tell my orthopedic friends, that when you discharge the patient, please tell them that if you get any pain and some redness or signs of inflammation, other doctors will tell you to take augmentin or some other drug like that. Please don't take that, come back to us and ask what is to be done.
Okay.
Because, see, any third party new doctor coming up, what is this part of this resistance? Okay, take linezolid, take augmentin, take something, and then let us know. Right? So that both the patient as well as the doctor, the orthopedic surgeon, should be convinced that that's not the right strategy to do, because we are hampering our own chances of a good cure for the patient.
Sure, sir. Sure. Thank you, sir. Any more questions from the audience?
Dr. Soman, sir, what is the incidence of infection in the post-prosthesis, and how many percentage of them they undergo arthrodesis or amputation in your experience? Because the orthopedic, they won't say anything right.
He will not be able to hear.
I think he could not hear.
Sir, can you come?
Or he has to talk on this mic.
Hi, sir. There was one question coming. Hi, sir. There was one question coming from the audience. So the question was, what is the incidence of prosthetic joint infections? Because the orthopedics are not very honest as per the questioner. And what was the second question, sir? So how many of these go for arthrodesis and amputation once the infection has come?
See, first of all, to tell you the two incidents, we will have to have a proper registry of all the joints which have been, or implants which have been placed. Unfortunately, that I am not sure such a thing exists. So you and me see only the patients who have infection. So that sort of keeps us busy. So there is a fair incidence, but we do not know how many more have been implanted, etc. So that actually needs a nationwide or institution-wide study.
Registry.
What is the proper incidence? Even diagnosis. First of all, to know the incidence, you may have the denominator. But how have you made the diagnosis of an implant or a joint-related infection? That diagnosis also has to be on a particular basis. Now, question was related to what was the final outcome. So the idea is to have a very good outcome, but if you have an elderly patient who's got a very bad infection, has a very bad organism, it is not very easily treatable with any oral treatment, but requires say only polystyrene, or say cetirizine, maybe pentam and astionine, or something like that. Now, if such a patient gets a recurrence after a new joint has been put in, then you can imagine the disaster which the patient is going to face. So in those situations, we make it very clear with the patient as well as with the orthopedic surgeons that if these being the circumstances, it might be a better idea to do approdesis where the joint is fused, no new foreign body is there, and therefore the chances of success are very good. On the other hand, for the hip, we can sometimes ask them to do a resection of the vertebral stone arthroplasty. So again, without any implant. In both these instances, the patient is able to be functionally reasonably well, especially if it's an elderly patient and has got a very bad infection with a highly resistant organism for which no easy oral treatment is available. The exact incidence, again, I would not be able to say, but these kind of answers can come only from a good registry.
Yes, yes.
So one last question. Where would you place ceftaroline in the management of prosthetic joint infection, sir?
So it's an excellent drug which can be used for MRSA infections, and therefore it will have a very good penetration into the bone as well as the joint fluid and so on. So compared to the glycopeptides, maybe it is a good alternative to use for MRSA infections. Yes. But after all, it is also expensive, very expensive, and I cannot tell you in what way it compares exactly with daptomycin or even with the glycopeptides. And for example, diclofenac is also a reasonably good drug for bones and joints. And that also is suitable to be taken once a day at home and maybe on an outpatient basis also. So a clear difference between these three drugs, daptomycin, ceftaroline, and one of the glycopeptides, especially glycopeptide, is not very easy to say which one of them is best. I think circumstances of the case and the cost, adverse effects, all these things have to be taken into account. But it's a very good new alternative.
And sir, one last question. Which drug for biofilm in cases of staph, MSSA or MRSA, in case the patient has a CLD, sir, now? In cases of chronic liver disease, sir?
Chronic liver disease?
Yes, sir. So we usually give
Sir,
rifampicin, whether you would use in these patients if the patient has a CLD and an MRSA prosthetic joint infection, sir.
Right. So rifampicin is often recommended to be used obviously it is in conjunction with other drugs. So it is best used probably with quinolones, sometimes with TMP-SMX, sometimes with clindamycin. But unfortunately in our country, quinolone susceptibility is so poor that that particular combination is not very easy to use. There has been a study called as the Ayesha trial, where they looked at rifampicin use in so they used it and found that it was not very highly beneficial. However, most of the cases in that trial were not having prosthesis. So that question is whether that Ayesha trial results can be applied to patients who have prosthesis is not possible to answer. So it will certainly have a role when the prosthesis is in place. A few caveats need to be just known in mind. I'm sure you know that it should be used only in company with another very effective drug. It should not be used right in the beginning when the organism burden is very, very high, because the drug will develop resistance immediately. The bugs will develop resistance very soon. Therefore, some other treatment is needed or surgical source control is needed to bring down the organism burden.
Thank you so much, sir. Thank you.
Thank you, sir. Thank you.
Thank you, Dr. Rajeev Soman, sir, for taking out the time and joining us over the Zoom session. Now we move forward.
महेश, एक बात बता, तूने कोविड का बूस्टर डोज लिया था क्या?
हाँ यार, वो तो कब का ले लिया. तूने फ्लू वैक्सीन ली है क्या?
फ्लू वैक्सीन मुझे क्यों लेना रहेगा?
So to actually know about the adult vaccination in special population, we have with us Dr. Kanishka Dawda, sir, consultant infectious disease specialist at Jupiter Hospital, Thane. Over to you, sir.
Am I audible? Now am I audible? Yes. Okay. So see, actually this presentation is for both of you only. Because you are extremely special. I can't think of anybody more special than Mahesh and Abhishek. Right? So let me just start. So how many of you have seen the movie Taken, in which this person is the main actor? Very few hands. So now I'm scared of this audience because you seem to be more studious than my other audiences. So there was one very famous dialogue which became a meme from this movie. So this guy was a CIA agent whose daughter was kidnapped in Paris. So he is speaking to the person who has just kidnapped her. So he says this dialogue. I don't know who you are, what you want, but what I have is a very specific set of skills that I have acquired over a very long career, and I will find you and I will kill you. Right? So instead of that, our goal from today's Jupiter inauguration of the vaccination program will be, we will find you and we will vaccinate you. किसी को नहीं छोड़ेंगे हम. Right? So, and we will be having the same fervor as if our daughter was kidnapped. So be very watchful. So with that, I would recommend everybody to watch the movie. If you take anything from today's event, it should be that you should go home and watch this movie. You will thank me later. So who is special? So vaccination in special populations. So who is special? So in terms of vaccination, any situation in which the vaccination may not give an adequate immune response, or a situation in which the vaccine may actually cause harm, is called as a special situation. So an immunocompetent adult, we don't have these two things. So immunocompetent adult will not be called as a special, whereas any person with an immune suppression will be called as special, because in that case the adequate immune response may not be there, plus the vaccine may actually harm the patient as well. So basically immunocompromised patients are called as a special populations in the terms of vaccination. So we kind of divided into pregnancy and other immunocompromised states. In the other immunocompromised states, we have the solid organ transplant recipients, the bone marrow transplant recipients, the patients of autoimmune disease on the immunosuppressive drugs, malignancies on treatment, and the splenectomized patients. So this is a broad groups which are called as special in terms of vaccination, where you need a slightly different approach to vaccination. So why is it important to vaccinate these special people? Because these are the patients with a higher risk of infection, including the vaccine preventable infections, and they are also at higher risk for the severe disease if it does occur, right? So imagine there's a HIV positive patient and you have not vaccinated him for pneumococcus. If he gets a pneumococcal pneumonia, and you can imagine how severe that can be, right? So this is why it's important to vaccinate these patients appropriately. So we'll go ahead. So now this is another phenomenon which we see in even the normal patients, but this phenomenon is accelerated in an immunocompromised patient. So what this graph is showing, firstly it's showing that Pfizer is useless. Secondly, it is showing that the decay is very high. Means by the 12th month, the efficacy of the vaccine has come to just 26% for Pfizer and 51% for Moderna, right? And this efficacy has dropped as the time has progressed from the time of vaccination. So this is called as a vaccine decay. Now this decay is accelerated in an immunosuppressed patient, right? Because they will have relatively poorer immune response. So you can imagine one more graph which is falling even more aggressively, right? So that will be the thing about the immunocompromised patient. That is why vaccination is even more important, and the timing is also crucial in order to maximize the immunogenicity and the efficacy. Ideally, you want to vaccinate when the immune suppression has not become too severe. Right? I will explain this a little later. So broadly, we have two types of vaccines, live and inactivated. The easy way to remember the 4 live ones. All other vaccines are inactivated. So varicella, your chickenpox, MMR, measles, mumps, rubella, your BCG, the yellow fever, and for all practical purposes, the live zoster vaccine, which goes by the brand name Zostavax. Nasal influenza is almost not used at all, so we can forget that. So varicella, MMR, BCG, yellow fever, and zoster vaccine. Not the new recombinant one, the older live one. So these are the live vaccines. These cannot be given in a severely immunocompromised state because the risk of vaccine-induced disease is high and you will cause more harm than good. And the timing is very important in these situations to prevent the vaccine-induced disease. Whereas the inactivated vaccines can be given safely in all the patients. All other vaccines are inactivated, your DPT and all those things. There is not much risk of, there is zero risk of a vaccine-induced disease. But timing here is also important. Here also you want to time it to the level of, before it gets into the severe immunosuppression, because the immunogenicity and efficacy is maximized. So I hope everyone got this table. So, it's, I found it easier to imagine it with this kind of graphic. I've created this. So a person doesn't go from normal to severe immune compromise very quickly. He transitions from mild, then moderate, then severe, right? So, जब वो ऊपर के part में है, that is the best time to vaccinate this person. And जब वो नीचे आ गया है, then you run into several problems. So when you are in the below part of the graph, the live vaccines are absolutely contraindicated. The inactivated ones can be given but won't be that effective. So that goes by a case-by-case basis. So all vaccines can be given in mild and moderate immune suppression. No live vaccines can be given in the severely immunosuppressed. And the inactivated vaccines ideally should be deferred till the immunity is back to at least moderate level, right? So, in the severely immunocompromised patient, we can consider something called as cocoon strategy. I will come to what that is a little bit later. So, and the other thing is, everybody is now wondering how to decide whether somebody is severely immunocompromised or not. I will come to that as well. So just to recap these basic principles, because everything ahead is just dependent on these 4 or 5 principles. So best time to vaccinate is when the immune suppression is mild or moderate. Live vaccines avoid when the immune suppression is severe. Defer the inactivated vaccines when the immune suppression is severe. Delaying of inactivated vaccine is from the point of view of augmenting immune response and not for safety concerns. Cocoon vaccination. So basically in this what you do is that suppose somebody has just undergone a kidney transplant 1 week back. Now this patient has obviously received induction immune suppression with basiliximab and whatnot, and he is severely immunocompromised. Now you can't give him any vaccination to protect him from anything, but you can vaccinate the people around him, right? So he will be surrounded by working people who will be taking care of him at home, who can acquire anything in the local trains or the buses, especially like common respiratory viruses, influenza. Imagine how scary it can be to get a severe influenza in an immediate post-transplant patient. So one of the best ways to protect him is to vaccinate all the people around him. So in a way, you are putting him inside a cocoon. So this is called as a cocooning strategy, vaccination of household contacts and the caregivers in order to protect the patient during this period of severe immune suppression, right? So this is something we can try to do, and it has been shown to be quite useful, and I think in our setting it will be even more useful. And the tests for protective correlates of immunity and boost as necessary. So once you give the vaccine, some of them have the antibody levels which we can check to see how effective the vaccine has been, and we should do that in some of the vaccines. So now, so when I hear about my crush's breakup, I remember Sholay, and I think that this is the best time to be opportunistic. So we have to be opportunistic while vaccinating people, and we have to be thinking like this as well. So जब mild to moderate immune suppression है, तो लोहा गर्म है, मार दो हथौड़ा, right? Now, so this is one example in the kidney patient how we decide whether something is patient is having severe immunocompromise or not. So this is given in the textbooks. So if the patient has end-stage renal disease, no urine output, is about to start, getting dialysis, then he is severely immune suppressed. And if he is immediately post-transplant up to 12 months, he is severely immunosuppressed. So before that, so somebody has come with a creatinine of 2, creatinine of 3, urine output is there, not initiated on dialysis, this is your golden opportunity. Because right now the patient has not gone into ESRD, the patient is not severely immunosuppressed, so all vaccinations, whatever you want to give, now is the time. Right? Similarly, in liver disease also, this sort of classification is given. And in the late post-transplant period, again, after 12 months, the patient goes into a slightly better immune phase. So that time you can give. Of course, the caveat is that the patient should not be having GVHD and on some augmented immune suppression for some rejection and all those things. So, so now what do we want to give in terms of vaccines? So the first 3 are actually kind of mandatory for all adults. Influenza annually, pneumococcal, and influenza is for all. Pneumococcal is for immune suppressed patients and adults above 65. And so pneumococcal conjugate and 2 months later pneumococcal polysaccharide is the standard protocol. For immune suppressed patients, all the 4 are compulsory. So hepatitis B, influenza, pneumococcal conjugate, pneumococcal polysaccharide. Then if there are some additional indications, like suppose somebody is having splenectomy or a sickle cell patient with autosplenectomy, then meningococcal will need to be given because of increase in risk of Neisseria, including the usual meningococcal ACWY and the MEN-B. MEN-B is not available in India as far as I know. And the hepatitis A if the patient is having liver disease or something like that. So the first 4 are mandatory in nearly all immunosuppressed patients. The next 2, meningococcal and Hep A, depending on spleen and liver disease. The last 2, MMR and varicella, are live vaccines. So you can give them in the state of mild to moderate if they are antibody negative. So most of the patients have received MMR and varicella vaccine in childhood. You check their antibodies. If the antibodies are negative, then it's a good thing to vaccinate them at this point. Because once they go into severe immunosuppression, getting varicella and something can be very life-threatening again. So in the severe immunocompromised state, no live vaccines, defer inactivated vaccines, and cocoon strategy. I've already gone through this. So a patient has come to you and you need to determine, you need to decide what vaccines to give. So try to assess his immune status, and this is the same flowchart that I've been talking. So vaccination in autoimmune disorders. Now in this, it gets a little complicated. So I go through it with a case, so it becomes easier. So 15-year-old girl has got SLE and has come with a autoimmune hemolytic anemia. Now she is planned for cyclophosphamide therapy in the next 7 days. So what should you do? So, right now she has come with just SLE, no steroids or any major things have been started. So is the immune suppression mild? So give all the vaccines, including the live vaccines? Or should we avoid the live vaccines since the patient is going to go for cyclophosphamide, which is severely immunosuppressing? Or should we do that? So if we do avoid the live vaccines, when can we give it? Right, so how long do we have to wait after cyclophosphamide? If you are planning to give the inactivated vaccine right now, when should you give it? So these are all very complex, they look very complex, but it will become simpler. And does anybody have any answer to this question? SLE patient with autoimmune anemia planned for cyclophosphamide within the next 7 days. Which vaccines should we give?
We give the inactivated vaccines, though I think that would be the best strategy to right now. Live vaccines we probably want to avoid because this is the time and every day is the hardly any antibodies that we talk right that and probably starting cyclophos because of the rapid deterioration maybe basically another 2 weeks time. So if we consider that 3 weeks is enough for getting a good immunity, using that may be useful. So good for the point of view of inactivated vaccines, but for live vaccines not taking option.
Correct. Absolutely right. Absolutely right. So even though right now she seems not very severely immunocompromised, she is going to get severely immunocompromised within 7 days. And if you've given a live vaccine just 1 week prior, and then you are giving a severe immunosuppression agent, you can be in a big problem. So when we determine the immune status, we don't want to just be illogical and think only right now kya hai. Try to think what it will be in the next 2 to 3 weeks, next 2 to 4 weeks, because your vaccine is going to take that much time to work. Abhi de diya ho gaya aise nahi hota hai. We need 2 weeks, 3 weeks to develop the antibodies. If you've given a live vaccine, the person has not developed good antibodies to it, and then you give him cyclophosphamide, you can imagine how problematic that can be. You may cause a life-threatening problem. So actually I've seen a case like this, which was described in a conference, ID conference. So patient was given varicella vaccine, and the patient did not inform the transplant team about it, then underwent a liver transplant. So vaccine was given around 1 week prior to liver transplant, varicella. And then he underwent a liver transplant in which all those heavy immunosuppression was given. Then he developed disseminated herpes and he was very sick. So I would call her severe right now, and I would avoid the live vaccines. In this situation, inactivated is a little bit of a gray zone. You may attempt to give it, and you may think that no, we can wait and give later also. So it's a little bit gray zone. Both choices are okay. You can go by case basis, and definitely we can go for the cocoon strategy also. Then ideal gap between the vaccine and the start of immunosuppressive drugs. Right, so other thing here can be, we can try to talk to the rheumatologist and ask him how how soon does he want to give cyclophosphamide. If he can defer it by couple of weeks, then we can very confidently give the inactivated vaccines, at least. And so communicate with the person, see whether he can wait, he can't wait, and based on that you can take a call. And suppose you have given the vaccine and he's saying, I want to start after 4 weeks. So you can give the vaccine. So based on the degree of immunosuppression that these drugs cause, you have put them in a descending order that way. So the more immunosuppressive the drug, the more you have to wait, the interval between the vaccine and the suppressive drug. So HCQS and sulfasalazine are not so immune suppressing, they are more modulating. So you can give them and the vaccine without any problem. Prednisone less than 20 mg per day, no problem. More than 20 mg for less than 2 weeks, again no problem. And if more than 20 mg for more than 2 weeks, then we will have to wait 4 weeks. So like that, you can see is the more immune suppressing the drug, the greater the interval needs to be. So suppose you chose not to give, and now she has received cyclophosphamide. So when to give after the drug has been given? So the duration again depends on how immunosuppressive the drug is. So after you have given cyclophosphamide and a patient has finished the course of cyclophosphamide, how long do we need to wait before we can give the inactivated vaccine and before we can give the live vaccine? So these are all standard things given in the books. You don't have to by heart. You just have to know and keep the data ready. So when the patient comes, you can just see this and go ahead. So the more immunosuppressive, the more you have to wait before you give the vaccine after the course is done. So now we come to a second case. This person was having pemphigus vulgaris and she was on rituximab. Last dose was 1 week ago, now referred for vaccine. What would you do? When can you give her the live vaccine? So same table. This time rituximab came into the picture. So we wait 6 months for the inactivated and 12 months for the live. And go ahead. Now, coming to the bone marrow. So just to summarize, so in autoimmune disease patients, yeah.
Quite a few of these patients are required to receive every 6 months.
Yes.
So how do you go about it?
Then you can't give. Then after the whole course is done, only then. So autoimmune diseases, this is the issue because the timing of their flares, the timing of their immunosuppression, the degree of their immunosuppression is all very variable and labile. Like in kidney transplant patient, you saw the table, it was very simple. ESRD के पहले mild है और transplant के 1 साल बाद mild है. So it was relatively easier. But ये patients में you have a very labile situation, so you need to be very careful. And you need to communicate well with the rheumatologist and do it this way. So in bone marrow, the principles are a little bit different. I'll just rush through it because it becomes too much. So the allogenic patient is considered immunologically naive. So he needs a full vaccination as if he has never been vaccinated, including all the other childhood ones, including DPT and all that. But again, we kind of measure the immunity based on the time from the transplant, if there has been no additional GVHD and all that. So first 3 months is considered as zero immunity. 3 to 12 months gradual immune restoration is happening. Inactivated vaccines, there's a full schedule which starts from the 3rd month and goes up to the 12th month. No live vaccines till 2 years. That is the rule here. Even after 2 years, no live vaccines if there is GVHD and patient is on some further immune suppression for that. Cocoon strategy, again, see, this patient is going to be like immune suppressed for almost a year. Right? तो यहाँ पे और भी ज़्यादा important हो जाता है कि family members don't get anything which is preventable. So better to do that. So this is the schedule for the bone marrow patient. Lots of numbers, not much point trying to remember it. But 3 to 12 months तक inactivated दे देते हैं, and after 2 years we go for the MMR and varicella. So the one interesting concept is the concept of donor priming. So bone marrow mein you are basically giving one person the whole immune system of some other person. So now that other person can be primed before the transplantation is done with the inactivated vaccines. So what happens is that the transplanted marrow has been primed with some vaccines. So that's been observed to facilitate and accelerate the immune response in the recipient. Right? So this is an interesting concept. So with
how much before would you like to do donor planning? How early?
So for a bone marrow transplant donor, he is basically a normal person. Your 2 to 3 weeks for the vaccine to become active or the antibodies to get formed well is enough. So uska apne ko koi tension nahi rehta, he is not immune suppressed. So we can vaccinate him immediately and plan the transplant at least 2-3 weeks after. Should be fine. Unless it's a very emergency thing, then it may not work. But if it's a little bit planned one, we can do it. So with that, I come to the end. I hope this has not been too dry after the dynamic topics by Sir. I tried to keep it entertaining.
It's good, easy probably in cases of renal transplant, but they are usually planned off, not very emergency. While liver transplants quite often come emergency.
Yes.
So would you recommend that makes the fully, even for the physicians, the transplant physicians or their team to have this yearly vaccination?
So influenza is all adults, anyway. So, and the transplant team, so basically you want to cocoon the people who are going to be with the patient for maximum duration of time. So the liver transplant team is going to see the patient occasionally in the OPD and then in the OT time. And obviously the transplant team should always be careful that they are not infected at the time of any surgeries. But cocooning the transplant team, I think would be a little overkill type. You want to cocoon the people who are going to be around the patient maximum.
I understand influenza vaccination yearly is a recommended thing across the world. Is it a good idea for Indian situations in terms of the costs involved for the whole country? Look at that. So recommending is very easy.
Yeah.
Look at from the cost perspective from the country. This is really advisable for everyone.
Yeah. So see, basically, even the people who are affording and are knowing are not doing. So that is a different this thing. In terms of purely medical advice, I would say we should do it because it causes. It's been documented to reduce. It has increased the economy of the countries because it reduces the time of absenteeism, admissions, and everything. And influenza, the other thing is that it actually prevents 3 things, not just influenza. Because after influenza, especially the elderly, they can get very bad secondary bacterial infections, pneumococcus, staph, aspergillosis, post-influenza. So especially in the elderly, I would say that it will actually end up being cost-effective. Because the number of admissions and the number of people who get, so to say, non-functional for that time period, it ends up being cost-effective. So, again, India is so heterogeneous that nothing applies to everybody. So difficult to say programmatically what should be the ideal thing. But in my view, at least the patients with diabetes, comorbidities, elderly, medical professionals, influenza is a must. Annual influenza.
What is the ideal time?
हाँ, तो उसमें controversy ऐसा है कि for us the influenza peaks during the monsoon, whereas for the Western world the influenza peaks during the winter. So what happens is that so influenza vaccine gets rejigged every year based on the prediction of the vaccinologists कि next year कौन सा strain आएगा उसका chances क्या है. So it's actually quite fascinating how they try to do that. And the first data for that.
Is it prediction or epidemiological studies in the last 6 months?
So I don't know exactly.
Different things.
I don't know exactly.
I think Kanishka, there are two, three things. In India, they also recommend probably not uniform timing period in India. And in southern India, where there is mostly predominantly more active, influenza is more during active period. So the ideal time is April, May or May, June. That's the ideal time. Probably in northern India, the timing is different when you live before the winter. So I think there are different timings in India, not
Correct.
uniform timings in India.
Correct. So there's no sort of consensus. Personally, I feel better to give pre-monsoon. But usually pre-monsoon, what happens is that we are giving last year's vaccine. Because the vaccine is created based on the Australian data, which comes around October, November. So many people think कि मैं को नया वाला strain लेना है. So, but then by the time they take it, all the peak is gone. They've already suffered from influenza without knowing it.
Also, the Singapore data starts with giving you what is the type of variety for that particular year. The Singapore variety.
Huh.
It comes plus.
Correct. Correct.
One thing I wanted to ask you about, you showed about the EMRDs being used in rheumatoid diseases. We could say it was not included there. So this is one of the 4 or 5 agents which are routinely being used. Okay, what is the thing you followed in the presentation is on pulse dose treatment?
Yeah, I think I seem to have missed it. It's there in the standard books.
Rheumatologists follow the why giving advice to patients to take it.
So that's what. So actually, when we were discussing this vaccination program and starting it in Jupiter, the first thing I had told Dr. Saraf was that if you really go by the guidelines, then practically every other patient who walks in needs a vaccine. So like in our case paper, there's a pre-printed treatment written. There should be a vaccination column as well. Because we are not in the habit of it. To get into a habit of it is going to take a lot of effort. So that's why I had spent almost half an hour, 1 hour explaining that we need to have this. So this is not the program. The program will be shared later, the Jupiter program. So we need to have the program in our head all the time. In a way, we need to be very down pat with it so that when the patient comes in, we don't have to think. It becomes a part of our muscles, kind of, when we write that. So we need to get into the habit. 200. About 200 you can give. Below 200, want to avoid.
And in post-transplant patient, you mentioned about 12 months we can give vaccination, but beyond 12 months, many patients are on more than 20 milligram of prednisolone. So in those patients, we'll have to postpone it?
Yeah, so they are on deflazacort. We'll have to calculate the equivalent of the prednisone and go by this chart.
What about patients who are on the high dose inhaled corticosteroids like duration at 400 micrograms per year or something? What are those in the previous? What about this?
So I think practically we can call them as systemic prednisone less than 20 mg per day. Like in this chart, I think it's not showing. So inhaled corticosteroids practically would be less than 20 mg per day systemic. So will not be considered as this thing, immune suppressing too much.
This would be the last question for the session.
Yeah. Yes. I am not aware, sorry.
Actually avoided COVID vaccination because still is the gray zone. Nobody is concerned about the future of those vaccines.
I think the general vaccines are boring enough without we getting into Covishield, Covaxin debates. So IVIG is a little bit like this, HCQS and sulfasalazine. They are immune modulators rather than suppressors. So no problems, we can go for the vaccines after that. Of course, that patient might never vaccinate himself again because he got GBS. Yeah, so basically immune modulating. So no problem with vaccine in that case.
Dr. Kanishka, could you elaborate on the new launch of the Shingrix vaccine, as well as second was the super accelerated regimen for hepatitis B vaccinations in patients with CKD and CLD?
So for the Shingrix, basically Shingrix is, I thought I had a slide here about hepatitis B accelerated schedule somewhere. I can't find the accelerated one. I'm sorry, I don't have it in my head. So Shingrix is a recombinant zoster vaccine, and it is for prevention of basically herpes zoster. So the strange thing is that varicella has 3 vaccines. One is the childhood vaccine, second is the live vaccine called Zostavax, and third now is the recombinant vaccine, which is inactivated. So the inactivated one has the highest efficacy, more than 99 or 98% efficacy. It's not come in India yet. It should be here by April is what the company is telling me. And it is again kind of for anybody above 55 and anybody with comorbidities even below 55. So that should be very useful because we see a lot of herpes zoster in the immunosuppressed patients, which ends up being very debilitating. So I think with that I'll stop because we need to get on. Thank you.
Thank you, sir, for the amazing talk. Now we have Dr. Amit Saraf, sir, for an announcement.
Thank you, Kanishka. He and along with Dr. Karnad, sir, had headed the local task force for Jupiter Hospital, and I think with his entire demeanor and attitude, you could see how he was chilled and calm during the entire 2 years of COVID. We had a good ID specialist who headed the infectious aspect with a very level-headed approach and a very cool thing. So I think we felicitate Kanish. Thank you so much. Dhanashri, if you could please give him a bouquet of appreciation. I think carrying on the tradition of felicitation, none of the event is possible till we have a good backup. I would at this point want to acknowledge and appreciate the support and presence given by Raphael Life Sciences, Mr. Daniel and his son Ronan Samuel are here. I would request both of them to come forth and accept a small little token of appreciation on our behalf. I request our august audience to please give them a big round of applause. The pharma industry always has been in the forefront, and they had an unrestricted educational grant to this event, and it's because of them that we're meeting, having lovely breakfast, lovely lunch, and I'm sure a good high tea at the end of it. So Dhanashri, if you could please, both of them, if you could felicitate on the department's behalf. Thank you so much. Thank you. I think we'll move on with the next session. There is over to Abhishek and Mahesh.
डेफिनेशन पता है क्या?
हाँ, पीओ का डेफिनेशन तो सिंपल है, फीवर ऑफ अननोन ओरिजिन.
भाई अगर ऐसा आंसर वाइवा में किया है ना, तो हमारे ओरिजिन का तो पता नहीं, हमारा एग्जिस्टेंस जरूर अननोन हो जाएगा.
So to give us a master class on PO, we have the master himself here, Dr. Dilip Karnad sir, senior intensivist and consultant, Jupiter Hospital.
Over to you, sir.
Good morning and thank you for inviting me. When Dhanashri told me, sir, will you talk on PUO? I thought to myself, good, 2 years back I had given this talk somewhere else. All my slides are ready. So no hard work involved. But then I must thank Dhanashri for asking me to talk on this topic, because there's a lot of new information in the last 2 years. Okay, I was surprised. There's a big review article of almost like 13, 14 pages in New England Journal of Medicine 2022. So if that journal thought it is worth revisiting this topic and devoting like 15 pages to it, it's something worth reading up about. So then when I started preparing my slides, I thought the best thing is to divide it into 2 parts. You know, what is old about PO, which is my last 2 years back slides, and then added something saying what is new about PO. So I think that's going to be the gist of my talk. How do you change? It's not. नहीं होता change. This doesn't change. This is the old definition. So it was first defined in 1961, and it included fever of 3 weeks duration, more than 101 on many occasions, no diagnosis after 1 week of inpatient investigation. Subsequently, as investigations got better, it was modified. So in 1991, no diagnosis after 3 days of inpatient investigation. In 2003, there was a debate about why 3 weeks. You know, why not 2 weeks or why not 1 week? So what they looked at literature and figured out that 75% of fevers, even if they are not diagnosed, subside in a period of 2 to 3 weeks. So there's no point wasting too much money, effort, and everything in investigating something which is going to disappear in a few days, even without treatment. So up to now, the debate is still not settled whether it is 2 weeks or 3 weeks. So most places still say 2 to 3 weeks without being dogmatic about one value. Also, with more investigations being done on OPD basis, the definition was changed, saying that at least 3 outpatient visits with investigation and no diagnosis, rather than several days of inpatient admission. Then, in the 20th edition of Harrison, 2018, this was the definition, okay, which said that immunocompromised patients are to be excluded because they need a different kind of workup. The second thing is, rather than quantitative criteria saying that no diagnosis in spite of 1 week of investigation, it came to no diagnosis in spite of a basic set of tests, okay? So what all do you need to do? Thorough history-taking physical examination and the following investigations, which are now called obligatory investigations. So you must do all these investigations in a patient with prolonged fever. After this also, if there is no diagnosis, then you can call it PO, right? So this is the list of investigations: CBC, ESR, CRP, creatinine, electrolytes, LFT, LDH, CPK, ferritin, some autoimmune disorders, ANA and RA, protein electrophoresis, urine culture, blood culture, and chest X-ray, abdominal sonography, and some tests for tuberculosis. Now coming to the classification of PO, in 1991 with the changing definitions also, it was classified into these 4 categories. So one is classical PO, which happens in outpatient setting. The second is nosocomial PO, which happens in hospitalized patients. So it was not there at the time of admission, but patients started getting fever after getting admitted for some other problem, right? So also fever has to be more than 3 days. So like we are looking at nosocomial infections, other complications which can happen in hospital, like deep vein thrombosis, thrombophlebitis, transfusion related, drug fever, and so on. And then there is neutropenic fever, which unless proven otherwise is to be assumed as infection. Right? So there is neutropenic PO. So even if you don't have a diagnosis, treat as infection unless proven otherwise. And lastly, HIV-associated fever, which again is a different set like, in immunocompromised patients. So again, why these so many definitions? So when 1991, Durack and Street gave their own new definition and classification, this was the justification that why do we need to keep changing the diagnosis. So imaging, which once upon a time was difficult, is now getting cheap, non-invasive and universally available, right? So with better imaging, we need to change the definition. Next is microbiology. With better culture methods, more of automated culture techniques and so on, more sensitive antibody antigen detection methods and so on, diagnosis of infections is getting easier. Again, collagen disorders, we know a lot of new antibodies keep getting discovered and are available all over the place. Similarly, diagnosis of cancer is getting easier. There are new predisposing factors, right? So nosocomial infections, neutropenic patients, HIV. Some time back, COVID itself became a predisposing factor for some new opportunistic infections, okay? And a lot of these tests are now were available on OPD basis. So that's the rationale for this. Now, also the changing pattern of PUO diagnosis, okay? So the 4 or 5 main categories of diagnosis in PUO. If you see the oldest series, a lot of these were infections, okay? So infections form the bulk of this, followed by neoplasms. Collagen vascular disorders formed only 13% because at that time, in the 50s, the ability to diagnose autoimmune inflammatory disorders were not such well defined as they are now. Most of them came into miscellaneous or undiagnosed categories, okay? And as you see, coming to 2018, Western countries, the diagnosis of infection is progressively becoming less, okay? And surprisingly, the percent of undiagnosed is increasing, right? So that seems paradoxical. As diagnostic facilities increase, why should undiagnosed increase? The reason is because the first 4 categories are decreasing over a period of time. We can diagnose those better. That is why bigger percentage of them are actually undiagnosed. It's not that, we are not able to diagnose in more cases. What is the situation in India? Again, so these 2 series were quoted in Harrison's textbook, which said in India, infections still form almost 50% of all PUO, okay? And 27% are roughly undiagnosed. Okay, so all this we know very well, so I'm just going to quickly go over this. So a variety of infections, especially localized infections, can cause PUO. These are the ones which are difficult to prove, right? It's not like typical URTI or pneumonia, which is easy to diagnose. These are the ones where infection may not be causing symptoms at the site of infection. For example, pancreatic abscess, prostatic abscess, perianal abscess, sinusitis, and so on. Then intravascular infections like bacterial endocarditis, vascular catheters, and so on. Systemic infections, there are mycobacterial, which are more of now atypical mycobacteria or non-pulmonary, extrapulmonary tuberculosis, some fungi, other organisms are listed there and so on. So this is the entire spectrum. Neoplasms, these are the ones which are common malignancies which are present in patients who present as PUO. So lymphoma, leukemia, we know that fever is a hallmark of these first symptom to appear. Can also be the case in myeloma, renal cell carcinoma, hepatocellular carcinoma, colon, as well as in atrial myxoma. Atrial myxoma actually is very much like infective endocarditis. So, in one of the older books, it said if you think it is infective endocarditis and all tests for infective endocarditis are negative, then maybe it's a myxoma. So you get fever, you get embolic episodes and everything else. Autoimmune disease, again, this is the list of causes which is put up there. And while many of them are easy to diagnose based on antibody, there are many of these for which there are no specific antibodies. For example, giant cell arthritis, aorta arthritis, and so on. So many of these are still missed, even though we can do a lot of blood tests for autoantibodies. Granulomatous disorders, so that's again a big group of diseases which are cause of PO. And a recent group of disorders is called the autoinflammatory disorders. So some of them are mentioned here. I'll deal with these in more detail later. These are miscellaneous causes. So I just want to spend some time on this because these are often easy to diagnose if you think of them. Okay? So one is factitious fever. So Harrison's textbook says very clearly that one of the reasons to hospitalize a patient is to document the fever. Okay? So on OPD basis, patient may come and tell you, I get fever which is 103, but is it really 103? So a lot of factitious fevers, the patients make the thermometer show a high reading. So you admit the patient, objectively somebody assesses, the nurse records the temperature, and a lot of times you will find that on admission during the hospital stay there is no fever. Right? So that is factitious fever. Drug fever. Drug fever is often associated with eosinophilia. It was interesting that how can drugs cause fever? So drugs can cause fever in 3 or 4 ways. Okay, one is a drug hypersensitivity kind of an allergic reaction. Okay, the other is the actual effect of the drug or a exaggeration of the effect of the drug. So we have serotonin syndrome, we have neuroleptic malignant syndromes. There is similarly an anticholinergic syndrome. So a lot of elderly patients are getting anticholinergic drugs for urinary frequency. So some of these can cause similar manifestations as with atropine toxicity. You know, it inhibits sweating, it causes high fever, it causes delirium, and so on. Then there are those drugs where you take the drug and within 2-3 days patients get a reaction, which is different. There are some which cause serum sickness. So the drug has been taken, after about 10 to 14 days patients get fever. And finally there is something called the DRESS syndrome, right? So DRESS syndrome is associated with eosinophilia, skin rash, liver dysfunction, and so on. So this happens almost 4 to 6 weeks after exposure to a drug. So depending on how much is the gap between drug exposure and the fever, the mechanism and the treatment may differ. Hyperthyroidism, this is something which is often missed. Patient has viral infection, thyroiditis, and then low-grade fever which goes on for days and days together. And then ultimately it turns out to be hyperthyroidism. Pulmonary thromboembolism is common as a cause of nosocomial PUO. Yeah, cirrhosis itself can cause fever. Even gout can cause fever. There are some of these which are less common, but again seen. So coming to an approach to PUO, again this is like what is old about PUO, right? Nothing new in this. So first is detailed history, which should include travel, hobbies, occupation, family history, exposure to animals, and so on. And physical examination. The purpose of physical examination is to localize the region in which we need to focus our investigations. Okay, so if there is one specific joint affected, we need to focus on that. If there is one specific group of lymph nodes, then we need to focus on that. If there is tenderness in the right upper abdomen, then that's the place to focus on, and so on. It's very important to tabulate all the investigations. Most of these patients, by the time they come to a physician, may have had a lot of sets of investigations done by multiple doctors and so on. So it's very important to chronologically tabulate everything and try to look for a trend. Review all the imaging which has already been done. Maybe it is worth having a second opinion on some of these imaging, because interpretation of imaging is often subjective, right? So a new person might see something which the previous person has not seen. If there have been biopsies, have them restained, seen by a new pathologist. And the other one is, as I said, observe the pattern of fever. A lot of times the pattern of fever itself gives a diagnosis, and hospitalize the patient to confirm if it is factitious fever. Increasingly, there is a tendency to use this term in all articles or chapters related to PUO. That is, look for PDCs. Okay, so what is PDC? PDC is potential diagnostic clues. So these can be of 2 types, right? One is localizing symptoms or signs, which I just talked of. The other is to look for typical patterns or findings. For example, if you have a patient who has, you all heard of relative bradycardia in fever, right? There is also this relative tachycardia, that fever is mild, but heart rate is 120, right? So tachycardia, tremors, increased appetite, so all of these can happen in hyperthyroidism, right? Then fever, arthralgia, genital ulcers, erythema nodosum, typically seen in Behçet's disease. Yeah, unilateral edema, painful inguinal lymphadenopathy, you can see this in filariasis, which can come and go for many weeks or months. Yeah, splinter hemorrhages, splenomegaly, in endocarditis, and so on. So look for these typical patterns or localizing manifestations. So new literature calls these PDCs. Okay, then coming to investigations, these are the basic investigations which we do initially. This is the set of investigations in the first column. If these don't show you diagnosis, then we go on to the next set of investigations, which is sending off autoantibodies, looking for some viruses, antibodies, sonography, chest X-ray, if not already done, and sometimes HRCT. And a lot of times in the olden days, the confirmatory test was to do a biopsy, right? So the various biopsies like liver biopsy, bone marrow biopsy, all these were considered as the diagnostic tests. So increasingly these confirmatory tests in new literature are looking for other antibodies, right? So there is this ANA blot which does an entire panel of autoantibodies. So there is no need to sort of think before, should I ask for this anti-autoantibody or that one? In one test you get everything. Then there is this mRNA or DNA RNA sequencing, which is like multiplex PCR. So we have tests like BioFire, which will look at like 20 different organisms in a CSF sample or a blood sample or so on, which has made diagnosis of infection much easier. Yeah, at times we need to do an endoscopy like colonoscopy to rule out ulcerative colitis or colon cancer or so on. So these would be the confirmatory tests. Okay, so next, a little more detail about imaging. Imaging would be ultrasonography of various regions like abdomen, pelvis, and this is the column on the right shows what are the diseases which we would detect by these. Then there would be a CT scan of the chest and abdomen. A lot of literature on radioisotope scans which use either gallium or indium. Then there are bone scans. So these are the various diagnoses which we can find by them. Echocardiography to look for pericarditis or infective endocarditis. And the new one is PET-CT to look for infections, malignancies, and so on. Finally, the last step in a lot of patients is to do a biopsy. So the purpose of all the previous steps, that is history, examination, investigation, blood tests, everything, is to help you decide what to biopsy, right? So which is the biopsy which is going to give you the best diagnostic yield? Is it a lymph node biopsy? Is it liver biopsy? Is it bone marrow or whatever else? So that would be the next step in getting this. So a lot of times you end up doing a skin biopsy. Rarely you end up doing a kidney biopsy if there's proteinuria and nothing else. Also in Western countries, in elderly patients, giant cell arteritis is very common, so they end up doing a temporal artery biopsy. Finally, a lot of data on older literature on therapeutic trials, right? So what is a therapeutic trial? So first is for drug fever, stop all drugs. Yeah. Second is antituberculous therapy. So antituberculous therapy trials should be done as a 4-drug therapy, not just 2 drugs or whatever. That will be a half-hearted thing. So you give the full treatment, look for adverse events, monitor weight, ESR, temperature, and not more than 4 to 6 weeks. If it doesn't respond in 6 weeks, looks for an alternative diagnosis. There used to be in older literature a test called the naproxen test. You give naproxen and the fever subsides. They said very high likely that this is malignancy. But this is also very effective in adult onset Still's disease, right? And then finally, therapeutic trial of prednisolone in the very elderly patients where it's a possibility of temporal arteritis or polymyalgia rheumatica, where there is a very prompt response. In a week's time, all the symptoms disappear. So that was what was there as a therapeutic trial.
What about anti-malarials in this perspective?
Yeah, okay. Yeah, good. So basically, malaria tends to...
Just smear is negative.
Yeah, so rarely malaria will cause more than 3 weeks of fever. Over a period of time, even if you don't treat it, the fever slowly tends to get less because of the natural response. But yes, if the pattern is very typical, there are periods of fever with afebrile period or alternate day fever, then certainly a trial of antimalarials. So if it is less than 3 weeks, then a trial of antimalarials is definitely warranted. If it's more than 3 weeks, maybe. Okay, so why is this so? So it says that PET-CT has a sensitivity in PUO of 86 to 98%. Wow, so that means if you do it on 100 people, almost 90 people it will show some abnormality, right? But then the question is, does it show the diagnosis? You don't want to know abnormal or normal, right? You know that this patient has fever, so there is some illness. Yeah, so the specificity is what is important. So specificity is less. It is in some series only 50%. In some it goes up to 85%. Its yield is 30% more than conventional CT. So it's much better than conventional CT. Okay, what does it detect? It detects inflammation much better than nuclear scan. So in one of my previous slides, there was gallium, indium, and then other bone scans. So technetium bone scans and so on. The purpose was to detect inflammation. So this one detects even better than that. So that's again a good advance. Okay. The yield is best for localized infections. So it's not going to be positive in malaria or typhoid. It's going to be positive where the infection is localized, say tuberculosis or abscesses or arthritis or something like that. So they said that one infection which is being diagnosed more and more is spinal osteomyelitis. Okay, so infection in the spine, which is detectable by other investigations very late, is picked up by this very early. So either it is due to staphylococci or tuberculosis or whatever.
Doctor, what about false positives in CT?
Yeah, that's what, no? So that sensitivity means it is showing abnormality.
Which conditions give
Yeah,
false
we'll come to that. Yeah, okay. So it's very good for chronic low-grade inflammation. Okay, and as I said, it is not going to give you a diagnosis, right? Except in a few cases. So for example, it is the only investigation which can diagnose aortoarthritis. Okay? By the time the arterial pulse is weak or something, it is advanced disease. Before that, for many months or weeks, the person is only going to have inflammation in the aorta and large arteries. There is no other test which diagnoses this other than a PET-CT. Okay? So it's very good for chronic low-grade inflammation. For all other disorders, it is a test to help you identify which is the site of infection. So from there, if it's an abscess, you have to drain it. If it's something else, if it's a malignancy, you have to get it on biopsy. So the main purpose of a PET-CT is to identify which site to biopsy or which site to focus your diagnosis on. Right? Okay. So this is a picture of a normal PET-CT. Okay? And I put this up to highlight what are the limitations of PET-CT. So first is there are certain areas where there is physiological uptake, which you can see on this, right? So if there is disease there, it's not going to be seen. So physiological uptake, you can see it in the brain over here. Okay, you can see it in the heart. You can see it in the kidneys, in the urinary bladder. Okay, so that's another picture in a different plane, which shows increased uptake in the intestines. Okay, and to some extent in the liver. So you may not be able to find out if there is a diffuse disease or even a localized disease in these specific areas. Similarly, in all patients who have had fever for more than a few days, the bone marrow shows increased uptake. Okay, so it's not like increased bone marrow uptake means that you should do a bone marrow biopsy. Any patient who has prolonged fever because of the inflammation, just as you get sort of, neutrophilia or whatever, leukocytosis, the bone marrow is going to be hyperactive. It shows more uptake. Other limitations are that it is costly and not widely available. So whenever it is costly, then we have to think twice, how do I use it most cost effectively? So the question to you is, would you do a CT scan of the chest and abdomen first and then HR-CT, or would you do, and then PET-CT, or would you do PET-CT first? Okay, so people have done kind of analysis of this, and the Harrison's textbook now says in the latest 2022 edition that the PET-CT is most cost effective. It is done before other types of CT, because anyway it includes CT. Instead of giving IV contrast, you give radioisotope. Okay, and this radioisotope helps you localize inflammation, infection better than IV contrast. So the best time to do it would be when you're thinking of doing a CT of abdomen and chest without there being a identified focus. Like if the chest X-ray shows you there is a hilar mass or something, then you don't need a PET-CT, right? You can directly go ahead with a chest CT. But if you don't know where the disease is and you want to find it, then this would be a better thing than doing the other. There are patients who have fever for a few days, then they are afebrile for a few days, fever again for a few days. So they've found that the yield is higher if you do it when the patient has high fever, high ESR, high CRP. Okay, so at that stage a PET-CT is going to be positive more often than if you do it in the intervening period when the patient is relatively less symptomatic. And lastly, if your patient is on steroid for any reason, then you get a false negative. So there may be a lesion somewhere, there may be abscess somewhere, but the PET-CT may not show it if your patient is on steroids. Okay, so few other new things. Okay, so there is this thing of IUO, or inflammation of unknown origin. Okay, so Harrison's textbook says it is the same as PUO but without fever. So there will be normal temperature but very high ESR and CRP, which is found on multiple occasions. It's lasting for at least 3 weeks or more. And the workup and management is same as PUO. Okay, so PUO includes fever more than 3 weeks or inflammatory markers elevated more than 3 weeks. The workup is the same. Next is, as I said, the number of patients with fever of unknown origin is decreasing. Right? So, I was just thinking to myself, so now it is more like fever of well-known origin, that we are able to kind of identify and diagnose so many of the things which we know are common, that the undiagnosed patients who last for 3 weeks without a diagnosis is reducing. As a result, the percent of undiagnosed PO, the last category, is increasing. So in Western countries, up to 50% are undiagnosed. The proportion of infections causing PO is less because of better molecular diagnosis by RNA and DNA sequencing. There is less need for hospitalization. So most of these things are now done on OPD basis. So now hospitalization is advised only for those who are unstable or who have a worsening clinical condition under your observation. Also, it is now possible to observe patients for longer period of time on an OPD basis. So there is no hurry to run after a diagnosis if your initial set of investigations don't give you a diagnosis. So there is this concept of recurrent fever. So recurrent fever is one with fever-free period of 2 weeks or more. Okay? So these patients often have 5 months, 6 months of fever, afebrile periods in between. And more than 50% of these will have no diagnosis. There is also this concept that if there is fever for more than 1 year, then it's not going to be a malignancy. Okay? Less likely to be infection, less likely to be malignancy. Okay. So which are these which are causing recurrent fever? So the 3 common conditions are these: vasculitis, okay, out of which the ones which are often missed is what is called allergic or urticarial vasculitis. The other is granulomatous disease, and the third is autoinflammatory disease. So what do you do for these patients? Basically reassess every 3 to 4 months. Okay, it is debatable whether you need to do a repeat biopsy. You've done one biopsy of the lymph node, it's not shown you a diagnosis. The question is whether you do another biopsy. Probably not, unless the clinical picture changes. Okay? So increasingly in Western data, those 50% who have no diagnosis are now being diagnosed to have this particular disease called autoinflammatory disease. So how is this different from autoimmune disease? Okay, so autoinflammatory disease, so whenever there is infection or exposure to a pathogen, there are two types of responses. One is called innate response, one other is called adaptive response. So innate response is like when a pathogen invades us, you know, the antigens are identified. I think you'll have to do it. So it's like neutrophils, inflammation, recognition of endotoxin, and so on, right? And there is the adaptive response. So the adaptive response is mediated by our immune system. That means lymphocytes, which includes antibody cell-mediated immunity. So a disorder of the adaptive system is autoimmune disease. So SLE, rheumatoid arthritis, and all the others are autoimmune diseases of the adaptive system. The newly diagnosed group of disorders, autoinflammatory, is a disorder of the innate system. Okay, so it's a disorder of neutrophil function, pattern recognition, receptors, for example, endotoxin. So up to now, more than 40 such disorders have been identified. The first of these was familial Mediterranean fever. We have been reading about this for the last 25, 30 years. Nobody knew the cause. We all knew you give colchicine and it goes away, right? So now they have identified that these patients have a defect in what is called the pyrine pathway. Okay, so the pyrine pathway is one of the pathways which is activated by bacteria when they interact with the neutrophils. So because of this defect, the pathway gets activated on its own, right? So that was the first one to be diagnosed. Now there are more than 40 such. So some of them fall into these other groups. Okay, they are also called inflammopathies or inflammosomopathies, right? And these are IL-1 mediated, IL-18 mediated, interferon mediated, and so on. So increasingly there is a group of specialists called clinical immunologists. So clinical immunologists' role is to diagnose immune deficiency as well as immune dysregulation. So they are the ones who identify this. So certain mutations in gene cause deficiency, in certain other mutations cause excessive inflammations. Okay, like these. Okay, so so coming to my last slide, this is the concluding paragraph from this review article from NEJM last year. Okay, I have highlighted some text which I am going to read. It says advances in molecular diagnosis such as DNA or RNA sequencing can rapidly detect multiple pathogens. Okay, then there are ways to detect host response biomarkers using genomics, transcriptomics, proteomics, metabolomics, which is what basically these autoinflammatory disorders are, may one day alter the diagnostic landscape of FUO, eliminating the need for sharp clinical acumen to diagnose challenging cases. The last part, it says, as the ability to diagnose FUO shifts from clinical judgment to molecular diagnosis, the field of FUO may one day enter the realm of precision medicine or perhaps even become completely obscure. That means more and more of these so-called undiagnosed are being identified as disorders of autoinflammatory disorder group. Thank you. Three same day is good enough. You know, you can keep a gap of 30 minutes to 60 minutes between samples, and preferably from different sites, you know. So.
About ANA immunoblot study, you said one patient of mine had ANA was 120 positive and immunoblot was all negative. So
okay.
Can you explain this?
Yeah, so a lot of times ANA is positive in a good percent of healthy population. So it gets confusing only if it is positive in a patient who has fever or symptoms. You know, a lot of times if you do it After the patient has recovered from whatever illness, it still remains positive. There is no manifestation of inflammation, so ESR, CRP remain normal. So then we don't need to follow it up. Yes, sir.
Very exhaustive presentation. You made a passing reference to adult onset stills.
Yeah.
Recently, I have come across two patients who were diagnosed after exhaustive investigation because it doesn't have a diagnostic test.
No.
Secondly, this Hashimoto's thyroiditis causing fever. Can you just say something about these two things?
Lot of these disorders, the diagnosis is based on the clinical picture. Like, if the disease goes on for a long time, you don't get a diagnosis. As I said, the response to anti-inflammatory drugs is very dramatic in patients with adult onset Still's disease. So you can do that and see if it keeps coming back, then maybe you can put some patients on steroids or go on to the next level of treatment and so on. Yeah, it is an anti-inflammatory, so it will work.
Elevated ESR will be into JS now, but now suppose somebody is doing routine testing and ESR is high, they are supposed to investigate like the weight scale and everything.
See, it's to be seen in the clinical context, no? So you wait, you wait for 3 weeks, you see if it is just an incidental finding with no other symptoms, if there is weakness, weight loss and other things, then you would definitely investigate fever or no fever. If it is just an incidental finding, you follow up. A lot of times you don't get the full-blown picture or even other manifestations for some time. And while you wait, the trend may be downward, so then you can probably not investigate. Yeah, but if it is like 90, 100 all the time, it is worth investigating. Yeah, it's worth.
I had a case of malignancy of the peritoneum in my house.
Okay.
And it only showed persistent high ESR. And we just waited, the ESR is high, we repeated every time it will come there. And ultimately, with the immunochemistry done, it turned out to be peritoneal disease.
Okay.
About the obligatory investigations, you have not mentioned about the rickettsia.
This will be the last question for this session.
Yeah. So in it depends, of course, on the clinical situation. If you have a patient with fever and rash which is going on, then certainly rickettsia have to be looked at. Yes. I think Kanishka is the right person. He knows everything about IGRA. Anybody knows, Kanishka knows. Come. Okay, so simple thing. If a patient has anemia, I would rely on the CRP. Yeah, if there is no anemia, then I think both of them will be equally useful.
So I'll just answer quickly about the IGRA. So IGRA and TST is obligatory more from the Western point of view, because so that is because TB is not endemic in that area. So finding IGRA or a TST positive means it's a big thing, because they treat the latent TB also and follow it carefully and all that. For India, I think for PUO patient, TST IGRA is not very relevant. We'll get too many false positives and can't really take any action on it.
Thank you, Dilip Karnad sir, for the amazing session. Now I would like to invite Dr. Javal Bhatt sir to kindly felicitate Dilip Karnad sir.
Thank you, sir. It's always a pleasure to listen to sir. We still learn from his lectures. I think, as I said in the beginning, in the morning, that we're doing this, to launch our adult vaccination program. And for that, we have in-house a very important guest today, the Group Chief Operating Officer of Jupiter Group, which is Thana, Indore, and Pune, Dr. Shilpa Tatke, Madam. I would welcome her with a big round of applause, please. I would request her to come onto the stage, and I would request my entire department, Dr. Dhanashri, Dr. Kanishka, Dr. Yogita, Dr. Javal, to please come up. We have a very small, just a ribbon sort of cutting, so to speak, of the vaccination booklet. And then we've also arranged, thanks to Madam, to keep these vaccination booklets onto the registration counter outside. On your way out, hopefully by post-lunch, we'll have to have some numbers outside on the registration desk on your way out. Maybe you can grab a copy. Most of the talks which Kanishka and everybody have been speaking have been compiled in this passport. If you go through every page, the dosages, indications, the duration of each dose apart is all given. So I think on the way out. So please, Madam, everybody onto the stage for a quick opening of the book, launching of the program, and then 2 words by Dr. Shilpa Tatke, please. So I think everybody, the entire department, this is my team, ladies and gentlemen, they have been behind this entire program. I would wish to give them a big round of applause. Kanishka, Dhanashri madam have been working very hard to get this program launched. I would request madam to please just open the bow. So it's very simple. The booklet is shaped like a passport, and we keep it with a pamphlet. The pamphlet is mostly for a common man. So when a patient comes in, he can pick it up from any cluster. As I mentioned, from the ground floor to the top floor is available at most of the clusters. Pick up the pamphlet, pick up the passport, study it, go through it, and then come back to the physician for vaccination. So Dr. Shilpa Tatke, madam, a few words, and thank you to the department. I would request everybody to take a seat, and madam, a few words, please.
Good afternoon, everybody, and welcome once again. First of all, I would like to congratulate the Department of Internal Medicine for taking this initiative. I must say that adult vaccination is not something which is very new to us, and still, surprisingly, a lot of lack of awareness. Incidentally, I was just reading post-COVID with one of the hospitals in Mumbai, and they were thinking of launching adult vaccination center. And I was like, why? Why there is a need for a separate center? And to my surprise, I came across one survey wherein only 31% adults across India had received some or other kind of vaccination in the past 5 years. Now, when Corona and pandemic we all have faced, we all have realized the importance of vaccination. So after that, I think each hospital, each one of us will take it up as our own initiative, and we will spread internally. So I will not stop you from getting into the further enriched sessions. I'll welcome you once again, and thank you all. Thanks for giving me this opportunity.
The vaccination passport is basically me and Dhanashri, we went through all the CDC guidelines, WHO guidelines, Indian guidelines, and we have kind of simplified it quite a bit and sort of homogenized it and made it extremely simple to use. So I'm sure you'll find it useful.
Thank you, sir. Moving on to the next session. यार अभिषेक, जब से मेडिसिन में आया हैरिसन के अलावा कोई बुक ही नहीं देखी है यार.
जैसे मेडिसिन में आने से पहले तुम बड़े शेक्सपियर पढ़ा करते थे.
यार मैं सोच रहा था कि अगर शेक्सपियर ने हैरिसन लिखी होती तो उसमें एक चैप्टर होता क्या, टीबी और नॉट टीबी, दैट इज द क्वेश्चन.
बिल्कुल होता. एंड टू सॉल्व दिस डिलेमा ऑफ टीबी वी वुड लाइक टू इनवाइट ऑन स्टेज वंस अगेन डॉक्टर कनिष्का दावड़ा सर. ऑन टू यू सर.
Hello once again. Yeah, so molecular diagnosis of TB. So a lot of new things are there here, and a lot of these things are not given in a simple fashion anywhere. So I've made a lot of diagrams and all that to make that easy. A lot of this I learned during my ID fellowship in Hinduja. So a lot of that is derived from there. None of this is completely mine. So we'll just start with a couple of very interesting cases which will illustrate the principles easily for you. So this was a young lady with a fever, weight loss, night sweats since 1 year, and a low backache since 5 months, and right leg tingling and numbness since 5 months. So the MRI was done, which showed this kind of intraosseous enhancing abscesses and marrow edema in the sacrum and the right iliac bone, and some pre-sacral abscesses, and an enhancing abscess in the gluteus maximus muscle. So in our country, when patient is having fever more than 2 weeks, 3 weeks, and this weight loss and anything else, any other symptom, we think of TB only. And we thought of it, the abscess was drained, we got this. Right? So now I want you to pay attention to this gene expert report. So on the top you can see it's saying MTB detected, low, and then it is saying RIF resistance detected. And we'll come to the subtleties of this a little later. I just want you to see that these are the probes and this is the analyte result. Just cast your eyes here. So you can see probe D positive, probe C positive, probe E positive, probe B positive, and probe A negative. Forget SPC for now. Probe A negative. So what is the meaning of this? I will tell you. So based on this report, obviously we could not give her first line therapy. We gave her second line, empiric second line AKT. And 1 month later, the TB culture came positive. So now we did the DST from the phenotypic DST from the culture sample. And to our surprise, we found this. Right? So just to remind you, it came resistant on the gene expert. Then the culture came positive. We did a phenotypic DST on it, the conventional DST, and it has come sensitive. So the very first learning point for you here is that don't go blindly by the gene expert. Always send the culture, because you can have these kind of things. Right? And so in this, we were lucky that she was on second line and she came sensitive. So the second line would work for a susceptible bug. But if it is the other way around, then you are in big trouble. Patient, if the gene expert is inaccurate for some reason, has called it sensitive, but is actually resistant, and the patient is on first line, the patient will not improve. So first lesson from this case is don't rely entirely on the gene expert. Phenotypic DST is still the gold standard. In TB, the patient is going to receive 9 months to 1 year depending on the site of infection. So don't skimp on the culture and thinking of cost and all that. Because the patient is going to take toxic drugs for 1 year, 9 months. You want to be sure that they are working. You don't want to give toxic drugs with side effects and not know what bug it is, whether it is sensitive, resistant. So always, if send the culture, send the gene expert. After the culture comes positive, send the DST. You may get the discordant results. And the whole crux of the topic later on in the presentation is why the discordance occurs. What are the principles of the tests, right? So now we shifted to first line. So based on this, she was on second line. We shifted to first line, obviously. But we kept the levofloxacin on because this was some confusion whether rifampicin will really work or not, because this was a discordant result. Second reason was that since the response had not been as much as we would expect, we wanted to do the drug levels. So this, doing the rifampicin blood levels, is a test which is available in Hinduja and many other labs now. It is not too expensive as far as I remember, and it helps in such kind of situations. So now we did the levels. You can see that the reference range given for rifampicin levels is 8 to 24. But we had a level of 3.7. So despite weight-based therapy, the rifampicin level was inadequate. so was the INH level, right? So since we had subtherapeutic levels, we increased the doses, but that won't happen instantaneously. So we continued the levofloxacin for another couple of weeks, and we did the levels again after 2 weeks. So once that second level came back as normal, then we took off the levofloxacin. Because see, effectively here, if rifampicin and INH are subtherapeutic, the patient is on only 2 drugs, pyrazinamide, ethambutol, if you take off the levo right now. So to prevent this, so one of the tenets of TB therapy is always be on at least 3 drugs, otherwise there is more resistance. So that's why we kept on the levo, and then later on, once the drug levels were good, we took off the levo. Now, she is currently doing very well on first-line AKT. In fact, she improved and did well. Just to summarize, this is the first case. The gene expert showed resistance, but the DST showed sensitivity. That is the basic thing, which is important for the molecular part. Now we'll go to the second case. At least 2 weeks. No, that there is. So see, rifampicin INH you are generally giving in the morning, and so there are different ways. Some people say you can take it together. Some people say take it 1-2 hours apart. So drug level has to be based on how you are taking it.
Sir, we want to take the questions at the end of the session.
Yeah, we can do that because otherwise we will not finish the topic. So this second case, this was a young lady, 5-year-old lady or girl, came with moderate high-grade fever for 1 month, decreased appetite, generalized weakness. So she was treated as enteric fever based on a positive Vidal, given multiple antibiotics, but did not respond. The fever persisted, so gastric aspirate was sent for gene expert, which came this way. So you can see it is showing MTB detected, very low, rifampicin resistance not detected. Right? So based on this gene expert, you would start the first line therapy. Unfortunately, she was not very adherent, and then she worsened. She became hypoxic, so CT was done, which showed miliary nodules and a calcified subcarinal node. And then she came with seizures finally to Hinduja, and the MRI showed these ring-enhancing lesions. You can see lots of multiple ring-enhancing lesions. And so DEXA was added because CNS involvement was found. And with that, the fever responded. And another gastric aspirate was sent for culture, which came positive. Now, just so you remember, the gastric aspirate earlier had shown sensitivity. And now this culture is grew, and we did the phenotypic DST, and here you see absolutely opposite finding. Right? So this kind of discordance can be there, and the phenotypic DST is the gold standard. So we have to follow what the DST, phenotypic DST is showing. If there is any doubt, if there is any discordance like this between the genetic test and the phenotypic test. Now, reasons I will come to why this is happening. So these are 2 cases where you saw discordance. In the first one, you saw that the gene expert showed resistance, but the phenotypic showed sensitive. In this one, you are seeing opposite. The gene expert is showing sensitive, but the phenotypic is showing resistant. So this again highlights the importance that we need to do both tests in most of the patients, all patients, if possible. Don't skimp on it, because the treatment implications are truly massive, right? So this is just a summary of that part. Now we come to the why this happens like this, right? So basically there are the genome of TB has many regions, and so the the regions which code for resistance to a particular drug are usually concentrated in small segments of that genome. So now rifampicin resistance is coded by the gene called RPO beta gene. Now RPO beta gene is a small segment of the whole genome of TB, but almost 95 to 98% of the resistance to rifampicin is coded for in this region called the RPO beta. So now, so what happened earlier, that when we started this Gene Expert and all, these are basically probe-based assays. So what they used was that they taught these molecular probes how does the normal TB look. Right? You can see the below part of this thing here. You can see probe A, probe B, probe C, probe D, probe E. Right? So ये सारे probes को कंप्यूटर्स ने सिखा दिया कि नॉर्मल टीबी कैसा दिखता है. नॉर्मल टीबी मीन्स सेंसिटिव टीबी कैसा दिखता है. So then these probes, so when you take a sample and you run the Gene Expert on it, so basically the machine puts in the probes into the sample, and then the machine analyzes whether the probes have bound to the TB genome or not. So the probes are designed to bind to sensitive TB, right? So if any probe does not bind, what it means is that that region is not a normal region, that is having some mutation. So this is the basic thing, right? You understand, the probes are designed to bind to the normal TB. If any of the probes does not bind, that means there is some abnormality in that area. So if any probe is not binding, then the machine gives the reply probe E. So like I showed you in the first case, probe A absent. So rifampicin resistance detected. So this is how the Gene Expert functions. This is a very basic thing. And forget the upper part for now. Just try to understand the lower part, how the Gene Expert works. So like see, in this, none of the probes are binding. So it will say, the machine will say MTB not detected. So you've sent a good sputum sample or a good ball sample from a patient, right? You put that sample into the Gene Expert cartridge. Now the probes are trying to bind to TB. They are not able to bind. So only this SPC primer is there, which is a standardization thing. None of the probes will bind. So this will be the machine report saying MTB not detected, right? Now see what happens when MTB is detected, but RIF resistance is not detected, right? So now you have taken a ball sample, you put it into Gene Expert cartridge, all these probes are going there, and if they bind, they release a light which is detected, and then we can see this. So if more than 3 or 4 probes bind, then it says MTB detected. And if all the probes have bind, then it will not call it resistance, because it is all the probes have bound. So that means that all the segments of the DNA were normal, right? So this is how the graph will look. All the probes have bound, so RIF resistance not detected. Now this is what happens when the RIF resistance is detected. So you can see that this green probe, probe B, did not bind. So it did not create this graph. So all other probes have bound, but this one did not bind. So there is some mutation in this probe B area, which is coding for resistance, right? So now forget this part, it is not very important. So now, like I told you, there is a segment in the genome called RPO beta, which is responsible for majority of the resistance, but not all. So this is the reason what we saw in the second case. So Gene Expert called it sensitive because that RPO beta did not have any mutation. But the phenotypic DST picked up a mutation outside the RPO beta region, which is coding for resistance. That is why the phenotypic DST came resistant, but the Gene Expert came sensitive. This is the mechanism for that discordance, right? The Gene Expert is checking only RPO beta region. There can be mutations outside the RPO beta which code for the resistance. That is why you can get this discordant result. That is why you need to do the both of the tests, right? Now, coming to the second case, sorry, this was the first case where the gene expert called it resistant, but there was no resistance on the DST. So sometimes what happens is that there are some mutations on the genome, and but they are actually silent mutations. It is just a small change in the nucleotide, which is not actually coding for resistance. But the probe is designed to bind to absolutely normal. So probe will say कि यहाँ पे तो कुछ है. So the expert will call it resistant, but the phenotypic DST will call it as a sensitive. So this is the mechanism behind the first type what we had discussed. The first patient, the sacral abscess. So this is the basic reason behind how this discordance develops. So there can be mutation outside RPO beta, or there can be silent mutations within the RPO beta, which can cause this kind of thing. Third explanation is a dual population, right? So I don't want to get into too much of the complexity, but just wanted to give you a brief idea about the mechanism. So we'll go ahead quickly. So, yeah. So the same thing in the second case, what happened, I've explained. So now, after this basic of the gene expert, so the advantages and disadvantages of genotypic and phenotypic I've just summarized in a simple manner here. So the biggest advantage of genetic test is there's a quick turnaround time. So if a patient is having CNS TB and his gene expert is negative, means doesn't pick up anything, and you have to wait 6 weeks for the culture to come positive and then decide therapy, then you will be in trouble. The disadvantage is that it may pick up mutations which are not actually important. And the disadvantage of the phenotypic, already we know it is slow turnaround time and all that. Yeah. So now, coming to the line probe assay, this part is a little complicated, but basically it functions like the gene expert. Now you can see the above part. So line probe assay can be done on the smear positive samples only, not the naked samples. So it has more primers. So like the gene expert had 5 probes, this one has more probes. Then it has probes to check for some canonical mutations, what you call it. So let's not get into the details of that, but the implications are very important. So this slide is taken from Dr. Camilla. So based on the LPA findings, the second line therapy can be fine-tuned very well based on this chart, right? So there are certain mutations in which certain other medications are much more likely to work. So you don't have to wait for the phenotypic DST, which may come 2-3 weeks later. So just based on this genetic test, you can fashion a very, very effective second line regimen. So this is the importance of the LPA. I don't want to get into the too much of this thing. So now both of these were probe-based tests, right? So they are having certain areas of the genome where they are concentrating. The probes are binding based on whether sensitivity or resistance is there. The last one is called as a sequencing-based method. So this is relatively new. So this is called as a pyrosequencing. So here the whole body of the genome is analyzed, not just a small section like we found in the previous 2 tests that we do. So here entire genome is sequenced, and we can find out which exact mutation is there, what is the significance of that mutation, whether it is silent or not. Everything we know from this. And it is a very sensitive test for TBM. It's probably the most sensitive test, even more sensitive than the culture. So that's practice changing, because all the old-time practitioners must be knowing TBM is most of the time you don't get a confirmation. Even after the gene expert, we almost still never get a confirmation. But the pyrosequencing has changed all that. So there are many papers Dr. Camilla has written which showed that it is sensitive, more than 90% sensitive for TBM. So this was definitely practice changing for me. And the other thing is that TBM, again, you are committed to minimum 1 year of treatment if it is sensitive, and 1.5, 2 years of treatment if it is resistant. So the initial cost is absolutely, I wouldn't think it is too expensive, because you are going to give therapy, toxic therapy for 1-2 years. So if you know sensitivity, you can avoid so many problems. So I would not be afraid of using it, even if it is a little expensive side, because the advantages are really far greater. So in cases of this, the last 2 cases that I discussed, where the genotypic test showed something else, phenotypic test showed something else, that pyrosequencing can help us to decide what is truly happening, because it gives you the exact this thing. It also helps the WHO to set the critical concentrations. So based on pyrosequencing, in fact, the phenotypic DST critical cutoffs were modified for some of them, and they are getting modified probably in later date also. So when the RIF resistance is called as indeterminate on the expert, again, this can come in helpful to clarify. So just to give an overview, this was one of my patients whom I had done this test because there was big confusion. So this is how the report comes. So it checks all the mutations over all the areas, and then it gives a report like this. So this test is done in Hinduja. If anybody ever wants to send it, you can communicate with them and they will do it. It's run about once a week, but it's extremely useful in cases of discordance that we discuss, plus in TBM. So this was a poster I had presented in one of the conferences, the same concept that we discussed of the silent mutation causing a discrepancy between the gene expert and the phenotypic DST. Right. So with that, I come to the end of my talk. I hope it was not too complex, boring. Any questions?
What is the cost? Can you just give us an approximate idea of the cost of
the pyrosequencing? I think it's around 6,000 to 8,000, rough. Yeah. Yes. Yes. No, so if patient has come with high suspicion of TBM, then I send the first CSF that we do, I send it. So lymph node TB, actually there is still a controversy whether we can use it or not. So pyrosequencing has been more for pulmonary and CSF for now. Baki sub sites ka it's still under investigation whether we can use it. Urinary tract also, so urinary tract, what happens sometimes it picks up some things which are not really there. So urinary may, in fact, it is kind of from personal experience also, and from the data also, they're saying urinary ke liye don't use it. Yeah. So PCR basically is, hybridization technique is used. I don't know the details of that, but that is actually the technology which is used even before gene expert. So it is only for identification, and every institute have their own PCR. So that is only for detection. It will not give you sensitivity. So gene expert and pyrosequencing and line probe assay, they give you sensitivity and detection. PCR is older technology. Not many people are using it nowadays. Hybridization method, different than the pyrosequencing. Yeah, so LPA is validated only for smear positive samples. So directly when you send sputum, you don't know whether it is smear positive or negative, you can't do it. If it comes smear positive, then you can do LPA. Yeah.
I have a patient of gland TB, hepatitis, and he is sensitive to rifampicin.
Yes.
Gene expert.
Yes.
But he is not responding to the gene. years of antibox.
Correct. So gland TB, the thing is that how do we judge whether he is improving or not? So if he has come with a fever and the fever has gone, then that is response is enough.
No, but he's got glands.
So glands may stay.
Necrotic glands, sir.
So glands, the thing is that the glands may stay despite all the germs inside being dead. So you, most of the time you don't need to extend the therapy beyond the standard 9 months one. You stop treatment. Let the gland be.
It will resolve by itself.
Last question for this session, sir.
Chances of the relapse are there because they are there in a dormant state. Are there any chances of relapse?
So recurrences are there, no, described. Whether it is pulmonary or any other side, recurrence can always happen, but the chances are low if you have given drugs as per DST and given adequate duration.
Sir, I did sonography. Glands which are ruptured, or the gland is ruptured, and necrotic.
So see, the gland one is a little complex because there are various things. There can be paradoxical response, there can be secondary bacterial. But if you have given the adequate AKT as per the DST and you have given adequate duration, then don't worry, you can stop the AKT and
In spite of this,
Jupiter Hospital, Thane.
Over to you, ma'am.
So very good afternoon to everybody. Again, welcome you all and thank you for attending our CME. So after a series of cold lectures, we would probably move on to a topic which is more practiced in the acute care medicines. So diagnosis and management to invasive fungal infections in the ICU, an updated approach to an old enemy. So for the purpose of simplicity, I have divided my talks into two parts. One is the didactic talk, and then in the second half, we would have cases, and then we could have an interactive session on the same. So as we have seen that in the post-COVID era, the incidences of invasive fungal infections has increased remarkably, more so in the intensive care. Just a second. Yeah, right. Yeah. So the mortality of patients with invasive mycosis is estimated to be around 50 to 60% in ICU patients, and it more so increases in patients with septic shocks. So what is the key here? Detecting high-risk patients and optimal diagnostics and therapeutic strategies play an important role in treating the fungal infections. So why is there a rise in the number of invasive fungal infections? So first of all, there is an increase in the number of the susceptible individuals. Second, we are using more and more of broad spectrum antimicrobials in our ICUs. Third, a lot of immunosuppressive therapies, monoclonal antibodies are being used, more devices are being inserted, more transplants are being done. Now this challenge is dealt with the advent of new antifungals with lesser toxicity and broader spectrum antifungals. So the scenario of invasive fungal infection differs in Western world as well as in the Indian world. How are we different in India? So now the incidence of candidemia in India is about anywhere between 1 to 12 cases per 1,000 admissions, and this is almost 30 times higher as compared to the developed world. Now, a study of ICU-acquired candidemia in India found out that invasive candidiasis happened in patients significantly earlier after ICU admissions, patients who were younger, patients who were non-neutropenic, and even those with lower Apache scores than Western countries. though the commonly isolated organism is an albicans, we are finding out that there is a shift in the paradigm from albicans to non-albican species. And how is that technically important? Is because the non-albican species do exhibit resistance to the azoles. So the commonest species of non-albicans candida is Candida tropicalis. So what are the features which are unique to this species is its predisposition to septic shock, skin embolization, and shorter time of blood culture positivities. The second important aspect in the Indian invasive fungal infections in India is the presence or the emergence of Candida auris is a matter of concern. Now this is a newest kid on the block. And in fact, in one of the studies, this fungus was isolated in 19 of the 27 ICUs, and the fungus is it's very well known to kind of spread from person to person. And second thing is that it is a pan-azole resistant fungus. So we really have to be on the watch out of our infection control measures once the Candida auris is isolated. So what makes the diagnosis of invasive candidiasis so difficult? The reason is because there is a lower rate of blood culture positivity. So in different studies, it has been found out that the blood cultures in invasive candida are positive in only about 20 to 30% of the cases. So thus it remains a diagnostic hurdle, and this results in a delay in initiation of treatment. So let's focus on the two big brothers in the ICU, that is invasive candidiasis and invasive mold infections, that is we'll focus on invasive aspergillosis. So the other molds infections like schistosporidiosis, trichosporon, mucor, they are also seen in the ICU, but what we clinically encounter in our ICUs is invasive candidiasis and invasive aspergillosis. So Candida, it's important to know that it is the usual flora associated in the mucosal surfaces in the humans. In the event of mucosal breakdown or immunosuppression, these organisms become clinically significant and they result in fulminant infections resulting in mortality and morbidity. So what are the different Candida syndromes? They range from pyelonephritis to meningitis to endocarditis, pneumonitis, intra-abdominal infections, abscesses, and sepsis. So thus, what is the pathognomic feature of Candida is that it can metastatize. It does have a tendency to cause metastatic infections, especially in the eyes, the endocardium, deep-seated infections. And in places of deep-seated infections, the blood cultures are frequently negative. So invasive candidiasis is a deep-seated mycosis amongst the clinically ill patients and is associated with a mortality rate of almost 50 to 60%. What are the other challenges in the ICU we as clinicians face? Amongst the critically ill patients, invasive diagnostic methods are not possible. So for example, if you are suspecting a patient to have invasive candidiasis, blood culture, so the patient has a relentless fever, the patient is on meropenem, teicoplanin, the patient is also receiving flucon. Despite of that, the sepsis is not settling. What is an objective way to know? We are suspecting candida in the abdomen, or we are suspecting candida. So the patient is hemodynamically unstable. So sometimes the patients, it's not feasible to perform invasive diagnostic methods in our ICU patients. Delay in specific therapy is associated with adverse clinical outcomes. So in our ICUs, as I said, that the incidence of non-albican species is on the rise. So there are 4 to 5 important non-albican species. One is Candida parapsilosis, the other one is Glabrata, cruzi, Candida auris, and the most commonly associated Candida tropicalis. Now this epidemiological shift as clinicians or as intensivists is very important for us to know, because it has got major therapeutic implications, because Candida non-albican species often carry a reduced susceptibility or absolute resistance to azole antifungals. So now we come over to the invasive mold infections. So we have heard about COVID-associated kappa. We have seen COVID-associated mucormycosis. So invasive mold infections caused by Aspergillus are not uncommon in the critically ill patients. So invasive aspergillosis was considered to be a disease seen mainly in neutropenic patients and in patients of hematopoietic stem cell transplant. It is also an important pathogen in critically sick patients without neutropenia, such as those receiving immunosuppressant therapy and those suffering from any chronic organ failure. The outbreaks of aspergillosis have been usually associated with faulty air filtrations, construction work material, and even infected medical equipment as the infection starts from the inhalation of the conidia. Now, diagnosis of invasive aspergillosis is challenging in critically ill patients because the typical features like halo sign or air crescent sign are not usually seen in the non-neutropenic patients, okay? In neutropenic patients, there is a higher chance of angioinvasion, so the clinical features or the radiological features could be more predominant. So, such patients do not progress to rapidly angioinvasive diseases. Now, what as clinicians we need to know? What are the various risk factors for invasive fungal infections in our ICU setting? So most of us have ICUs, and we need to pick up, or we need to have a very high clinical index of suspicion to pick up or identify the patients and start them on empirical antifungal therapy. So what are the risk factors? One is a patient who has been there in the ICU for more than 7 days, has received broad spectrum antimicrobial therapy. Secondly, there is a presence of Candida species colonization. Patient with gut sepsis, especially patient who has undergone abdominal surgeries, patients who have been operated for malignancies, colonic malignancies, patients who are receiving TPN, patients with indwelling catheters, urinary tract catheters, patients with steroid use, uncontrolled diabetic mellitus, patients who have undergone stem cell transplants or solid organ transplants, and secondly is patients with structural pulmonary disease. We have seen increasing number of invasive aspergillosis in patients who have COPDs, non-resolving pneumonias, invasive aspergillosis. You've got to look for it to isolate it. Patients with hepatic failure, renal failure, major burns, mucosal damage, neutropenia, and lastly, those who have higher Apache scores, who have been on prolonged mechanical ventilation, prolonged duration of stay, and on total parenteral nutrition. So now this completes our theory. But as William Osler has said, that medicine is learned by the bedside and not in the classroom. It is very easy to give a didactic talk, but when it comes to the bedside, we need to have a practical application. Why so? Many of the funguses, like for example Candida or Aspergillosis, they are colonizers, and we'll end up treating colonizer. So we have seen many patients who landed with voriconazole toxicity because they have been treated with sputum which grew Aspergillus, but the clinical syndrome was not compatible with an invasive aspergillosis. So just because your sputum grows Aspergillosis, we don't have to start empirical voriconazole treatments. Either we need to have a radiological co-marker, or we need a BAL. We need a BAL galactomannan to be positive because that's more specific as compared to serum galactomannan. Or we need to isolate fungal filaments, or we need to grow it on BAL cultures. So just growing Aspergillus or Candida species in sputum does not mandate antifungal therapy. So only 10% of the colonized individuals develop clinical manifestations. So to reduce or to kind of identify the patients who actually can benefit with antifungal therapies, there are clinical prediction scores, okay, and they help in empirism in therapy. So one of the scores was the Candida colonization index, which was formulated in surgical ICUs. So what is this? It's the ratio of number of colonized anatomical sites to the number of cultured sites. If it's more than 0.5, it is associated with an increased risk of invasive candidiasis. So now these are the various scores which have been written, and these predict an individual's risk of developing invasive candidiasis. So typically if you have a patient who is in your ICU for a long time, the patient has got worsening sepsis, has received broad spectrum antimicrobials, your cultures are negative, your procalcitonin is negative, the patient does not, the blood cultures are 3 sets of blood cultures, they are negative. The other thing is patient is on TPN, patient has got an intra-abdominal condition like necrotizing pancreatitis, or has undergone a surgery for, is a recipient of the stem cell transplants. So these are the patients who need to be empirically treated with antifungal. So there are simple bedside scores that is known as a Candida score, which helps us in commencing empirical antifungal therapy. So this is an important quote by Albert Einstein. In theory and practice are the same. In practice, they are not. Okay? So still, despite of the advancement in molecular diagnosis, most of us as clinicians are faced with a dilemma to know whether we are treating with an invasive fungal infection or no. So what are the limitations of fungal cultures and radiological methods? So as I said, the typical radiological signs are not seen in immunocompromised persons. Limitations of fungal cultures, though it is a gold standard, it is only 50% sensitive. Blood culture isolation depends upon the burden of organisms. It is lesser sensitive in neutropenic patients. Now what happens in hepatosplenic candidiasis is that the candida first encounters the liver. So it acts as an efficient filter for these organisms. And hence the sensitivity of blood cultures further reduces in invasive intra-abdominal infections causing invasive candidiasis. So there is a long time to positivity, especially for species like Candida glabrata. The differential time to positivity is longer. They could take up to 8 days to grow on cultures. And the blood cultures do not detect deep-seated infections. So what are the rapid molecular tests we as clinicians need to know? One is the beta-D-glucan. So beta-D-glucan is a component of the cell wall of the fungi. Now from different nested studies, they have found out that its sensitivity varies between 50 to 80%, but the specificity is only 50 to 70%. So what I want to say is that BDG can have a lot of false positive BDG. Just because you have a BDG which is high doesn't mean that you have an invasive fungal infection, okay? So it depends upon, so false positive BDGs can happen in patients who are receiving antibiotics like amoxicillin clavulinate, piperacillin tazobactam, patients who are on IVIG or for that matter on albumin infusions. So all these can produce a falsely positive BDG. Even patients with severe sepsis can have a falsely positive BDG. So it has been noted that we need to have 2 to 3 positive, serial positive values of BDGs to call it or to classify it to have, to label it as an invasive fungal infection. Second is your beta-bal-galactomannan. So this is useful in the diagnosis of invasive candidiasis. So thus, the rapid diagnostic biomarkers, they do not have a high positive predictive value, but they have a high negative predictive values, okay? So what do you mean to say is that if a patient who is sick and septic and shocky in your ICU has a negative BDG, you probably can exclude invasive fungal infection as the cause. It helps us to avoid unwarranted empirical antifungals, which are very costly and which could be toxic as well. But if it is positive, you still are not 100% sure that you are dealing with an invasive fungal infection. So what are the latest diagnostic advances? So we have the BCID2 test. So we have the molecular PCRs, which identifies 24 organisms from a positively blood culture. So once the blood culture flags positive, you have your BCID2 panels, which can identify up to 19 bacteria and 5 important fungi. So it shortens the time to diagnosis, okay? And it does identify organisms in low burden states like neutropenia and gut sepsis. Similarly, the newer tests like Candida 2, Candida panel test, which is based on nanodiagnosis, detects Candida from the whole blood in 3 to 4 hours, and it also gives us a species identification. Nevertheless, these tests too do not differentiate between colonization, past infection versus true infection. Okay? So there are so many caveats, so many loop and holes. There are lots of tests, but we still are not sure. So, and if we use the antifungals injudiciously, they cause an increase in the antifungal resistance. So we are also seeing an increasing number of flucon resistant cases in our country. Now this is because of selective pressure from certain antifungals, usage in prophylaxis in immunocompromised individuals, selective preemptive and empirical use, and inappropriate use of antifungals in the community. So as clinicians, we need to know that there is a changing epidemiology of Candida species. From Candida albicans, we are encountering more and more number of Candida non-albicans species. So these are the specific risk factors of for non-albicans. So we need to know that in our ICUs, Tropicalis is the most commonly associated non-albicans Candida. The good point is that it is susceptible to fluconazole. If you identify Candida parapsilosis, you probably could say that the central line or vascath is the source of infection rather than the gut. So it gives us an idea that yes, you need to remove the foreign organism or the device to clear off the Candidemia. Similarly, if you grow Candida glabrata or Candida krusei, the news is not good because they are usually drug-resistant invasive fungal infections. So these are typically happening in patients who are on prior fluconazole prophylaxis, or in patients with hematopoietic stem cell transplants, or in patients with profound neutropenia. So, confusion hai confusion, solution kuch pata nahi. So whether it is an invasive fungal infection, yes or no? If yes, which invasive fungal infection? Is empiricism indicated in antifungals, and which is the most appropriate antifungal to use? So with this, we have a few cases. A 60-year-old diabetic admitted in the ICU 6 days back for fever and community-acquired lower respiratory tract infection. Now he has got a central line, he has got a urinary catheter. Is prophylactic antifungal therapy required? Yes or no? No. Who says yes? 6 days in the ICU, just with a community-acquired LRTI, he has fever. Would you start him on fluconazole or anidulafungin? No. Yeah, so no. So what do the IDSA guidelines recommend? They recommend only selected situations of giving prophylactic antifungal therapy, and that is in those ICUs who have more than 10% of fungi in their antibiogram. So you need to know the antibiogram of your ICU as well. So if you have high rates of invasive fungal infections which are more than 10% and they are grown in your blood culture, then only you are justified. Otherwise, you should not give empirical antifungals. Okay? So what do you mean? So there are different terminologies when it comes to treating antifungals. One is prophylaxis, one is preemptive treatment, and one is empirical treatment. So prophylaxis means you administer a fluconazole only on the basis of risk factors. What do you mean by preemptive treatment? Preemptive means there are risk factors, the biomarkers are present, but the patient does not have a clinical syndrome which is akin to that of an invasive fungal infection. And what do you mean by the empirical? Empirical means that there are risk factors, there are clinical signs, the biomarkers may not be positive, the mycology is also negative, but the patient has a strong clinical predilection towards developing an invasive fungal infection. So now this is the second case, a 70-year-old male, CA colon, receiving TPN, develops fever, 6 to 8 days durations. The blood cultures are negative. Is antifungal treatment required here? Yes. So what is this therapy? It is prophylactic, it is preemptive, it is empirical, or it is directed? Yes, it is empirical. Director means you have grown or the blood culture flags positive for a candida and then you start. So this is an empirical onset or start of the antifungal therapy. So thus the take-home message is that an empirical start in your antifungal therapy delays the mortality. So an effort must be made to identify the patients who benefit from empirical antifungals, okay? And scoring systems and molecular diagnosis will aid it. Now the third case, 60-year-old male for perforative peritonitis on TPN. Is empirical treatment for candida with echinocandins indicated here? Yes. So this is a grade 8-2 recommendation on the basis. So what does the IDSA say? That if the patient is on TPN, has been on ICU stay, has undergone an intra-abdominal surgery and is septic, echinocandins are the drugs of choice. You would probably defer from giving fluconazole in such patients. So what does the treatment of, what are the IDSA 2019 guidelines recommend? The treatment of IFIs depends on whether the patients are clinically stable or unstable. In clinically stable patients, species known, no recent azole exposure. If the species are still Candida tropicalis, Parasphilosis or albicans, we are justified in giving fluconazole. Okay, so it depends on the patients whether they are clinically stable or unstable. So what do you give for tropicalis, Parasphilosis or albicans? You use IV fluconazole. IV, what are the doses? 800 milligrams followed by 400 milligrams a day. Anidula fungin, the dose is for 200 milligrams followed by 100 mg. So anidula fungin does not need a hepatic or renal dose modification. What about liposomal amphotericin B? It is very costly. The dose is 3 to 5 mg per kg. For unstable patients, or if the species known as glabrata or cruzi, or the patient has got recent azole exposure, then the drugs of choice will be echinocandins or pollens to begin with, and we de-escalate to fluconazole after cultures and clinical stability. What is the duration of treatment? It is 2 weeks from the last positive culture, or the treatment could be individualized for deep-seated infections. Always consider metastatic sites and drug-to-drug interactions, especially when we are using azoles, okay? So azoles in patients who have received, who are on cyclosporin or on calcineurin inhibitors, the dose needs reduction. A 50-year-old male COPD with community-acquired pneumonia grows candida in the sputum cultures. Which is the most appropriate antifungal? Fluconazole, voriconazole, posaconazole, or none of the above? Yeah, so not all Candida positive cultures are significant. Candida recovered from respiratory secretions, especially antibiotic treated persons, is common and represents colonization. Patient with AML who is neutropenic on chemotherapy, fluconazole prophylaxis. Now he develops high-grade fever with loose motions. Now blood cultures you send from the port and the periphery, they are positive for Candida. So what is the treatment of choice here? Voriconazole, fluconazole, echinocandins, or amphotericin B? Yes, true. No, we are coming to that later. Now, this is a neutropenic patient who has a precious port, sir. So, echinocandin is recommended as the initial line of IFI. The risk of Candida glabrata cruzi is higher. Should the port be removed immediately? Now, this is a precious port. You don't have any other axis. Your oncologist says, no, you are not allowed to, I mean, there is no other axis. What can we do? So yes, there is a rationale in removing port because the ports, they, they accentuate the formation of biofilm. It causes septic thrombophlebitis. But with precious tunnel ports, we could use echinocandins as lock therapies. So and the other point of consideration is that in neutropenic patient, we have to be doubly sure that it is only the port which is the site of sepsis, because multiple studies have shown that in neutropenic patients, it is often a gut which is the site of sepsis. So you might land up removing a port which is probably not a culprit. So make sure that the gut is not a site of sepsis, and then we have to take a decision of removing the port. Which is the best treatment for lock therapy? They are echinocandins. So in high volume oncology centers, sometimes wherein you need to retain a port, you'll end up giving an echinocandin lock. Now the last case is a patient with obstructive uropathy. You have done a DJ stenting. He is on meropenem. Urine culture gluc candida. He received fluconazole. After 20 days, patient again came with fever. Again the patient has got candida albicans. Why? You have treated him well. The stent is in situ, but still the patient is growing candida. So yes, so candida tends to form biofilm around the calculi. So therefore you need to remove the obstructive focus. Second important point is we need to look for metastatic sites like ophthalmitis and endocarditis. Yeah. So whenever the patient has got obstructive uropathy, unless and until we remove the source of obstruction, it is not possible to clear the candida from the blood or from the urine. Now one last case, this was a patient of diabetes with autoimmune hepatitis, steroids, developed ARDS. We thought that this was probably gut sepsis. Now this was the patient, she was on a meropenem, teicoplanin and anidulafungin. This is frank ARDS. So we did a bronch in these patients, and what we found out was the branching filamentous septae, which were suggestive of aspergillus. Her BAL was strongly positive. So the patient, the choice of antifungal here was wrong. It should have been voriconazole. So these are the risk factors for invasive aspergillosis. So invasive aspergillosis happens in patients who are immunocompromised, prolonged neutropenia, with prolonged corticosteroid therapy, CLD, COPDs, diabetes, weight loss, and influenza. So these are the newer recognized risk factors for invasive aspergillosis. So these are there are basic 4 spectrum of antifungal drugs: polines, azoles, we have voriconazole and posaconazole and isavuconazole, who are the new azoles on the block. They, however, are usually fungistatic. The echinocandins as well as the polines are fungicidal. So now these are the standard doses for all the azoles as well as for the Pauline therapy. We need to dose the medications rightly for optimization of the PK/PD parameters. So this was an important slide which I thought that the azoles are important cytochrome P450 inducers. So if the patient is on isoniazid or on rifampicin, they may reduce the azole concentration and they may technically reduce and reduced efficacy of the drugs. Vis-a-vis if the patient is on calcineurin inhibitors, tacrolimus, statins, they can increase and they can potentiate drug toxicity. So take-home message, critical components in the management of invasive fungal infections are a prompt antifungal therapy, risk factor and analysis to identify patients at high risk, choice of an appropriate antifungal and dosing regimen, and source control. Currently, until a species susceptibility is known, an echinocandin is the recommended first-line therapy for most patients with invasive fungal infections. Once fungal speciation is done for Candida albicans or tropicalis, and if the patient is responding to initial therapy, the appropriate step-down therapy should be done. Thank you very much.
Thank you very much, ma'am, for that informative session. We now break for lunch, and we'll meet again at 2 p.m. sharp for the further sessions.
Thank you. And now I would like to introduce Dr. Yogita Pendurkar ma'am, consultant Jupiter Hospital Thane, to moderate the session.
Now our honorable panelists, first starting with Dr. Kirti Sabnis ma'am. Ma'am is a consultant ID physician at Fortis Hospitals, Mumbai, who will be speaking for the motion. And next we would like to invite Dr. Kanishka Dawda sir, who will be speaking against the motion.
Over to all the panelists.
Yes.
So it's going to be a clash of the titans. We'll see what the two titans have to say. With the invent of molecular diagnostics, we feel that medicine will probably become easier, just like AI. But is it so or is it not so? Let's see what the experts have to say.
I thank for the warm welcome. It's really heartening to see such a crowd on a Sunday afternoon. Thanks for invite Dr. Dhanashri and Dr. Kanishka. I can't say no both, you know that already. So this is a relative topic which requires a bit of clinical input as well. It's not only the lab test, so we'll see how it goes. I have 15 minutes, right? So this is my disclaimer. I think disclaimer is more important for non-financial disclosures, because it is very important that the further whatever slides and discussions we have, we can't replace physical examination and history taking wherever you go in ID, because that's the basis of ID. As Kanishka will agree, he is a student of Dr. Rajeev and I'm a student of Dr. O.C. Abraham. Both are excellent clinicians, which can't replace the clinical examination and mainly the history taking in infectious disease. Also, the molecular tests are always have something called as pre-test probability. Means how much you suspect. आपको ये होगा कितना लगता है. ये बहुत, it is very important for all the molecular tests. Without a pre-test probability, you can't interpret those tests. So these are very important two disclaimers, which everybody has to keep in mind when we debate further. So I start with a case. A cough with expectoration for 2 weeks, loss of weight, appetite, generalized rash, itching, all investigations baseline were normal. He can't give any sputum for testing. Man 2 was positive. So input was, had bilateral infiltrates. What to do next? We planned a bronch. Everything was negative. Fungal culture was awaited. AFB culture was awaited. Started on empirical AKT, did not improve. After 2 weeks of worsening of respiratory failure, admitted and got ventilated. So as my friend who is going to turn as a FOE, he is going to tell that we have to save the cost. I saved the cost. I didn't send a gene expert. I saved cost. I didn't send a respiratory biofire and ended up in paying for a ventilatory cost. So still we have time to think. We have 15 minutes. Which side you want to go? So history. After he got intubated, mother came and said, brother also expired because of XDR-TB 2 years back. So how many Star Wars fans in the crowd? I'm a big fan. I don't know what to do for this kind of history takings and saving cost on investigations, especially for infectious disease. Already we have had a wonderful discussion on TB diagnostics. So I'm putting our home ground study. This is done in Nayar. 132 pulmonary and extrapulmonary samples in which you can see the sensitivity, specificity and positive predictive value. They also looked at rifampicin sensitivity in that, which also stands for pulmonary samples around 95 to 99%, and for extrapulmonary it drops to around 87%. So this again in time it proves that we can't escape for molecular diagnosis when we have such a burden of infectious disease and variety of burden in the country. So what we are just talking about molecular diagnosis, actually what it is. What is a molecular diagnosis? So if you see, this is just to put a figure, this respiratory infections amount almost 7% of the deaths. So we have really good diagnosis. Obviously there is no cost against a cost for death. So we don't have to discuss about if we are saving lives by doing 1 or 2 tests. Whether it matters. If you go to a mall, next mall, you will spend more than 5,000 to 7,000 in one go. So I don't know how we will have a further debate, but still we'll continue. So as we see, also it's very important for neonatal diarrheal diseases. Neonatal CSF panel, which is for meningitis, it can actually save a life of a child. So these are the various panels available. They are specific for nervous system infections, pulmonary infections, bloodstream infections, diarrheal infections. I'll come to it in detail. So we saw about faster diagnosis, turnaround time, and how important it is for prognostic as well as diagnostic implications. So this is for respiratory illness. How it works is, so for the right, this is about the turnaround time, which is for the respiratory panel. If you ask
to your microbiologist. It is around, depends where it is the test done, like if it is done on Jupiter or where I work in Fortis, our turnaround time for a flu PCR is almost 10 hours. So depends on where you are practicing and how much the sampling transport time. If you can cut down on sampling transport time, the results will be faster. So how it is important? The respiratory panel specifically, it's very important. I'll definitely like to cover those rhino and adenoviruses, which are really can have a therapy changing diagnosis. We can offer them immunoglobulin, we can offer them ribavirin, otherwise we would have just labeled them as flu. And again at a cost of around 10 to 12,000 rupees, which I feel ventilated in any hospital, cost is more, death there is no cost. And again, a very important aspect of it is GI diseases. Majority of the GI pathogens in immunocompromised individuals are non-cultivable in routine culture media. Like viruses, we can't. GI pathogens like specific Cryptosporidium, Cyclospora, Giardia, most of the times we can't. So this is a very useful panel, and culture turnaround time is 3 to 5 days, which is for an immunocompromised person can be again a lot. He can go into sepsis during that time, mainly for post-liver or renal transplant. Again, same thing, we are again saying that we are actually reinventing the wheel, because the molecular diagnosis is not something new. It has been in vogue for last 40 years. We are just improving on them to have a better short turnaround time, reducing the cost. Like I'm very sure my opponent is going to put a cost of iPhone, because everybody says iPhone is the costliest one, gives very good connectivity phone and all. But again, it is getting improved. Same like that, we have better things which are available at a lesser cost, and which are again competing with the similar diagnosis. So as more and more tests will come, more and more companies will produce, ultimately it is going to be economical. But till that, I feel there is no price for price of life. Again, one case, 52-year-old man, he is admitted with headache. I'll just go fast with the case because we have again some time to discuss. So he was admitted elsewhere initially, developed ascending paralysis, required ventilatory support. His urine culture was MDR Kleb. Transferred to our hospital with GBS. He was already on meropenem and colistin because the urine culture was MDR Kleb. He was in ICU because the ascending paralysis, everybody thought of a GBS or that was initiated on plasmapheresis and high dose steroids. The repeat CSF was done, which grew myriad species in a routine culture. This was almost 4 days down the line of admission by the time the culture came. And MRI was suggestive of a leptomeningeal enhancement with arachnoiditis. Now, what to do next? I can have quick audience survey. How many of us think empirical AKT will good? How many of us think it can be something like an autoimmune vasculitis, we should do a PET? He's not getting better on a standard treatment of steroids and antibiotics. Relatives we counseled, they are not ready for an empirical AKT because of the relatively side effects. And where is the diagnosis of TB? Nowadays everybody is a Google master. They want to know culture में तो TB नहीं आया है, फिर TB है किधर? कहाँ ऐसे कैसे treatment देंगे patient को? So there is an answer for it. We did a pyrosequencing which detected MTB positive. Started with a first line AKT, patient improved. And we continued the steroids, obviously. And the cost saved? Yes. We saved the cost of plasmapheresis. We saved the cost of empirical antibiotics. So here is the cost-effective analysis, iPhone versus various other phones. So now we come to very two important issues which I feel as doctors we are going to face more and more. Medico-legal issues as well as cost-effectiveness for tailoring of a therapy in the hospital. So as I said, previous case was a very good example regarding the medico-legal issues because we could prove that your patient is deteriorating or improving or what patient has is a TB. So now we come to India. India, how we don't have much skilled personnel. Every time we can't send a sample to the tertiary hospitals, how it is possible. So I think COVID has told us how to go about and go around, eat from the right to left side and work from home, except doctors. So there is a very wonderful study which includes how a COVID testing or a point of care testing with molecular platforms. A very important example is also Gene Expert. As we know, if we have microbiologists in the crowd, they will agree with me that we can do different 4-5 types of tests only with the small Gene Expert machine. So I don't think so we should give an any excuse of not having the test with low skilled or low cost settings in the India. And the review which I quoted is including maximum samples from Bangladesh. So I think we should be at least be concerned about our health conditions are better than Bangladesh. So this is again which includes direct cost-effective analysis of a flu PCR in improving a diagnosis and empirical antibiotic therapy in elderly. As we know, the guidelines also say that ordering a flu PCR in an OPD-based young patient might not be cost-effective because anyway he is going to recover within next 3 to 4 days. I completely agree, but elderly patients who are going to might get admitted, having this diagnosis is very important. It's effective, cost-effective as well as prognostication. Like if the patient is flu PCR positive with heart rate which is slightly more, you will admit that elderly patient rather than sending him home. So this is published in PLOS. PLOS is a journal which actually always does this cost-effective analysis and effect of any test. So this is from PLOS, which clearly mentions clinical judgment versus RT-PCR is better. This is regarding they did analysis in an emergency unit when a patient presented in sepsis. How asking for a point of care rapid test or like a blood culture BCID panel which is from Biomedics helps in reducing the antibiotic therapy and reducing the length of stay in the hospital. So there are various platforms available. I think we might have a separate talk on the platforms which are available, so I'm not going to go into details. What I want to have your attention to is difference in the length of stay. What is IAAT is inappropriate antimicrobial therapy and AAT is appropriate antibiotic therapy, which is decided by getting a molecular panel. So length of stay is different. Cost of molecular assay clearly you can say, and cost of hospitalization per day you can clearly say. So this is again, it is cost effective in critically ill patients also. So now where we need this molecular testing basically in our hospital settings. So these are the 3 things where the mortality is directly related to effective treatment. These are patients in ICU, post-transplants and immunosuppressed. So this is little busy slide. The thing which you need to have a look at is this second line which says 201 patients with gram-negative bacteremia. They studied about ID pharmacist intervention which resulted in reduction in antibiotic prescription as well as how the conventional method continued to have antibiotic cost. And they also have done, because doing a cost effective analysis is actually very difficult, but they have done in this a cost effective analysis which is clinically significant.
Pointer.
Thank you. So this is the thing which I wanted to have a look at. This 46-hour reduction in antibiotic therapy, reduction in the length of stay as well as reduction in the hospital cost per patient. So this is clinically significant. So I think we are going ahead with the molecular diagnostics faster than what we think. This is our own data in Fortis. We are in a line of publishing it. We are looking for the cost-effective analysis. We have 130 patients with matched controls in ICU with a BCID panel positive, and out of that, effective change in the therapy was in 78 out of 130. So this is also about the same, how the turnaround time helps in blood culture positive patients. So now we really need to think, what is this debate about? So our own speaker is now changing parties. Changing parties is not very unusual for, at least for Maharashtra, but we are seeing here also. We are also seeing it here on here very dais. Because he just 2 hours back spoke about how the TB diagnosis and moleculars help in better diagnosis. So this is my last time. I rest my case with this one. Thank you.
This is working, na? ये कर रहा है? Yeah, everyone can hear me?
Yes.
I am not who I was earlier. So वो सारे comments अभी आप भूल जाएंगे. So this was all, you know, very cunningly planned by all these three ladies, because see, they are so cozily sitting. So these two decided the program, right? Dhanashri madam and Yogita madam, they said you speak on molecular diagnosis in TB. Nobody can speak on it like you can. I said, okay, okay. Then they said, now you speak against molecular in the debate. And they are my seniors, what can I do? So all this is a shadyantra, is what I want to say. But I will still do my best. I am a humble student in front of them. And just before I go on, I just want to really thank Kirti for coming. She just told me what she has been doing last 3-4 days. She was out of town 3 days. Then she came today morning. She did 10-kilometer marathon. Yes, and now she has come for this, debating me. So imagine how energetic and confident she is of defeating me.
I think this is a free debate thing.
I have to give all my excuses na before I lose.
My two slides are remaining after this. Huh?
So how do I change? Go to my presentation? अच्छा इससे होगा. मेरे presentation? So, who is this person? Can anybody name him? Satish Kaushik. In which movie and what character he is playing? Yes. कौन बोला? Very good. Yes, yes. You have to vote for me then. So this is actually Pappu Pajar from Divana Mastana. Now why is he making appearance here? I will reveal the mystery slowly. How many of you have seen this spoof video? So CID is very, unintentionally funny, many times. So these TVF fellows made a spoof video, missing dimag, kissa missing dimag ka. Again, I will explain why this is coming here little later. Just remember these two things. So this was a 14-year-old guy who came with fever and headache since 10 days, altered sensorium since 1 day. Now the resident who performed the CSF had a cold. Then a CSF biofire was done which showed pneumococcus. Okay, so he was treated very confidently as acute bacterial meningitis due to pneumococcus. But but he did not really improve. Repeat CSF was done which showed gene expert positive. So what happens in molecular tests is that you don't know whether the thing you have detected, is it really invading or not? Because there are so many DNAs in the air. If you do molecular testing for fungus, you will come so many positives that you will go mad. You will not know what to do. Right? So they create a lot of confusion because they can be colonizers, they can be contaminants. And, so this person, now why I said that the resident had a cold, is actually a case described in one of the journals, that the person was doing the CSF, sneezed, and went into this thing. So that little bit of that also will get detected. But that was not what was inside the patient. Right, so the molecular tests, you really need to be very clear how you are using them. You should, otherwise you can fall into very bad traps. Because they do not know, so the machine is very dumb. But what happens is when machine gives a report, we become dumb. Because we stop thinking, machine ने दे दिया है कैसे गलत होगा. But machine किसने बनाया है? Right? So we have to, so all the computers in the world, they are only as good as the person who has programmed it. And the person who has programmed it is a human. अभी तक तो AI ने खुद का machine तो नहीं बनाया ना. So we have to take it with skepticism, use it with some logic. We can't just go by some report that has come, clinico-pathology, clinico-radiology, correlation, all that needs to be there. And the biggest problem is that because of these tests, the people are forgetting palpation and percussion. And during my Hinduja ID posting, one DNB medicine resident, second year, he told me, "Sir, आप मुझे spleen palpate करना सिखाओ." He told me, second year DNB medicine resident in Hinduja. He said, "मुझे spleen का confidence नहीं है, sir, आप मुझे सिखाओ." But you ask him, CSF biofire में कितने germs आते हैं? Sir, 27 germs आते हैं. So they are learning all this. They are not learning the history taking, physical examination. So who will teach? And they get used to all this. It's like fast food, you know. So with the invention of the pen, the people's memories were destroyed. So same way with the invention of the 2D echo, auscultatory skills are gone. So now with the molecular diagnosis, we will lose our brains also. That is where we are headed. So, but now Kirti will tell me, but I am using my brain. When I trained, there were no PCR tests. I have all the skills, so I know how to interpret. Good doctors will not do all this. Nah? But now you see what has happened. What we used to do in COVID. Our esteemed guidance makers, the best doctors in India, the top 1% doctors in India made guidelines. Top 1% doctors of the world made guidelines like this. Don't you remember how we used to discharge our COVID patients? The very first discharge policy said what? You need 2 negative RT-PCRs. Otherwise you cannot go home. Then they themselves changed it. Why? Because you are picking up dead DNA. You don't know what is the difference between detection and infection and infectivity. So this is how the PCR tests fool even the most intelligent people in the world. I think Kirti's boss was one of the people making the guidelines. Not Kirti. And of course, the person making the guidelines may not get his way because everybody else will vote him down. So I'm just joking.
I think COVID was an exception. COVID, this initial period was an exception as we learned from that. And eventually we are evolving to 5 days of isolation.
Correct. Yeah. But I'm just, you can still understand what I'm saying, right? So this is what happens when we stop using our brain. So no matter how advanced we get, we need to continue using our gray matter, right? So always remember one more thing. So why do they make the robots humanoid? Robots can be made in any shape, size. You can make 10 hands, you can make 10 eyes. Why are they made humanoid? The most advanced robots. Does anybody have any answer for this? Because humans have never come across a machine more perfect and more suited to do all the activities. Right? That is why all the robots are made, the advanced robots are being made more and more humanoid. We don't try to make them non-humanoid as such because the human brain is the most advanced machine in the world. Is there any machine more advanced? Not yet. So we should keep that in mind when we are using advanced technology. We should not be blinded by the technology. So 2 negative PCRs means patient used to stay 3 weeks. And who was benefiting? The people doing the PCR tests. Nobody else was benefiting, right? So then they reduced it and then all that went away. So this is a key concept regarding any molecular test that you need to understand, that detection is not always equal to infectivity or disease or invasion. It can be colonization, it can be contamination, it can be persistence. So here you see the antibodies, the red line has started coming up from a long time. But the PCR may show positivity, but that doesn't mean that the patient is infected. It is like, calling something as, you seeing a snake skin and then calling it a snake, like that, So this was the first pitfall, that you can have, false positives for stupid reasons, and we should use the clinical judgment. So what the second pitfall is, what I was again referring to in the first this thing only, कि what happens is that we leave our brains on the side. दिमाग को साइड पे रख के डायग्नोसिस करते हैं, बट उसमें ही तो प्रॉब्लम होता है, right? Nothing is a replacement for clinical judgment. Now Kirti has already said this, and I agree. So nothing is a replacement for clinical judgment. Don't think that सारे मशीन आ जाएंगे, सारे टेस्ट कर लूँगा तो मिल ही जाएगा डायग्नोसिस. I don't have to think. The minute you start doing that, the patients will start suffering and you will lose your reputation eventually. So the David Dhawan movies, we always used to say, दिमाग साइड पे रख के जाओ तो मजा आएगा. मूवी के लिए ठीक है, मेडिसिन में नहीं करना ऐसे. So, now coming to the cost. Now Kirti has very smartly preempted many of my arguments. But she didn't highlight the costs like how I am going to do. So this is the GI panel cost, Metropolis 16,800. Now this is the CSF panel 18,500. Now if you see that when you tell somebody, normal person, that we need to do this test, so they will be like this. And we are Thanekars. We are not as rich as Mumbaikars. So always keep that in mind. So, and once this fails, then what do the people do? So then they go to this. अब ये टेस्ट कराने के लिए मैं मेरा किडनी बेच देता हूँ, वापस हॉस्पिटल को और रेवेन्यू. So, cost is an issue, and I have some ideas about how to reduce it, but I don't think it will ever happen. So like suppose this PCR was done on somebody with an encephalitis picture, then you got this enterovirus. So now what do? You've done this 18,000 rupees test, you got the enterovirus. So how is it going to help you? So what happens in this situation is that relatives get very happy. अरे कुछ तो positive आ गया, वाह, diagnosis मिल गया आपने को. So they get happy. Then what happens? Then they ask you, sir, अभी आप treatment change करेंगे, patient ठीक हो जाएगा ना? Then you say कि हाँ, ये अभी ट्रीटमेंट में तो कुछ चेंज नहीं, ये डायग्नोसिस मिल गया, पेशेंट का पता नहीं देखते. Then the relative is thinking, I have spent 18,500 rupees on something, and that has not resulted in any difference. So when they do these panel these things, I always feel, why not include only the viruses and bacteria which have some treatment. Like the GI one is the worst. It will have astrovirus. Now Kirti must have sent and got astrovirus. I don't know what treatment she's giving. I have not read any treatment for astrovirus. So what is the point of putting the astrovirus in the panel and increasing the cost? Just make a panel where there is a treatment. बाकी सब diagnose करके क्या फायदा है? Right? So this is my idea. Now mostly it will not work out because that will reduce their revenue. Right? So, so then the patient will feel like this. Then we'll say कि नहीं वो test करना तो ज़रूरी था. We ruled out 10 other things. But he will be like this, frustrated. गलती चाहे किसी की भी हो, बेवजह मरता मैं ही हूँ या मेरा patient, right? So and then they say कि नहीं वे ये सब बाकी सब germs, they are, when we detect we can do better infection control. What infection control are we doing in our country? We don't isolate open coughs, we don't isolate MDR coughs in the government hospitals. What infection control are you going to do after you get astrovirus? Right? So with that, I will just, I think that is my last slide. So false positives, non-treatable things being tested, high cost, and दिमाग को side पे रख के diagnosis करो. Syndrome happens. And all the junior students get into this bad habit. अरे history छोड़ना, अपन PCR भेजते हैं. क्या मिलेगा history से? PCR भेज दो. सोचने का नहीं, अपन history लेते बैठेंगे तो खाना कौन खाएगा? हाँ, so this is what is happening. So with that I stop.
I'll lead the mic. मेरा presentation. So as my opponent has put up various pictures will not come to help you to treat the patients. As I've already put, if otherwise you have to get a Nasruddin Shah next to you, patient will look at Nasruddin Shah and you don't need to treat. So I will come to 2 points which are really required as a clinician to decide. As I already said, nothing can replace a history taking and a physical examination, and it's very important. We normally forget when we order a test, what is a pre-test probability? What we will do if the test comes positive? What is, suppose if I send a CSF PCR in an immunocompromised post-transplant individual, which diagnosis is really vital, because if there is a meningitis, encephalitis, obviously as Kanishka has definitely put it, to decide only treatable viruses, but there are few things like normally which don't come, like I have put rhinovirus, like astrovirus for his favorite virus, we'll take astrovirus. So astrovirus, the important treatment, it comes only in patients who are immunosuppressed. So very important is to reduce the immunosuppression. It is very difficult to convince. Try talking to a nephrologist, try talking to your liver transplant physician to reduce an immunosuppression. You tell there is no test, you don't spend 18,000, patient is spending on a diarrhea treatment, patient is spending on a immunosuppression cost. Ultimately that cost will come down when you convince your transplant physician that patient has astrovirus, it doesn't have any treatment other than reducing your immunosuppression. Reduce the immunosuppression, patient will get better. So I think it is very important to do the PCR even if it is costing 18,000. It is like initially mobiles we used to have. They used to be very costly, SIM cards used to be very costly. When everybody started using it, the cost automatically comes down. So we hope the cost comes down in next 4 to 5 years. It's not working. So these are the key principles of rapid diagnostics or molecular diagnostics which we use in infectious disease. With the right interpretation of the test, what clinician understands from the test, it's very important. Right antimicrobial, whether we are going to appropriately modify our antibiotics or antivirals, and right time. We can't send, as we said, he correctly said, RT-PCR, we have to keep on doing. There is no, what is the correct time of doing RT-PCR? In initial first 3 days for the diagnosis. It is not a test of cure. Like same gene expert, it's not a test of cure. So this interpretation is by the clinician at the bedside when he examines the patient. So I think we are not able to run away from the molecular diagnostics. The brain behind the molecular diagnosis is more important. A microbiologist, a clinical microbiologist plays a very important role in your infectious disease practice. So I feel your best friend should be your clinical microbiologist rather than anybody else. So we can have a regular dialogue and get out from the difficult clinical situations easily. So I end my debate with this last slide. Purpose of a doctor or any human in general should not be simply to delay the death of a patient, but to increase the person's quality of life. And I feel to increase the quality of life, if we are spending in this era or in India, in Mumbai, we are in Thane, we are okay to spend. And anyway, this idea of putting the slide of the symposia was his. So even if I win, I'll share the prize with Kanishka. It's okay.
I don't have much defense. I just want to say, I will practice in Fortis. You come here.
I'll be more than happy to be the girl cat.
Yes. Just joking. So, of course, we can't practice without molecular tests in today's age. It definitely helps. The only thing is that we have to be logical and not forget the basics. So, debate is mainly for a fun, the post-lunch session. So, we did it more like a fun. So both sides are right in their own way, and madam has to decide.
Indirectly, you're trying to threaten her to decide.
There is a tie between both the board participants. Yes, both get 100 on 100.
Thank you all the panelists for a wonderful debate session. Now I would like to invite Dr. Dhanashri Atre-Singh ma'am to kindly felicitate Dr. Kirti Sabnis ma'am with a token of her appreciation. Can we have a round of applause for the ma'am?
Kirti has used, apart from trekking, she is a lover of plants. She's got a lovely nursery in her house as well.
You added to her nursery.
Yes. I'm very happy. Organize more and more CMU than call me. More than happy.
Thank you everyone for the wonderful session. Now we would move forward. यार अभिषेक MBBS डेज में पता है हमने कितने सारे सिंड्रोम्स पढ़े थे?
हाँ थोड़े बहुत तो याद है.
एक CMV सिंड्रोम पढ़ा था क्या, वो याद है?
नहीं, वो कभी सीनियर्स ने अपने IMP के लिस्ट में टिक ही नहीं किए थे.
चल आज पढ़ लेते हैं. So to tell us in detail about the CMV syndromes, we have with us Dr. Ravindra sir, Head Director of Critical Department, Jupiter Hospital, Thane, for the next talk. Thank you, sir.
To you all. So you are absolutely correct. CMV is something which is not near to our heart. It's too far from the heart and brain as well. And Dhanashri has given me this topic because she wanted me to learn this topic and read. And I tried to learn and make presentation, learn, read, and I realized one thing at the end, that I have to give reference to the infectious disease specialist. That is the best thing to do when you are suspecting CMV-like syndromes. Okay, that's not something which is very common to infection. And cytomegalovirus, it's a herpes group of virus commonly known that we know is HSV and kind of those. CMV is not very commonly known, and this is a virus which usually would infect immunocompromised patients, especially common in post-transplant solid organ transplant patients. And here we deal with solid organ transplant, so we are little familiar with this, but not as much as, because most of the patients, they don't come to the ICU or get admitted. Most of them are managed on the OPD basis. So usually this would present as a simple disease like a mononucleus disease. The common cause of mononucleus disease or infectious mononucleosis is Epstein-Barr virus. 10% of cases are caused by CMV as well. It gets vertically transmitted. So there are three syndromes that can happen, predominantly three syndromes that can happen with CMV. One is the simple illness, then second is the congenital transmission, and 1 in 100 infected patients are there if a mother is positive. And out of those 100, 1 in 5 become symptomatic in children, I would say, I mean the neonates. more interest to us is the last one, the immunocompromised host, where this has become more common. So in children, the common presentations are microencephalopathy. They can have seizures, petechial purpuric rash. They can have long-term disability. So it's a very dangerous virus to have actually in the mother, in pregnancy, in an immunocompromised host, or even in immunocompetent host. They can have respiratory distress and hepatomegaly and splenomegaly as well. Low birth weight. There are certain risk factors in a transplant patient. We are predominantly going to talk about the transplant and immunocompromised patient today. So donor positive for a patient who is, the donor which is positive for CMV gives the organ to a recipient who is negative for CMV, are at high risk of developing an infection. Allograft rejection, CMV itself can cause allograft rejection. Then severe lymphopenia due to severe immunosuppression, excessive immunosuppression use, genetic polymorphism, transplanted organs. I mean, with different organs, the risk of CMV is more. Like in patients who have bone marrow transplant, they have a highest risk of developing CMV, and they need more prophylaxis or empirical therapy for CMV. Not so common with kidneys, but very common with liver as well. So they have a spectrum of infections that CMV can cause. Usually there has to be an evidence of virus undergoing complete replication. So then only it becomes detectable in the blood or plasma. First is the asymptomatic infection, where there are no symptoms, but you will detect a virus in the blood or the plasma by PCR test or any other test that you do. Second is the viral syndromes. Now in viral syndromes, you will have mild symptoms like, it's like any other viral illness where you have fever, leukopenia, neutropenia, sometimes leukocytosis, sometimes thrombocytopenia, altogether myalgias, a routine viral syndrome. And when this viral syndrome is associated with some affection of an organ, as I said, CMV is a systemic disease. It can involve all the organs. So it can have CMV, it can cause retinitis, it can cause pneumonitis, and so on. When that is there, or you have a histological specimen where you have detected a CMV or inclusion bodies in the histological specimen of that particular tissue, then it is called as CMV disease, which is very dangerous. Latent CMV is a viral infection without full replication of the cycle, and the CMV, mind you, there are 40 to 50 or even 60% of population is infected with CMV, and the CMV lies latent in your body, in all of our body, and whenever the immunity goes down or the body is suppressed for its immunity with drugs, the latent infection crops up, and then it becomes an infection and manifests, right? So all of us get this CMV infection in the childhood. We carry it, and it is there. The CMV is there latently in the body. So how do you check that whether you had a serum? Usually it is done in the donor and recipients, but if you are to check whether you had a CMV infection or you have CMV in your blood, you are supposed to do the IgG level. Sorry, क्या हो गया भाई? Sorry. So you have to do the IgG levels. That is a serology test. In serology, you do IgM or IgG levels. So IgG levels would tell you that you had an infection in the past, right? So donor recipient serum status you need to know when you are transplanting the patient. Whether there are multiple categories where a donor is positive for CMV, that is IgG is positive, recipient is positive, donor positive, recipient negative, and so on, and the other way around, right? In the previous era, CMV pneumonia was most common clinical disease manifestations in the pre-antiviral and preemptive therapy. So when there were no antivirals available for CMV, pneumonia was the common presentation. But now, gastrointestinal involvement has become more common. Right? The pneumonia has gone behind. How does the virus affect the body? It causes it is a lytic virus, and it is a cytopathic virus. It has a cytopathic effect. That means it affects the cells. Initial infection, there is epithelial cells of the salivary glands. Usually, saliva is the most common one to transmit the infection. Then there is viral shedding. It infects the genitourinary system, proximal tubules near the cortical areas, and it can be found in salivary glands, lungs, liver, kidneys. I'm talking about the latent viruses, intestine, adrenal glands, and CNS. The other pathognomic mechanism by which it causes a problem is it forms an immune complex. It has a granulomatous reaction, particularly in liver, That's how it affects the liver and cause hepatitis. You can actually on the histopatch see those granulomas like pictures of the CMEs. Vascularity it causes, and the host factors play a big role in this. Incubation period is around 28 to 60 days. Primary infection symptoms start from 9 to 16 days, viremia of 2 to 3 weeks. IgM response develops in 30 to 60 days. And peak infection is at around 7 weeks. So in an immunocompetent host, talking about not immunocompromised host, the common symptoms are usually it is asymptomatic. As I said, it is a mononucleotic syndrome with fever, malaise, rash, headache, lymphadenopathy, lymphocytosis. Less common would be exudative pharyngitis, splenomegaly, adenopathy and lymphadenopathy, anemia. Rarely, you can also have ectopic hepatitis, Guillain-Barré syndrome, GBS, with CMV, myocarditis, encephalitis. These are more common with immunocompromised patients. In immunocompromised patients, apart from whatever we talked about, there are more things as well. So there is an activation or accelerated infection to the other viruses. So it accelerates the infection of other viruses, number one. It augments the risk for developing other infections like bacterial or fungal infections. So if you have a CME infection, you have a high likelihood of having a secondary fungal or bacterial or another viral infection. Then it has an oncogenesis and proliferative syndromes also it can cause. Then it can cause an injury to the graft, direct injury to the graft, without causing any other systemic symptom. So you can have an allograft rejection due to CMV, right? So that's why you have to be very about CMV and so on. In the lungs, it can cause bronchiolitis obliterans, and it accelerates the atherogenesis as well in the cardiac tissue. So it presents a systemic disease. So when it is a disease, that means you have a symptom and sign of a particular system, plus there is viremia or detection of the virus in the blood or the plasma. So it can affect all the system. The gastrointestinal system, it can cause esophagitis, enteritis, colitis. So it can affect the upper gastrointestinal system as well as the lower GI, and it has been shown in the studies. The common symptoms would be dysphagia, nausea, vomiting, diarrhea, right? And sometimes you have hemorrhages also, so hemorrhagic diarrhea with abdominal pain. In the hepatitis, you will have increase in the SGOTs and SGPT, again nausea and other things. Pancreatitis also it can cause, presenting as elevated levels of amylase, lipase and abdominal pain, vomiting. It can cause in the lungs pneumonia, which would present as a pneumonia symptom like cough, shortness of breath, bilateral pulmonary infects and so on. Meningoencephalitis is also known, and CMV encephalitis is very common in post-transplant patients. It presents as nuchal rigidity, headache and mental status changes, sometimes paralysis. GBS, post-CMV infection can happen. Retinitis also can happen. It predominantly affects the retina. There is retinal edema, hemorrhage, loss of vision can happen, and it would require an ophthalmologist opinion to look for all these things. Nephritis can affect the kidney and causes an allergic type of nephritis, and on biopsy you can actually see that it is an allergic nephritis. So some of the pictures how it affects, how do you diagnose on all those things? Ultimately you require a tissue biopsy, we'll come to that, but different fluids, like for pneumonia you can do a bronchoalveolar lavage, BAL, right? For encephalitis you can do a CSF. Urine samples sometimes, except in pregnancy, are not valid. In the pleural fluid, abdominal fluid or whichever fluid, tissues are invaded with CMVs, and you can detect actually inclusion bodies there and the protein aggregates there. This is a picture of a CMV pneumonia on the X-ray, bilateral interstitial shadows, and you look at the CT scan, it is showing these are all bilateral infiltrates, they are interstitial pneumonia. So the CMV typically cause interstitial pneumonia, and it looks like PCP or ARDS, and it is very difficult to diagnose because you would not suspect it. It mimics a viral infection like an influenza, like COVID and so on. You will have ground glass opacities, you will have interstitial pneumonia in a picture, you will have bilateral infiltrates. You really need to think hard and deep to actually think that this is CMV pneumonia. And mind you, in last 2 months in our ICU, we have seen almost 5 to 6 cases of CMV pneumonia and CMV disease. And this was not very common. It came like an epidemic because in my last 20 years of career, I had hardly seen any CMV diseases like that. Maybe once in a year or so. But in last 2 months, one patient, and mind you, these patients were not post-transplant patients. They just had low immunity. One patient had leukemia. She presented with gastrointestinal symptoms and then pneumonia. One patient was vaginous granulomatous and was only on steroids and had received rituximab as a part of therapy because he had an exacerbation of vaginous. And he had this type of picture on the X-ray and that type of picture on the CT scan. And we did not think about it immediately. We thought it is an exacerbation of disease. Then we thought of PCP, and we covered everything but CMV. And at last we sent a CMV, and then it came positive, and then we treated it, and patient did better after that. But of course he succumbed to other things. So what I was thinking, one patient was a patient who was taking steroids for anabolic steroids for building up his body. So he was a gym trainer and bodybuilder who used to sort of go into these competitions of bodybuilding. And he came to us with renal failure, vasculitic type of picture, multiple skin lesions. And retrospectively, most of the time we diagnosed it retrospectively. There was a skin lesion and we thought we should do a biopsy of the skin lesion. We did a ball and did a biopsy of the lung with the ball. And we found that on the skin lesion, and the bronchial lavage, we found that this is an autoimmune disease. Right, so there were lymphocytic infiltration and so we started increase the immunosuppressants, thinking that it's a multisystem involvement, pulmonary renal syndrome, and then we thought, okay, those skin lesions are not going up. What are those? In his blood test fellows, so the thought was that whether they were PTK and all, but we did a skin biopsy, and the skin biopsy showed inclusion bodies, and then we sent his CMV, and it came positive. The copies were significant, and then we started him on treatment for CMV. The patient did well, of course. And now he's gone home. But most of the time, my point is that you need to have a very, very strong suspicion, and really need to have your ear, eyes, and open and brain open to have a diagnosis of CMV or thought of CMV. And most of the time, the diagnosis is retrospective because this is not common. The other point is it is not restricted to only solid organ transplant or organ transplant. Now the disease is coming up in immunocompromised host also, like patients who are on steroids, patients who are heavily diabetic, uncontrolled diabetics. So you need to think about this. Patients who are in ICU for a longer period has received a lot of antibiotics, are critically sick, nutritionally poor, and so on. This is a picture of CMV hepatitis. You can see those with the arrows. These are the denaturated or aggregated proteins of the CMV, which can be seen there. CMV colitis. Now, the first picture shows colitis with or without erosion. No erosions, a small erosion like picture. The second B picture shows a pseudomembrane formation. In the C, you can see tumor or polyp-like syndromes. And in the fourth picture, there is a cob-like appearance. So all these things you can see on the colonoscopy or upper GI scopy. And what you need to do is to do a biopsy of this and then try to find out whether there is a disease. Again, if there is no detection of inclusion bodies or the disease in the biopsy, that doesn't mean that the patient doesn't have CMV infection or a disease. Vice versa is also true, that just because we have a CMV infection and this picture, that doesn't mean that patient has a gastrointestinal disease due to CMV. It can happen with other diseases also, like Clostridium difficile and all. CMV encephalitis, this is the MRI scan which is showing a periventricular enhancement. You can see those white patches around the ventricle with hyperintense white matter lesions. Some other pictures of those, basal ganglia involvement, and there is periventricular hyperventricity again. Here there is a basal ganglia. Is my pointer? Okay. Oh, this is a pointer. So you have to manage two. Okay. So these are the basal ganglia lesions, periventricular lesions. So these are common pictures. Then this is a picture of, so you can have hemorrhagic encephalitis with CMV. So this is a picture of MRI or brain which is showing multiple hemorrhages in the brain. This is the retina, this is the deceased one, and now it has cleared up after the treatment. So the point is, it is a multi-system involvement, and you really need, any organ can get affected. How do you diagnose it? Molecular methods. Now we have better molecular methods. Initially we had only conventional cell culture, which takes a lot of time to come, maybe 3 weeks, 4 weeks, 6 months, by the time patient would be dead. So this really has, Kanishka sir, this really has changed the diagnostics capability of, especially in post-transplant patient. And these are the tests like PCR-based tests or a good immunosuppressive therapies has really changed the outcomes in transplant patients actually nowadays, right? So the advantage of this test is that you can diagnose them early, you can quantify them early and decide whether to treat or not treat. Similarly, the serological test will give you an idea about whether the donor was positive, the recipient was positive, both were positive. So that puts them at an increased risk of having an infection. For example, if the donor was positive and recipient is negative, the recipient is at increased risk of having a infection or activation of CMV, right? If the recipient is positive and the donor is negative, the recipient again is at increased risk of development of infection or reactivation of the infection because he was positive. And once you immunosuppress them post-transplant, the reactivation can happen. So these patients, you can pre-transplant diagnose them with serology and find out whether they are IgG positive or not, or PCR positive or not. And after transplant, you can monitor them by doing serial PCR test and find out and start the therapy early. Even if they are not symptomatic, some centers believe if you have a positive test, you need to treat them, right? Or preemptively give the treatment. There are some antigenemia tests also, shell viral cultures, but the gold standard is ultimately the gold standard is histopathology. We'll come to that. Before that, the diagnostic test, the choice depends on what you really want to look at, and usually the quantitative tests do better because there you know the number of copies and the viral load. Because just having a positive CM report, as we discussed before, doesn't mean that the patient has infections. There has to be a significant value. Usually, if you are measuring it in international unit, it should be more than 2,000 to 4,000, or if you are measuring in copies, then it should be around 700 to 800 copies or more, or 1,000. So you have more number of copies with clinical symptoms, then you can say that the patient has an infection. The other thing is the test and the assay that you are using, that has to be persistent and constant. So it should not happen that one time you send a patient to Metropolis, a sample to Metropolis, the other time you send it to Suburban or some different lab, because every lab would use a different assay. So if you are monitoring or diagnosing, you have to have the same lab, right, and the same technique. Ideally, you need to look at the rate of the increase, So if you have 100 copies, the next sample shows 200, that means the infection is coming and a single test may not be diagnostic. Some tips for diagnostic tests: individual with suspected CMV tissue invasive disease should also, I'm going to just read all those things, should also have plasma or whole blood testing, since PCR results are often available prior to the biopsy result. So biopsy is not adequate, you need to have a PCR test because it diagnosed it early and you can start the therapy early. You can't wait for the biopsy report. And it is important to establish the baseline viral load, because then you can see two things, whether your treatment is failing or your treatment is active. Because every week if you are going to monitor the viral load, if your treatment is active, then the viral load should come down. A negative test does not exclude tissue invasive CMV disease, as we said, and vice versa is also true. The absence of CME inclusion or histopathologically, if there is no inclusion bodies or CME, that also doesn't exclude a diagnosis. It can be a sampling error, right? And you may not get a positive result on the patient. In some patients, it may not be possible to obtain a tissue biopsy. When in this case, viral load testing and culture assays, as we said, are very important. The diagnostic test is histopathology, showing presence of inclusion bodies. They are typically basophilic intranuclear inclusions, although eosinophilic cytoplasmic inclusion is also known, but basically they are basophilic intracellular inclusions, right? Detection of CN inclusions, lung biopsy or in blood. So any tissue or fluid, if you diagnose them, that is the diagnostic things. What about the treatment? That is divided into asymptomatic and symptomatic patients. In asymptomatic, if there is a viremia and detection, the first thing is to either reduce the immunosuppressants or stop the immunosuppressants if the viral load is too high. And then continuously monitor for symptoms. Many times immunocompromised patients may not develop symptoms and you would just be monitoring the viral loads and viral copies. If the viral load is increasing in subsequent cultures or subsequent PCR based tests or quantitative tests, then you need to treat the patient. Otherwise, you can just observe the patient and look at the viral loads. Some centers believe in giving preemptive therapies, especially in solid organ transplant like bone marrow transplant, where immunosuppressants are too high. While in patients with liver transplant, immunosuppressants are not very highly used. They require less immunosuppression. So probably there you can wait. Also the donor status and recipient status of seropositivity matters. In symptomatic disease, stop the antimodalities. So thymocyte globulin and the antimodalities like azathioprine and mycophenolate, if you are using, they pose the patient for having increased risk of developing a CMV infection. Right, so these are the immunosuppressants who would cause the patient to have CMV infection more. Right, so these has to be stopped or decreased or switched over to other immunosuppressants. Antiviral therapy, depending on whether there are clinical manifestations or an invasive disease. The choice of therapy is intravenous ganciclovir and the dose is around 5 mg per kg every 12 hours, which needs to be adjusted for kidney function. So apart from ganciclovir, which is usually 5 mg per kg BID, the induction dose is for 21 days and then the maintenance dose. How long you continue the maintenance dose? Till there are, so every weekly you need to, weekly or 15 days you need to monitor the viral load. And the viral load either has to become non-detectable. So CMV either has to become non-detectable or it has, the number of copy has to be really, really low. That is less than 100 or 50. When probably you can think about stopping the treatment. But even if that doesn't happen, or if the CMV virus becomes negative at first week or second week, you still need to continue the treatment for 3 weeks at least. So minimum 3 to 4 weeks and maximum till whatever time the virus becomes undetectable or less detected. Or if the symptoms go down and still the virus is detected, you still need to continue the treatment. The other options for these are, if there is, for sick patients, definitely IV ganciclovir. Valganciclovir, it's an analog of ganciclovir which is orally available. The problem with both diseases is myelosuppression. Like CMV disease itself can cause bone marrow suppression. You have leukopenia, thrombocytopenia, anemia with this. And the drugs also can cause leukopenia and thrombocytopenia. So it becomes very difficult when you are monitoring the treatment, what is causing what. Whether it is because of the disease or it is because of your treatment. Right? And you can't stop the treatment. Then the other options are, if this is not working, then foscargonate and cidofovir, but these are not very safe drugs and they should be reserved only for resistant disease. How do you monitor the response to the treatment? I think we have already discussed this. You need to monitor the viral loads, assess, and therefore be monitoring using the same assay. As I said, you should not be doing the same assays. Then values you need to look at and so on. And as I said, you need to do the viral testing every weekly. Let's skip that. Then if there is no response to the treatment, then there are something called as resistant testing. So how do you do a resistance testing? You can particularly look at one gene which usually confers resistance to this ganciclovir and other treatment from the CMV antigen. Yeah? So that can be done. Usually the markers suggestive of CMV resistance are a rising viral load, a rebounding viral load, means initially you see a response, the viral load comes down, then again it increases. And then persistently elevated viral load in setting of, in spite of viral therapy, antiviral therapy. The treatment of these drug resistant CMVs, the first thing that you can try is look at the decrease the immunosuppression or stop the immunosuppression completely. Second is you can increase the dose of ganciclovir, but the patient has to really tolerate it. So you can go up to 75 mg per kg to up to 10 mg per kg. as per the patient tolerance. The other choice which are not probably available in our setup is Mirabegir. In US they are available. Mirabegir, Foscarnet and Citalopram with all its side effects that you can have. The other thing is you can probably use the, though it has been, these are all off-label indications, and the studies have not found that it is really useful, but in some patients it has been shown to be useful, is the CMV specific immunoglobulins, and we have given these to both of our patients. Or if you don't have these cytomegalovirus immunoglobulin available, then you can probably also use upon a routine immunoglobulins, IVIG, right, simultaneously with antivirals. But the important thing is you have to use them simultaneously. Number one, you have to use them in the early course of the disease. If you give immunoglobulins at the end of 15 days of your disease, they are not going to help. Or at the end of 4 weeks, 3 weeks, they are not going to help. So they should be in the initial phase of the disease. Again, I think we talked about that. Treatment options. So if we have time, actually I have finished my talk there, but if we have time, I can just read up all these recommendations for the summary of recommendations for prevention of CMV infection in post-transplant patients. Already 3-4 slides or 5 slides.
Yes, sir. Yes, sir. We have 1 minute left.
So preventing CMV, I'm just going to read those because I have just copy-pasted it for all of you. Preventing CMV infection and disease, determining CMV recipient. All organ donors and recipients should be screened for CMV immunoglobulin, IgG. Sero status prior to or at the time of transplantation. If donor CMV is unknown and recipient is seronegative or unknown for CMV, this should be characterized as donor seropositive recipient, seronegative for CMV. Then CMV prophylaxis, how do you decide? For adults and children and young people receiving a solid organ transplant, post-transplant patients, offer ganciclovir prophylaxis to people receiving kidney and liver transplant. For kidney and liver transplant, 3 months. Post-transplant, 3 months. If either, कौन से patient को, which patients we are supposed to do it? If the recipient is seronegative for CMV and receives an allograft from a CMV seropositive donor. So donor positive, recipient negative, 3 months of valganciclovir for liver and kidney, liver, sorry, the recipient and the recipient allograft from a seropositive donor positive, then 3 months of this. Patients who have received ATG, antithymocyte globulin, here also you are supposed to give 3 months of antiviral valganciclovir, right? Then consider valganciclovir prophylaxis for people receiving heart, lung, intestine and pancreas transplant for 3 months. Again, here in which condition the recipient is seronegative for CMV and receives a allograft from CMV seropositive. So donor positive, recipient negative, 3 months again in this patient. Or the patient has received, recipient has received antithymocyte globulin. Again here also you are supposed to give, or the recipient is positive. Or if the donor and recipient both are positive, right? Now do not routinely offer valganciclovir when donor and recipients are seronegative. If both are seronegative in pre-transplant checkup, then valganciclovir is not required. You just need to monitor for them for symptoms or development of symptoms, and then do a viral load testing, quantitative test, PCR test, and then decide whether you really need to give them. Be aware that some recipients who are seronegative for CMV may require valganciclovir prophylaxis for prevention of other herpes. So it may not be required for CMV, but it might be required for herpes simplex or herpes zoster infection. Consider valganciclovir prophylaxis for at least 3 months after starting treatment for acute allograft rejection if either or recipient are CMV positive. If you develop an acute rejection, then definitely you have to give. Adjust the dose of ganciclovir if creatinine clearance is less than 60. So you need to adjust the dose of ganciclovir as well as valganciclovir if the creatinine clearance is less, right? And it really need to be adjusted because they are very, if they accumulate, they are very toxic. For children and young people under 18 years, adjust the dose of ganciclovir according to body surface area up to a maximum dose of 900 once daily. Monitor fluid blood count at least 2 weeks based on whilst on. So because it causes bone marrow suppression and pancytopenia can happen. So you need to monitor CBC at least every 2 weeks, ideally every weekly. Consider switching to CME monitoring and preemptive therapy if people develop side effects. So neutropenia or alternative therapy you will have to do. Laboratory testing, clinical laboratory should be used quantitative nuclear Quinat test for whole blood or plasma. If you use a whole blood, it would detect more number of copies because it also detects the CMEs in the blood cells, right? So the plasma would detect only plasma. So usually it is double. No? Transplant center should adopt a consistent approach to use either whole blood or plasma. So if you are monitoring plasma, then monitor plasma only. Otherwise you will be misled. If you are using blood, then use only blood, right? To quantify. CME Q-nat should be calibrated using the WHO, so you have to have a reference. CME viral load should be reported as international units per hour wherever possible, as I said, or if reported as copies per ml. When more times we get that report as copies per ml, it has to be converted with a factor into international unit per ml. Transplant center should determine local threshold of viral load that portend CME infection or disease requiring treatment depending on the CME NAT. So you need to decide your own standards where you want to treat or where you don't want to treat. Q-nat threshold should not be used in isolation, and there has to be some clinical syndromes, yeah, to actually say that this is disease and this needs to be treated. Monitoring of CME infection and disease. Offer monitoring of CME viral to guide preemptive therapy for children and young adults if they are CME seropositive and they have not received T lymphocyte depletion therapy and they are not receiving Vulgan seropositive. So
sorry to interrupt you, sir. The time is up.
Okay. So we'll stop there. Anyway, that is the summary of all this. Yeah. Thank you.
Thank you, sir, so much for shedding the light on a lesser known topic of CMV. Now I would like to invite Dr. Amit.
Put them into light or I have put you all in dark?
Now I would like to invite Dr. Amit Saraf, sir, to kindly felicitate Dr. Ravindra Gawar, sir, with a token of our appreciation.
गाइडलाइंस पे गाइडलाइंस एवरीडे न्यू गाइडलाइंस आते रहते हैं. कौन से न्यू है कौन से पुराने समझ ही नहीं आता.
बाकी गाइडलाइंस को पता नहीं, बट आई कैन हेल्प यू विद द क्लेप्सी गाइडलाइंस ऑफ 2023. सो लेट्स अस इनवाइट डॉक्टर जवल भट्ट सर, कंसल्टेंट फिजिशियन ऑफ डिपार्टमेंट ऑफ इंटरनल मेडिसिन, जुपिटर हॉस्पिटल थाने. ओवर टू यू सर.
Hello, good afternoon. So we have discussed a lot of different topics today: TB, fungus, different viruses like CMV. So I am going to talk on a very simple topic, which is one of the very important and significant nosocomial infection, which is central and related bloodstream infection. So we'll first start with the cases first. So this is a 64-year-old female presented with a complaint of sudden onset severe headache followed by unconsciousness, and CT brain was suggestive of subarachnoid hemorrhage due to the right MCA aneurysm. So this patient was of course eventually admitted into ICU, and central lines, atre lines was inserted and decided for the DSA. Coiling was done, and then again patient was again shifted back to ICU. After extensive prolonged stay of approx 10 days, patient started having fever spikes. So we were wondering what could be the cause here. So we sent cultures which turned up to be Klebsiella pneumonia, and these are the reports. So blood culture showing Klebsiella pneumonia, and just susceptible to amikacin, gentamicin, ciprofloxacin, tigecycline. So this scenarios we commonly see in ICU setup. Patient is admitted with certain different conditions, very sick patient like patient having sepsis, pancreatitis. All the patients are admitted, we put central lines when there is very strict indication, but later on, after a few days or a week, patients start having fever spikes. So let's see another one case. This is a 75-year-old female patient, known case of diabetes with history of chronic pancreatitis and CKD. Was brought to casualty in a gasping state with significant hypotension. ABG was suggestive of very severe metabolic acidosis. Patient was admitted in ICU. Again, invasive lines were required for hemodynamic monitoring. Few days later, patient started having fever spikes and culture was showing Atre-Singh faecium. So this is something very commonly seen nowadays. Either it is gram positive, gram negative, even fungi, or something like atypical bacteria like Mycobacterium fortuitum. So this patient, this Atre-Singh was just susceptible to linezolid, teicoplanin, and vancomycin. So what is this central line related infection? So basically, central line associated bloodstream infection is a laboratory confirmed bloodstream infection and not related to infection at any other site. Of all healthcare associated infections, CLABSIs are associated with the very high cost burden and accounting approximately $46,000. So this is of course a USA data. So this is very costly infection to have, CLABSI, because it increases patient stay in ICU, patient stay overall in hospital, and it costs a lot of money. We have to treat with vigorous antibiotics as well. So most cases are preventable with proper aseptic techniques, surveillance, and management strategies. So that's why it is very important to discuss about this topic. So now there is always this confusion. When do we call it CLABSI? When do we call it CRBSI? So both are similar looking term. So let's see one by one. So CRBSI is called catheter-related bloodstream infection, which is very rigorous clinical definition, which is defined by precise laboratory findings, whereas CLABSI is a term used only for surveillance purposes. So we'll see one by one. So what is CRBSI? So one of the following 4 criteria, if patient is falling in one of the 4 criteria, then we call it CRBSI. So a positive semi-quantitative culture of a catheter tip, so which is a 5 centimeter. If we do the culture and if we find more than 15 colony forming units in a catheter segment, then we call it CRBSI. Or it could be simultaneous quantitative blood cultures with a 5:1 CFU ratio in central line versus peripheral line. So you send a culture with peripheral line and central line simultaneously. And at the same time, you see that in central line blood, the blood which was sent from central line has grown infection, and the CFU ratio is more than 5:1, then it could be CRBSI. Now, differential period of CVC culture versus peripheral culture positivity more than 2 hours. So this is one of the very, very important criteria nowadays we use. So we are sending the cultures, and both will grow the same organism. But in central line, it will grow earlier, more than 2 hours earlier, then we can call it a central line related infection. Or a quantitative more than 10:2 CFU per catheter segment cultures where the same organism is isolated from the catheter segment and peripheral blood. So these are the 4 main criteria to call it CRBSI. So either of them is a CRBSI. Now the next is CLABSI. So what is CLABSI? So it's a primary bloodstream infection in a patient that had a central line within 48 hours period before the development of BSI. So no apparent infection at another site. So it's a basically surveillance. So this guideline, this definition is mainly for the surveillance purpose. And so the culture of the catheter tip is not a criteria for CLABSI. So that is for the CRBSI, not for the CLABSI. So mainly it is a surveillance guideline. Now let's see the pathophysiology. So basically, there are, when we put a central line, so some of the catheter tip is going inside the vein, of course. Some of the part is remaining in the skin, under the skin in subcutaneous tissue, and this part is above the skin. So the first is skin organisms like skin flora, because of the healthcare worker hands, contaminated disinfectant. So all this can lead to the infection of the skin. So we can get a skin organism which can touch here and it can travel and cause the clepsy. Now contaminated catheter hub, if you see the catheter hub, again skin flora, hands of the healthcare worker, and contaminated infusate. So when we infuse from here, so contaminated infusate like fluid, medications, or if there is some problem from the manufacturer, this can also contaminate this. And at last, there is hematogenous spread from any other site of this, which can infect the central line and cause clepsy. Now looking at this study, it's a Moser study done by ISCCM, which shows that the organisms you can see here, the top 5 organisms for the clepsies are Klebsiella, Pseudomonas, Acinetobacter, E. coli, and Candida. Among this, you can see here the hospital mortality is the highest for Pseudomonas. And so ICU mortality highest for Pseudomonas. So all these organisms are very common. What are the risk factors? Which are the risk factors? So in ICU population, frequent insurgents, we have to infuse a lot of medications, we have to access repeatedly, and of course it is inevitable that patient may require these lines for extended time period. But it is very important to remember that most clepsies occur not in the ICU, but it occurs outside the ICU. So non-ICU population is at more risk for developing of clepsy. Patients on HD catheter, intraoperative oncology patients, or patient having PICC line. So all these are the risk factor for clepsy. What are the other risk factors? Prolonged hospital stay before catheterization. So patient is hospitalized for 1 month and then already there is some colonies are formed on the skin, and then you insert a catheter, patient is prone for the clepsy. Prolonged duration of the catheter, and very commonly we usually put multi-lumen catheters. So 3 lumen is very commonly we put, and that is another risk factor. So whenever possible, use 2 lumen or even a single lumen catheter whenever possible. So concurrent catheters, patients are having arterial lines, HD catheter, central lines altogether. Neutropenic patients, obese patient, BMI more than 40, and reduced nurse to patient ratio, parental nutrition, and excessive manipulations. So these are the risk factors for clepsy. So now the question is how to prevent clepsy. So there is a strategy developed from Society for Healthcare Epidemiology of America in association with IDSA, EPIC, and American Hospital Association. So they have made guidelines in 2014. And now again in 2022, they have updated the guidelines. So we are going to look at those guidelines. So first, how to prevent? We can even prevent before putting a line. So how to do that? So provide easy access to the evidence-based list of the indications. So very strict indications, for example, patient is having hypotension requiring BP support with noradrenaline. Patient is having very severe hypotension requiring multiple lines, unable to get access. So there has to be some evidence-based indications for the central line to use to minimal unnecessary central line placements. Now education and competency assessment of healthcare professional involving in the insertion, care and maintenance of a central line about clepsy prevention. And bathe ICU patients more than 2 months of age with the chlorhexidine preparation on a daily basis. So these are some of the prevention strategies. So with this bathing of chlorhexidine, we can remove the skin contaminants at least. So now, what about prevention at insertion site? So in ICU and even in non-ICU setting, a facility should have a process such as checklist. So in foreign countries, they use this checklist system where some nurse is just observing and putting all the checklist to ensure the adherence of the infection prevention practices at the time of CVC insertion. So observation of CVC insertion by a trained nurse and physician. So if a junior is putting a line, so some senior can just observe how they are doing it. Perform hand hygiene, which is the cornerstone of the prevention. So perform hand hygiene prior to catheter insertion or even manipulation. This is very important. Not only while putting line, even if you are manipulating the line, you should do a hand hygiene. So use alcohol-based waterless products or soap and water. Now, there is always this debate which is the best line. So in these guidelines, they have changed the subclavian site is preferred to reduce the infectious complication when the catheter is placed in the ICU setting. So in ICU setting, it's very high quality of evidence that subclavian line, if you are putting, it will be great because it will reduce the infectious complications. Now use an all-inclusive catheter kit or cart. Preferred use of sonography guided line placements, and so mainly it should be used in IJV and femoral site, which reduces the non-infectious complications like puncturing an artery or doing a large hematoma. So you can reduce that non-infectious complications, so better to put lines with the sonography guided. Now use maximum sterile barrier precautions during line insertion. Preferred is use full body drape for the patients, mask, cap, gown, and gloves for all healthcare professionals involved during the line insertion. Even for exchanging a catheter over a guide wire, if the line has exhausted, for example, 10 days, and if you're suspecting if there is some issue and you want to change the catheter, if there is some clotting, so you should, even when you are changing, you should wear all cap, gown, mask, everything. Use an alcoholic chlorhexidine antiseptic, at least 2% chlorhexidine gluconate for a skin preparation, and let it dry for a few seconds. So this is a prevention which should be so at insertion site. Now what after you have inserted a central line? So ensure appropriate nurse to patient ratio and limit the use of floating nurse in ICUs. So that is one of the very important thing, high quality evidence. Use a chlorhexidine containing dressings for a central line in patients over 2 months of age. So I'm just going to show you how it looks like. So this is a chlorhexidine dressing, which is transparent dressing, which you can use here, Tegaderm chlorhexidine dressing. So for non-tunneled central lines in adults and children, change the transparent dressing. So this transparent dressings and perform the side care with a chlorhexidine based antiseptic at least every 7 days or immediately if the dressing is soiled or loose or damp. So this is very important. At least every 7 days you should change the transparent dressing. If it is not transparent, then gauze dressing should be changed every 2nd day. So in 2 days or earlier, of course, if it is soiled or loose. Now, so we have seen this. Now, what else can we do? Disinfect catheter hubs. This is very, very important, which often people miss. So I'll just show you how do we have to do this. So this is a cartoon which shows first we have to do hand hygiene, then 15 seconds of hub scrub. So basically, you have to scrub the hub for 15 seconds with alcohol swipe, and then let it dry for 15 seconds and maintain a non-touch technique. So such kind of posters also you can put in your hospital or even in wards and ICU. So scrub the hub, easy to remember. So this is very important. Now coming back to other things, so yeah, disinfect the hubs, needleless connectors and injection ports before assessing the catheter. And so how to scrub it with alcoholic chlorhexidine for 5 seconds. So the guideline says for 5 seconds, but ideally if you are doing for 15 seconds, it would be better. So now remove, the most important part is remove non-essential catheters, and you need to do this assessment on a daily basis. Like do my patient need a central line today? If no, just remove it. Now, routine replacement of administration set is not used for blood products or lipid formulations, can be performed at interval of up to 7 days. So this administration sets can be changed after 7 days. Now, perform surveillance. So this is another very important aspect that when we have central lines, we should do audits, we should do surveillance and assessment of our own in our own hospital setup and see if we are compliant with the guidelines. So we have seen this. Now, another additional prevention strategies is use antiseptic or antimicrobial impregnated central lines. So antiseptic chlorhexidine, antiseptic chlorhexidine silver sulfadiazine, or antibiotic impregnated central lines with minocycline and rifampicin can be used. Hospitals with very high CLABSI rates should opt for this antiseptic or antimicrobial impregnated lines. Now, use of antimicrobial lock therapy for long-term catheters. Central line should be used. So here what we do, supratherapeutic concentration of antibiotic in catheter lumen we put, and patient with long-term HD catheters, patient at risk for severe sequelae of CLABSI should be, we should do this lock therapy. So lock therapy can be done with vancomycin and ceftazidime. You can combine it with heparin and you can infuse it in the central line. So this is how we can do lock therapy: 1 ml of vancomycin, 0.5 ml of ceftazidime. So this is another. This is one of the examples. There are many other antibiotics which you can use for antimicrobial lock therapy. Now, using a recombinant tissue plasminogen activating factor (RTPA) once a week after hemodialysis in patients undergoing hemodialysis through a central line, through a HD catheter. So in these patients, so we can use this RTPA once a weekly. This is one of the strategies. Now, utilize infusions or vascular access teams. So in certain countries, they are using this vascular access teams. So apart from these teams, nobody is going to touch the lines. So they have specialized teams which they found that if you are using such kind of teams, that will reduce CLABSI rates. Using antimicrobial ointments for hemodialysis catheter insertion sites, just at the insertion site, you can use antimicrobial ointment. So you can use Neosporin, you can use povidone iodine to the catheter insertion site, but you should avoid mupirocin because it increases the resistance and it prevents, it causes catheter damage, basically, this mupirocin. So use an antiseptic containing a hub or connector cap. So this is another strategy like antiseptic impregnated lines. We can also use hubs which are medicated. So these are some of the strategies which how we can prevent the CLABSI. Now what we need to avoid. So use of antimicrobial prophylaxis. Many a times maybe still in some of the hospitals this practice is going on to use antimicrobial prophylaxis for short term. So that practice should be avoided. So and routine replacement. So routine replacement of the central line or art line should not be done. So there is 7 days, now we have to change the line. No, if the line is not needed, you should not again put it. So just to simplify what we have seen, we can use the central line bundles. It's nothing but what we have learned: hand hygiene, barrier precautions, skin antisepsis, cannulation, and remove the catheter when it is not needed. Now coming to the treatment part. So when CLABSI is suspected, empirical therapy should be started based on the most likely organism, host factors, and the overall clinical picture. You should also take into consideration your hospital's local antibiogram also. So while awaiting cultures, empirical antibiotics should institute promptly with coverage of gram-positive, negative, as per your institution antibiogram. If MRSA is prevalent, then you should use vancomycin. But if the vancomycin MIC is more than 2 or it is VRE, then of course the drug of choice is daptomycin. So this is for the gram-positive. Now coming about the gram-negative coverage, it depends on the risk of Pseudomonas. For example, if patient is having neutropenia, severe illness or prior colonization with Pseudomonas. So in that case, you have to use Pseudomonas anti-pseudomonal antibiotics like piperacillin, tazobactam. But if the risk is low, then you can use a simpler antibiotic like ceftriaxone. In patients with resistant organism, if there is history of this resistant organism, then you can use cefepime and carbapenem. So all this is when you are waiting for the culture reports. So now what about the antifungal? When do we use antifungal? So we have talked about gram positive, gram negative. What about antifungals? So this should be considered in patients with femoral catheter lines, patients on TPN, total parenteral nutrition, those who are having prolonged administration of broad spectrum antibiotics, and hematological malignancies, lymphoma, leukemia, or solid organ or bone marrow transplant. So all these patients, all this set of patients, we should use empirical antifungal when we are waiting for the culture reports. Now, in these patients, echinocandins are preferred for suspected candidemia if azole resistance is suspected. So when do you suspect azole resistance? When there is Candida glabrata or Candida krusei. So once culture report is available, then of course you have to de-escalate to a specific and appropriate treatment. If you get fungal, you give only fungal. If you get positive, negative. So according to that, you have to de-escalate. So this is very important. If there is no growth, then you reassess the need of antibiotics. Then you have to think, you have to find other causes of fever, and you reassess the need of antibiotics here. But in a septic patient or in a case of unexplained fever without culture positivity, so patient is persistently having fever spike, patient is very septic, requiring very high inotropic supports. In that case, you need to remove a catheter and send the tape for the culture. So all non-tunnel catheters causing CLABSI should be removed promptly. So if you are suspecting strongly that it's only CLABSI, then should be removed promptly. But again, you have to reassess the need. If you are unable to remove because of certain reasons, then you have to continue antibiotics. Sometimes even before the proven with above criteria and clinical suspicion. So basically, if your suspicion is very high, if patient is very sick and you're suspecting it's only line related, then even before the cultures, you can remove the lines. Now, the question is when to preserve then, when to preserve non-tunnel catheters. So they have mentioned here that you need to all catheters should be removed. So when to preserve it? So only for long-term catheters, salvage can be attempted in a limited instances such as, so uncomplicated CLABSI which is caused by organisms other than Staph aureus, Pseudomonas, Bacillus, Micrococcus, Propionibacterium, fungi, and mycobacteria. So other bacteria, any other bacteria apart from all this, if it is there and if the CLABSI is uncomplicated, we can continue, we can salvage the line and we can continue antibiotics. The patients with limited vascular access, again, like I told you, if it is not possible to remove lines, it's a very precious line. In that case, you can continue the non-tunnel catheter like central line, which you put IJV, and you continue antibiotics. What about HD catheters? So if culture is negative, you stop antibiotics. If culture is positive, continue antibiotics. But for example, perm cath, long-term HD catheter is not that simple. So when do we remove the catheter? This is very, very important question because usually these catheters are very precious. So when do we remove? If the persistent symptoms more than 36 hours or a severe sepsis patient, hemodynamic unstable patient in shock, and metastatic infection. So patient is having infection everywhere. In this case, you remove this HD catheters. If the blood culture shows remain positive 72 hours after, even with the appropriate antibiotic therapy, then also you should remove the catheter. It's difficult to clear organisms. For example, these organisms, Staph aureus, Pseudomonas, and fungi. Different speakers have spoken about this, that they form biofilms. So they are difficult to clear, and that's why in that case also you should remove the catheters. Now, recurrence of uncomplicated CLABSI. So initially patient had uncomplicated CLABSI, you have treated, but again it is recurrence of the same. When salvage is difficult, then you should remove. Now, when you are removing the catheter, place a new catheter only after the cultures are negative. And if catheter is retained, then surveillance culture after 1 week should, after 1 week after the completion of antibiotics should be again done. Now, what is the duration for patients with uncomplicated CRBSI, that is no endocarditis or metastatic infection? In absence of the risk factor for hematogenous spread and negative blood cultures 72 hours, the following approach for the intravenous antibiotic should be used. So, for example, in Staph aureus, there is no other hematogenous spread and the cultures are negative 72 hours after. Then in Staph aureus, you continue antibiotics for 14 days in absence of endocarditis. If it is cons, coagulus negative staphylococci, then you can use antibiotic only for 7 days. Enterococci and gram-negative bacilli, you need to use 10 to 14 days. In case of Candida, it is for 14 days in absence of the retinitis. So this is the duration of the antibiotics. So now coming to the last slide, what is the take-home message here? So CLABSI is one of the very common and very costly nosocomial infection. Hence, its prevention should be the priority in every ICU and even in outside the ICU setting. Maximal sterile barrier, skin antisepsis, hand hygiene, and aseptic technique is the cornerstone of the preventing CLABSI. Assess daily need of line and remove promptly whenever it's not needed. Send central and tip culture only if the CLABSI is suspected. CRBSI is diagnosed if same organism grows from CVC and peripheral with earlier growth by 2 hours in a central in a catheter tip. Use empirical antifungal in a subset of the patients and remove long-term HD catheters if it grows Pseudomonas and Candida. Thank you.
Thank you so much, sir, for that amazing talk.
यार अभिषेक, अभी तक के सारे टॉक्स के बाद तुझे क्या लगता है फाइनल वर्ड्स किसके होने चाहिए?
I think so. Final word भी intensivist का ही होना चाहिए यहाँ पे. So we call upon stage Dr. Sanjay Walke sir, consultant and intensivist at Jupiter Hospital Thane, to deliver his talk on infections in NTR patients.
Let us hear applause for sir. Over to you, sir.
Good afternoon, everybody. First, I would like to thank Dr. Dhanashri madam and Dr. Amit Saraf for giving me opportunity to speak on this forum. Also, Jai Guru, Abhishek and Mahesh for such warm welcome. I will rapidly finish my talk so that rest of the audience can go and enjoy their Sunday. I'm going to speak on infection in post-transplant recipient. As we all know, there are increasing number of transplant patients, and we also see better outcome and with improved surgical techniques, with improved immunosuppression. So as the immunosuppressions are improved and they are at the same time the graft survival has also improved. So this type of better improved suppression makes a transplant recipient more prone for infection as well as at the risk of malignancy. So here comes the role of multidisciplinary team approach, where an transplant physician, intensivist, and ID specialist come together to manage such challenging patients in ICU. Now, what are the general principles? It's very important, such patients, we should diagnose them early and aggressively manage them in early stage only. Otherwise, the outcome will be very devastating. We know these patients are at diverse etiological risk. They can present with bacterial to virus to fungal infection. Again, the pulmonary complications can land them in crisis. They are at the same time, they are at risk for rapidly progressive pneumonia with PCP, no cardiosis, cryptococcus. Again, we know such patients are at impaired inflammatory response. again the classic signs and symptoms of infection are impaired, diminishing. Classic sign of fever will not be there. Again, we have to base more on the molecular, serological and radiological finding. Again, fever will be lacking in such patients. Fever will not mount, and even if fever is present, they may be of non-infectious etiology. They may be related to allograft dysfunction or graft dysfunctions. They can land up in advanced critical condition, and on presentation only the condition may be very serious. Again, at the same time, being a post-operative patient, again examining them, physical findings find out will be challenging in such patients. So we have to most of the time rely on imaging basis, CT finding, MRI finding, and mostly on tissue biopsy with histopathology and microbiology. So here comes a transplant physician should be very receptive, vigilant in managing such patient. At the same time, we know when such patients land up in shock, so they are on wide spectrum antibiotic. So these are at risk of complex, and the therapy may be complex or inadequate with use of urgency use in the therapy. At the same time, these are at the risk of drug toxicity as well as drug interaction with the immunosuppression agent. As well as we know the more the broad spectrum antibiotic we use, they have the more antibiotic resistance pattern, and at the same time these patients are immunocompromised host patient. So at the same time, whenever we see a source, the source control is very important. Drainage of any collection or debridement of any tissues are very important in such patient. At the same time, the patient, those are on immunotherapy, drug level may not reflect everything. Those patient drug toxicity will not depend on what symptom they are. The patient will have low level, but at the same time the patient is in toxicity. So this is also a challenging part to manage. Again, more or less they are immunosuppressed patient. At the same time, some of the symptoms of immunosuppression also mimic like infection. So our focus should be central. Our focus should be on disease prevention as well as target drug, appropriate drug therapy, as well as on vaccination. So we have to be very strategical. We have to be strategic in finding out what are the risk factors in such patients. So what are the epidemiological? Epidemiological exposures are divided into 4 categories. One is donor-derived, second is recipient-derived, third is nosocomial, and fourth is community-acquired infection. These patients are at the risk of latent infection also, and most of the transplant patients are immunodeficient already. They may be neutropenic, which are already at risk of bacterial or fungal infection. At the same time, they have T-cell immune deficit, which makes them for viral or intracellular TB infection, and a strongyloid infection may come years after transplant. What is net state of immune? This is for identifying risk of patient who are at infection. So net state of immune suppression is a conceptual framework of all factors which are contributing for infectious risk. This may be type, dose, duration, temporal, sequence of immunosuppressive therapies, those patients who are on chemotherapy drug, those patients who are comorbid, those patients who have fluid collection, devitalized tissue, those patients on indwelling devices, and other host factors like immunodeficient patients who are already neutropenic, hypogamma-globulin patient, metabolic problems like protein calorie malnutrition, uremic or diabetic patient. Sometimes these patients are also having concomitant infection also. So this helps in risk stratifying a recipient patient for infection. So these are the immunosuppressive agents. Anti-lymphocyte globulin, these causes T-cell depleting antibodies which make them activation of latent virus infection. These patients can present with fever and cytokine release also. Those patients who are on steroid, they are at risk of bacterial PCP infection as well as activation of hepatitis C and hepatitis B. Patient on azathioprine can land up with neutropenia as well as they have possible role in human papillomavirus infection. Those who are on mTOR inhibitors are at risk of early bacterial infection, B-cell depression, as well as they have possible role in late onset cytomegalovirus. Those patients on cyclosporin and tacrolimus, they have increased viral replication. They may lead to B-cell depression, gingival infection, and intracellular pathogens. Those patients on sirolimus, excessive infection in combination with current agent can also present with idiosyncratic pulmonary syndrome, often landed with concomitant respiratory pathogen. Those patients who have underwent plasmapheresis, they are at risk for getting encapsulated bacterial infection. Post-emitter blocker, unknown so far, but can some patient present post-transplant lymphoproliferative disorder. Patient who receive rituximab has B-cell depletion, bacterial and at risk of bacterial and viral infection. So timeline is very important. We can predict this timeline of what time can infection occurs after transplant. So this development of infection can be delayed because of the, Dr. Ravi has already spoken about the prophylaxis, because of the infusion of prophylaxis. As well as we can also predict, as soon as we intensified the immunosuppression agent, the risk of infection will increase. Again, at the same time, those patients who land up with drug toxicity, where we reduce the level, again they will have a risk of activation of latent infections also. So risk stratification is very important in such patients. That's why thorough evaluation of donor for donor screening as well as recipient screening. At the same time, if we know the surgery is challenging or technical outcome of the surgery, if your surgery is challenging where we expect lots of blood loss, technicality difficult while anastomosis, so we are here to worry about the infection. At the same time, if we increase the immunosuppression agent for the graft position, again this is the time where we expect there will be patient will have the infection. Again, this is the timeline chart for solid organ. Less than 1 month, 1 month to 6 months, and more than 6 months. So for first 1 month post-transplant, they are at most risk for nosocomial infection derived from donor and recipient, as well as those patients who are facing technicality difficulty while operating. So most, and also patient who have received antibiotic before that, antimicrobial resistance like infections like MRSA, VRE, Candida species, non-albicans, line infection, Jawal has already spoken about it, wound infection, anastomosis leak, Clostridium difficile colitis. Donor-derived infections are HSV, rabies, West Nile, and recipient-derived infection are related to colonizations like Aspergillus and Pseudomonas. The infection which are common from 1 month to 6 period, where now your immunotherapy is intensified. But the patient who have received prophylaxis for PCP and antiviral, they will be at risk of BK polyomavirus, Clostridium difficile colitis, hepatitis C virus, adenovirus, influenza virus, Cryptococcus neoformis fungal infection, and Mycobacterium tuberculosis. At the same time, those patients who have not received, they will be at risk of PCP, herpes virus infection, hepatitis B, listeria, nocardiasis, toxoplasmia, protozoal infections also. And now those patients who have more than 6 months post-transplant, where their immunosuppression has been, patient is doing stable, now the immunosuppression has been reduced. At the same time, this patient will be at risk for community-acquired pneumonia, UTI. And the fungal infections like aspergillosis, atypical molds, mucous species, nocardiosis, and at the same time, because the prophylaxis has not been there, so at risk of late viral reactivation of CMV, HSV, and JCV polymovirus. So now there are two major causes for treatment for the first month transplant. So those patients who are having the pre-existing disease in donor itself and in the recipient. And at the same time, those patients who have infectious complication of transplant surgery and hospitalization. Again, because they are at the first month of the immunosuppression, the major side effect of immunization are not yet evident. But at the same time, those patients who are already on immunosuppression, like autoimmune hepatitis and immunodeficiency state, they will be at the same risk. Now, donor-derived infection. This can be latent or simply a bad timing. It can be unappreciated active infection at the time of retrieval. Again, the efficiency of transmission depends on enhanced immunosuppressed transplant receiver. But again, at the same time, we should know the classic signs of fever, leukocytomia, erythema. It will be lack in such patient, and there may be non-specific signs like altered mental status, elevation of blood liver function test, wound adhesion, unexplained hypotension. what are the bloodstream infection? Some donor have active infection at the time of procurement. So, like certain pathogens like Staphylococcus, Pneumococcus, Candida, Salmonella, E. coli, Klebsiella, and Acinetobacter. This may stick to the anastomotic and can have bloodstream infection in such patient. So it's very important. We should want a proof of adequate therapy of such infection must be established before accepting the organ. That's why here also, whenever there is a cadaver, we make sure we culture all patients and make sure these are patients on appropriate antibiotic therapy before donating organs. So these are donor-derived infections. These are virus, bacterial, fungal, and parasitic infections. Again, recurrent infections are common. Those recipient infection present prior to the transplantation. And some are common viral infections are hepatitis B, C, HSV, CMV, papillomavirus, BK polymovirus can re-emerge after transplantation. So that's why recipient evaluation is must in such patients. Recipient-derived tuberculosis, non-table mycoplasma, histoplasma may emerge months after transplant. And reactivation of strongyloid may also come after accompanied by gram-negative bacteria and sepsis, meningitis, and pneumonia. So it's important, goal should be the pre-transplant evaluation should be very cautious and it should identify such latent infection. And preventive strategy must be applicable. What are the nosocomial risk factors? Those patients who are already prolonged hospitalization, those patients who are on prolonged mechanical ventilation with poor lung compliance, patients with persistent ascites, stents in situ, again intravascular clots, those patients who required re-exploration, retransplantation, those patients with leaks, multiple fluid collections, multiple blood transfusions received during surgery, again those who are patients who are having prolonged indwelling catheter, patient with ischemic graft or Dilip. These all are the risk factor for developing nosocomial infection. What are the common nosocomial infections are gram-negative bacilli like Pseudomonas, Klebsiella, Acinetobacter, and multi-resistance organism. Gram-positive organisms like Enterococci, VRE, MRSA, also Legionella species. Common fungal infections are Aspergillus, non-albicans, or azole-resistant Candida. Clostridium difficile colitis also, and non-tuberculous mycobacteria from surgical site. It's very important. So we should maintain our quality of air, food, equipment, and potable water supply to the hospital or at the home. It should be contaminated free while managing such patient and to prevent cluster of infection. What are the infection from 1 to 6 month period? This is the period where there will be maximum immunosuppression effect. So these patients will be at risk of opportunistic infection. So here key role is for prophylaxis. Again, what are the common opportunistic infections are PCP, viral pathogens, and community acquired respiratory viruses. Also latent infection such as protozoal disease like strongyloid, Chagas disease, and less commonly leishmaniasis. Again, some endemic fungal zones have histoplasmosis, coccidioid, paracoccidioids, and tuberculosis and non-tuberculous mycobacteria also. Some patient may present with persistent diarrhea. There we have to suspect GI parasites like Cryptococcus and mycosporidiosis. And CMV, sir has already mentioned that. These are the common viral infection in solid organ transplant patients like herpes virus, donor-derived virus are West Nile, rabies, hepatitis B, C, papilloma virus, polyoma virus, BKC, respiratory viruses like adenovirus, RSV, influenza, para-influenza, parvovirus B90 and HIV. CMV infection and Epstein-Barr virus. Sir, as Dr. Ravi already mentioned detail about CMV virus, the greatest risk for invasive infection are seen in that recipient who are seronegative and received infected graft from seropositive donor. Sir has detailedly mentioned about this. And these patients should warrant anti-CMV prophylaxis as well as EBV monitoring in organ recipient. These are the direct and indirect effect of CMV virus in a recipient, transplant recipient. against viruses as co-pathogens. These may have direct effect, which include virus-specific clinical syndrome. CMV infection may present with fever, neutropenia, gastritis, esophagitis, choleritis. Respiratory viruses may present like pneumonitis. Hepatitis C, B patient will present like hepatitis. Varicella zoster will present like cholangitis. HSV will present like encephalitis. And specific graft-related injury in CMV, like they will present like pancreatitis, myocarditis, retinitis. Indirect effect is immunosuppression and predispose them to opportunistic infection, like aspergillus after CMV infection. CMV will accelerate HSV infection in patient with cirrhosis and with those patients who have graft loss. EVB may increase risk for post-transplant lymphoproliferative disorder. CMV reactivation may lead to graft rejection mediated by pro-inflammatory cytokines release and upregulation of histocompatible antigens. Oncogenesis is also very common. Many viruses predispose to the cancer state and cell proliferation. BK polymovirus has been associated with infection in the renal allograft patient. Patient will present like hemorrhagic cystitis, asymptomatic viremia, interstitial nephritic, urinary obstruction, patient with rising creatinine in renal transplant recipient. Adenoviruses will present like hemorrhagic cystitis, hepatitis also, and pneumonia, which can be diagnosed on basis of culture and anti-detection and molecular testing. HHV 6, 7, 8 also been identified in transplant recipient. Again, specific viral pathogens, Epstein-Barr virus, varicella, HSV, often activated during 1 to 6 month period. B cell will lead to B cell non-Hodgkin's lymphoma, particularly in seronegative recipient who receive from seropositive organ. Varicella zoster will lead to cholangitis. Papillomavirus had risk of anogenital and squamous cell cancer. Parvovirus B19, patient will present like anemia which are not responsive, unresponsive to erythropoietin, present like myocarditis, chronic allograft injury in a renal transplant recipient. Again, respiratory virus development, these are patient development of bacterial infection and graft rejection. Again, those patients who lined up more than 6 month to 12 month period, these patients are stable and there are a reduced level of immunosuppression. So these patients are at risk of getting community acquired pneumonia with respiratory virus like pneumococcus, legionella, and other patients. At the same time, because now they are not on chemoprophylaxis, they will have mount a late CMV response. Again, those patients who have received marginal graft, they require higher immunosuppression agent. So such patients warrant prolonged antimicrobial therapy. Again, at the same time, these patients will be at risk for PCP, Cryptococcus, nocardiosis, Listeria, monocyte. At the same time, fungal infections like risk of mold, nocardiosis species, and as well as they are at risk for post-transplant lymphoproliferative disorder. Tuberculosis and histoplasmosis. These are latent infection, including tuberculosis and histoplasmosis, may activate many years after transplantation. Again, treating such patients is challenging. It's very difficult. Such patients, those who are on immunosuppression, because of the risk of interaction of such drugs like rifampicin and isosiadine with immunosuppression agent. So what are the key points? The key points are such patients, it's very difficult. You will not get classic signs and symptoms of infection. So you have to more rely on your radiological microbiological picture. Key is early identifying such patients at risk. Again, timeline, we can predict what are the patterns of infection in such patient depending on their presentation. Again, early specific microbiological diagnosis is very important in treating such patient with appropriate antibiotic therapy. Again, those patients who are refractory, those patients who have refractory fever, cytopenia, and clinical deterioration in spite of all therapy, so there should be an alternate diagnosis of TTP, GVHD, or HLH. At the same time, those patients who are on prophylaxis, it will eliminate risk of PCP, at the same time prevents patient from toxoplasma and reduce UTI, Listeria, and nocardiasis infection. those patients who are on anti-CMV prophylaxis will prevent them from CMV infection and other viral infection. So it's very important that the approach to such patients should be multidisciplinary. It's all the efforts of all team makers, transplant physician, intensivist, hepatologist, everybody should come in front and manage such complication challenging patient. Thank you.
Thank you so much, sir, for the amazing talk. Now I would like to invite Dr. Yogita Pendurkar, ma'am, to kindly felicitate Dr. Sanjay Walke, sir, with token of her appreciation. Thanks for this.
Javal Bhatt, sir. And I would request Wagre, sir, to felicitate Dr. Javal Bhatt, please. please come on the stage. Please come.
Dr. Bhatt, please. You didn't mention that you are supposed to be felicitated.
Thank you, sir. Thank you so much. I think my job here is a very small, little, but a very important job as a vote of thanks. So I think I'll keep on giving the reasons for a round of applause. The first reason being the audience who waited till the very end. A big round of applause to everybody sitting till the very end. Of course, I know MMC certificates and tea is one of the reasons, two of the reasons rather. But still, I think the program can count as reason number 3. Thank you so much for that. Thank you, sir. I think second, my residents. Please give them a big round of applause. They anchored the event. They were here till late night. They were here early morning. They saw to it that the lights were on, the AC was on, the toilets were opened up, the screen was set up, the speakers, the testing of it all. So all that, hello, 1, 2, mic check, 1, 2, mic check was done by them. So big round of applause, I think, to Abhishek, Mahesh, Sufyan, Ajay, Aditya, Bittu. Those 2 gentlemen and lady over there have been the anchors last year. So they handheld these 2 to anchor this event. Thank you so much, Aditya, Bittu, and thank you both these gentlemen for today's anchoring. I think also a big round of applause for the hotel management. You know, they are the workers behind the scene to ensure that the moment you clear the breakfast, the lunch is placed, to ensure the moment the lunch is cleared, the tea is placed in, to ensure fresh water bottles, everything is, spick and span, so we can keep on moving ahead with the academics. So these are small, tiny cogs, but which keep the giant wheel of academics rotating. So I think a big congratulations and applause to the hotel management. AV people, I think we are heard and sound and I think can be seen only because of the AV support, and I think I thank them as well for a big contribution to this entire event. Thank you so much. And I think lastly, to all of us, my department, the entire team medicine for putting together a show, we would welcome a feedback because this is an annual event for us. We've been doing it for the last 4 to 5 years. We continue to do it in the beginning of the year, every year, and year after year. So if there are any particular themes, suggestion, topics, some way to do it forward, we welcome them all the time. So a big round of applause to my team. Thank you so much for everything. Thank you. Thank you so much. Photographer. Team, AV team, but yes, I agree, sir. Photographer, your name, please.